Hello, good morning, doctor. Welcome back to the Game Changer session by Dr. 𝗧𝗵𝗶𝘀. Today, we'll see most important subjects. Why? Because these are subjects which looks very small, but they play a major role in your examination. Because in these subjects, you need to read just few topics, but if you read those few topics only, you will get questions from it for sure. Okay, so we read less but we score more. That is the main agenda of today's session. Fine. If we missed other sessions, that I'll be forgiving you. But if you miss this session till the end, then it will be your game changer. So don't miss it. So change your game in a right manner. Okay, that is the thing, and that is the motto we today will be carrying. Yeah. First of all, good morning, guys. Good morning, Dr. Pooja. Good morning, Dr. Harikrishnan. Yeah. Good morning, Dr. Odysseus. Good morning, Dr. Anna. Good morning, Dr. Teja. Good morning, Dr. Parul, Dr. Aishi, Dr. Baba, Ansha. Welcome you back, guys. I guess yesterday few of you were bit busy as it was Sunday. Yeah. Good morning, Dr. Ramesh. Yeah. Good morning, Anurag, sir. Yeah, like Arun Kumar. Yeah. If you did some revisions before, and if you do one more revision along with your previous notes and this revision notes, it is more than enough. Fine, it will more than enough, and after in further revisions you keep on adding stuff either to your main notes or to this notes and revise those notes for at least two times, and give 1 or 2 GTs and do solve PYQs. You will be able to crack the examination. Yeah, good morning, Dr. Larry. Good morning, Dr. Ashish. Yeah, medicine. Till what time class? Like it will be today. We'll finish much earlier. Okay. Like as of now, we'll have till 12. Till 12, we'll have a break. Okay, we'll have a chai break. And maybe it will go around, I guess 4. The maximum is 4. Okay, this is like my perception. Okay, if you got interested, we'll move into. Yeah. Yeah, Amrita, I already answered it. Yeah, it is curated for FMGE. It is not enough. It is curated for FMGE. Okay. Like don't worry about the biochemistry, just I have put up these things, just read them in biochemistry part and take any rapid revisions, the rapid revisions in the Dr. 𝗵𝗵𝗀𝗀 channel. It will be taken by Dr. Priyan Jain sir. You just take it out, it will be more than enough for you. Don't worry. Good morning, Dr. Anum. Yeah. Don't worry about the physiology also. The physiology as well, you can just go through my notes and also do watch Dr. 𝗧𝗵𝗶𝘀 sir's session in Dr. 𝗵𝗵𝗀𝗀𝗀 sir's channel. Fine. Yeah, good morning, Dr. Nandini. Yeah, fine. Without wasting time, we'll move ahead with this hard subjects, but it is high yielding because from pediatrics there will be 15 to 18 number of questions, and it can go with integration with pathology, pharmacology, and biochemistry with around 20 questions even in some days. Fine. Yeah. Yeah. Yeah, do it. Do the rest sessions like once it's done. Yeah, don't worry about that. Yeah. 𝗓𝗵𝗀𝗀𝗀𝗃. Okay. Yeah. Okay, guys. It's good to go. We'll go ahead with this pediatrics part. First, you need to know about this neonatal resuscitation. Okay. About this neonatal resuscitations, you should know. Like mostly when you will start. Second. Okay, just a second, guys. Yeah, live. Okay, fine. Yeah, I guess we are live back again. Are you able to see me, and are you able to see the video and audio? Is it all fine? Yeah, thank you, Dr. Anna. Yeah. Yeah, okay. Fine, yeah. Thank you, Dr. Mohammed. Fine, good. Okay, fine. We'll move ahead with this pediatrics part, and this pediatrics part, as I told you, there will be the minimum number of questions. It will be 15 to 18, and it can even go up to 20 if it is integrated with pathology, pharmacology, and your biochemistry part. Fine. First, we'll start with this resuscitation part. If you see about this resuscitation part, you need to know this resuscitation. Mainly here they will ask you about this two things. One is when you will start this compression and when you will do this ventilative correction steps and when you will do this intubation. Okay, for that you need to know like how we progress. For example, when a baby is delivered, either mostly in both in a case of vaginal delivery and also in a case of cesarean section. Usually these vaginal delivery babies, they will be more vigorous in nature, means they will cry by of their own, whereas we need less stimulation in such cases. Whereas mostly in a case of cesarean section, we need to do stimulation, and after once you just get back, well, then the baby will start crying. Okay, this is the usual scenario. And in this cases, first we'll start with this first thing. First, what we will do? First, we will set up a team in a case of usual things. We'll receive the baby and we'll check whether that baby is a term baby or the baby's tone is good and the baby is crying. Okay, if all these criteria meet, okay, fine, then everything is fine. Then put him in the warmer, because the baby will be warm inside his mother's uterus, whereas when it come inside, it feels that baby is hypothermic, means the environment is very much cold. So to prevent this hypothermia, what we'll keep them under this radiant warmer. First we'll keep them under the radiant warmer, fine. Then we'll position the airway and we'll clear off any of these fluids inside. Okay, and you should know the sequence of suctioning. The sequence of suctioning is, it is what? It is the mouth followed by the nose. It is the mouth followed by nose suctioning. Okay, once you check it, then you just warm the baby with what? With this radiant warmer. Then you just clean the baby and you just clean for any secretions. Then you stimulate the baby. How will you stimulate? You just rub its palms or rub its back, then the baby will start crying. Okay, this is the usual and normal scenario. Once the baby starts crying, you just check for any gross anomalies, then you just move ahead with this pediatric part. Fine, this is this usual things. But if all of these things is not there, okay, yeah, fine, yeah, okay guys, yeah, if you see this, all of these points is not there. For example, if the baby, once you stimulate also, the baby is not crying. Okay, in such cases what you will do, you will check for the next thing, which is whether the baby is having apnea or the baby is gasping. Okay, baby is having apnea or baby is gasping. Then you will check for this heart rate of the baby. Usually it should be more than 100. Then you will consider, yeah, if it is more than 100, fine, then no problem. Okay, but if it is less than 100, okay, it is normal one. But if it is less than 100, then what you will do, you will just go for this positive pressure ventilation. So usually we'll be having this small amber bag which will be having the capacity of 250. Then you will start with this positive pressure ventilation. Then you will go for this, I'll attach the monitor for SpO2, whether the SpO2 is maintaining or not. Then you can even consider about the ECG part. Then you just do it for 15 seconds. Once you give oxygen and positive pressure ventilations, you just give for the 15 seconds, and after that you check again. You check for this heart rate again. If the heart rate is still less than 100, then you should do for this ventilation correction steps. For this ventilation correction steps you should do. For example, you need to check how you are holding the baby, whether you are holding, means while ventilating the child, the mouth is open or not. You can use the C and E techniques to open its mouth, and once ventilating, you should see whether the baby's chest is rising or not. Means then only it is an adequate and proper ventilation. If not, you are just ventilating to the outside, it won't reach the baby. So first you will do, if again the heart rate is less than 100, first you will do, it is what it is, this ventilation correction steps. You will check for this ventilation correction test. You will check for this movements. So once you check all these things, then you can try for ETT. Okay, you can try for ETT at this moment, but it is not definitive one. You just do for this ventilation correction steps. Once if ventilation correction steps you did, like, yeah, you opened the mouth adequately, you made this extension and you just made this see like whether there is a proper rising of chest, so everything is well, then you check for the heart rate again. If it is more than 60, you proceed ahead, then you will go for this routine usual management. If it is not, okay, we'll guide you the rest about it. Fine, yeah Pooja, yeah fine, yeah. Then if you see, if the heart rate is still 60, okay, if the heart rate is still 60 or if it is less than 60, then you need to go for the next step. Then it is the definitive management of ARV, which is this ED2. See, remember, first you need to give, it is this endotracheal intubation. First you need to do intubation, then you go for this chest compression. Okay, without intubating it, you cannot go for the chest compression. Remember, fine. First what you will do, you will You will intubate if it is not done previously. Then once you intubate with this, then you will provide this 100% ppv. So once you intubate this, then you will check for the compressions. You will check for the compressions and you will start compressions. Once you will start compressions, usually you will start these compressions after less than 60. Okay, if it is less than 100, you can consider for ET intubation, whereas if it is less than 60 only, you will start for compressions. Once you will start for this compression, then what will happen is that the heart rate will start improving. The heart rate will start improving. So they will ask you, what is the, how you will see, or how you will say that ventilation or this resuscitation you are doing is working for the baby. So it will tell like the ventilation or this resuscitation you are doing, it will be working once the heart rate is improving. So here the main parameter you will check for this resuscitation, it is what? It is this heart rate. It is the heart rate. Okay, heart rate. Then what means, then if then after this intubation, after you are doing this compression, means I will tell you about this compressions in much in depth. Okay, and after this also, if this baby is still, if the baby is still having the heart rate of less than 60, then you should consider the other points. Like for example, you can give this adrenaline, which is this epinephrine, you can give. Okay, you can give, and you should rule out for this other conditions as well. So means first you will provide warmth to the baby. Okay, then you will provide this routine care, then you will check for the heart rate. If the heart rate is less than 100, then you will go ahead and you will do this ventilation correction steps, and before the means like after giving this oxygen. So once you will give this positive pressure ventilation, if the baby heart rate is still remain less than 100, then you will go for this ventilation correction steps, and after this ventilation correction steps also, if it is less, then you will go for this positive pressure ventilation like ET tube. Then if it is heart rate is less than 60, then you will go for this compressions. Then you will go for these compressions. But remember, before going for this compression, make sure you did endotracheal intubation. Okay, this is the thing. And for compressions in the infant, see, we are this big, but if you see this child, it will be very small. So for child, we can use different methods. For example, you hold this back of this child like this, and what you can do, you can put this thumb in the center. You can put this thumb in the center, and you can give compression. You can give compression. So this will give you the enough support. If not, you can use this 2 finger and you can do compression, but this is that it won't give much support to you. Whereas this is known as thumb encircling technique, it will give more support than this 2 fingers technique, Okay, this is how we'll do. Fine, this is the mota you need to know. So first, as I told you, warm, dry and stimulate. Yeah, compression site, like it will be like around this 𝗧𝗵𝗶𝗀𝗀, you just go little bit above around this 𝗧𝗵𝗶𝗀𝗀, especially on this left side, you will compress, you will do compress. Or else if you are doing the thumb encircling techniques, it will be around the point of the same, it will come around here. Okay, that is the point. Yeah, fine. Then as I told you, if the heart rate you will check, means then after, means first you will check for this breathing, then you will check for the heart rate, and after that you will do this ventilation correction steps. You will adjust the mask, you will reposition the airway, you will suction. First you will suction the mouth, followed by this followed by the nose, then you will go for this positive pressure ventilation, or followed by this endotracheal intubation. Once if the heart rate is still less than 60, yeah, if the heart rate is still less than 60, we will go for this compression. Okay, and the compression ratio is 1:3. Okay, it is 1:3. See, you are talking about adults. Like, see, first when we are talking, you just imagine, just initially just try to understand the concept and be roam around to this respiration part of neonates. Once we are done, we can have a multiple things, because while solving a question, you should have multiple axes, but you should know for what the reason you are solving. For example, if the child is given for neonatal resuscitation, they are not even talking about adult resuscitation, means you will get confused. Okay, so don't make things which is confusing you. So just see what is necessary points, see, understand the question, then see the options, like what they are going to ask. For example, they described about resuscitation, and they can ask you about the mask, they can ask you about the ET tube. Then if you still, means it is going to good like that, it is better to go like this, because you will be having less confusions and you will be saving your huge time. Okay, so if you see, good guys, for adults it is 30:2. Fine. Whereas if you see about this infants, it is the 1:3 ratio. 1:3 ratio. So just remember these things, and as I told you, this is how we'll keep this mask, and we'll use 2 techniques. One is known as C techniques, another one is known as E technique. Remember, okay? And this is how this thumb encircling techniques, by which we'll do compression. Okay, we'll do compression. Just remember, and make sure you stop your compressions once the heart rate is returned to this more than 60. Okay, more than 60, then you can do reassessment about what is the reason for it, and still you should supply what oxygen. And once if the heart rate is more than 100, means there is a, you check for the necessity of this positive pressure ventilation. If there is no necessity, you can remove, or you can you can remove this endotracheal tubes. Okay, this is the main thing. Yeah, it was this. Yeah, it was asked in July. Yeah, and they will ask you like in a case of child, they ask you like if it is present in one risk giver, two risk giver. Okay, in a case of one, then we'll go for this usual. If it is two, is there only in children, it is not in adults, only in children, then we'll go for this 15. Okay, so don't get confused, guys. 15:2. Okay, don't get confused. Okay, that's what. Whereas here it is 1:3. Okay, 1:3. One breath and three compressions. One breath and three compressions. Okay, one breath and three compression. That is for neonatal resuscitation. Whereas in children it is 30:2, and if it is one rescuer, and if it is two rescuer, it is 15:2. Okay, we'll see them also in anesthesia part. Don't worry. Fine. And this is the motto of this neonatal resuscitation part. Then next. Means, and they also ask you this about this epinephrine. You need to give usually by, if you have this IV access, if it is newborn, you will be having this umbilical venous catheter. Then you can add this, or you can give this drug from there also itself. If nothing helps, then you can go for endotracheal route as well. Okay, all of these things. Okay, for IV, as I told you, right, 1:10,000. Fine, just go through this pharma parts. It is 1:10,000. Okay, whereas in the case of, we studied in anaphylactic shock, the dosage in the case of anaphylactic shock will give in IM. In such cases, will give in the less, in the more dosage, like 1:1000. Okay, yeah, good, Dr. G says. Yeah, you are in correct track. Fine. Next, we'll move on to this transient conditions. They will tell you that there is a 3 and 4 days old child, or 3 to 4 days old newborn, and is presenting with this red erythematous rash on trunk. Okay, on trunk. Okay, what you will think, what is the name of this rash? It is what it is, this erythema toxicum. This is the erythema toxicum. See, these are the transient conditions. Means if you do anything or if you don't do anything, these things will resolve by its own. So they are known as transient conditions. They will resolve by its own. Fine. So this is what, this is this erythema toxicum. And next, if you see, there is what, this is the sweat glands. If there is any blockage in the sweat glands, yeah, if there is any, yeah, reassured, yeah, good Dr. Anna, good Dr. Ansh. Okay, then if you see the next one, it is this milia. So milia, it is what, it is the blockage of the sweat glands. So if you see about this glands, there might be different blockage. So, okay, if it is kind of just liquid collection, it is just milia. If it is red colored one, it is known as milia rubra. So okay, so if you are able to see these small collections due to the blockage, this sweat glands, yeah, good Dr. Pooja, yeah, it is what, it is this milia. Next, if you are able to see this kind of changes, okay, this kind of changes over this forehead region, okay, over this forehead region. So then it is what, then it is the stroke bite. Then it is what, then it is stroke bite. Don't confuse it with this Portman stain. Okay, and next, if you are able to see, if there is increased maternal hormones, then it leads to this acneiform eruptions. It leads to this acne kind of eruptions. It is known as acne neonatorum. Yeah, good. It is known as acne neonatorum. It is due to the increased levels of maternal androgens. Due to increased maternal androgen. Okay. Next, if you are able to see this type of large pustules, okay, large pustules in the infant. If pustules present, it is known as pustular melanosis. And if you are able to see only half side of the body, is getting discolorized. Okay, if the half side of the body is getting discolorized, then we'll call them as what? We'll call them as harlequin discoloration. Fine. And next, if you are able to see this type of bluish discoloration on back, it is known as Mongolian spot. If there is bluish discoloration on the back, it is known as Mongolian spot. Fine. And next, if you are able to see here, it is because of this maternal androgen, the same maternal androgens. Yeah, good Dr. Pooja, good Dr. Mohammed. Fine. If there is this type of thing where there is this breast enlargement, in this neonates, it is known as mastitis neonatum. It is also due to this increased maternal androgens. Okay, remember. Okay, maternal hormones especially. Right? Yeah. Next, if you're able to see this type of changes, like kind of marbling kind of changes due to the exposure to cold. As I told you, this baby inside the uterus, it will be having a normal warm temperature, whereas when it comes out, it will be exposed to this cold. So because of this exposure to cold, if there is skin changes like this, it is what it is this? It is the 𝗃𝗃𝗬𝗏. It is the 𝗃𝗃𝗬𝗏. Fine. It is just remember, it is this hormonal changes. Okay, don't worry about this hormonal changes. Okay, because we know pregnancy means pregnancy. It is just a hormonal imbalance. Fine. Just remember. And next about this part, which is this most important one, it is the neonatal jaundice. If you see about this neonatal jaundice, mostly previously they used to ask about the levels. Now they start asking or stopped asking about this level. First, you need to know about this neonatal jaundice. It will always go from this cephalocaudal progression. Cephalocaudal progression. Fine. In the case of cephalocaudal progression, means it will start from the head and it will start involving this or go into the opposite direction. So in the case of seriously, if it is more than 12 or more than 12 milligram of bilirubin is there, then it will be staining the palm. So finally, see, if initially it will start from this phase under this cephalic phases, then finally it into the palms and soles. So the palms and soles will be affected last. Palms and soles will be affected last. At last. Fine. And if this jaundice, if it involves this basal ganglia, it will leads to this type of thing which is causing this baby to be having this spasms, which is known as 𝗃𝗃𝗀𝗃. Means if the jaundice involving this basal ganglia, it is known as 𝗃𝗃𝗃𝗃. Fine. And there are two types of jaundice. Usually they will give you this history and they will ask you which type of jaundice is this, or which of the following is not seen in this typical type of jaundice. If you saw an infant who is presenting with hyperbilirubinemia, which is happening mostly after 24 hours, and it spontaneously regress, or it will regress by its own within 1 to 2 weeks. Within 1 to 2 weeks, it is getting regressed by things. But you know these things. But the patients, the child's mother, father, they won't understand this. So what they will do? They will insist you to check their child. So once you check which type of which type of bilirubin will be increased in this case, is it conjugated bilirubin or unconjugated bilirubin, guys? Batao? Which type of bilirubin will be commonly increased in a case of physiological jaundice? It is what? It will be always unconjugated. It will be always unconjugated, because if you see during this fetal life, good Dr. Puneet, good Dr. Anna, good Dr. Medicine, good Dr. 𝗃𝗃𝗀𝗃𝗀𝗃, good Dr. 𝗚𝗔, fine, Nandini, and good Dr. Teja, good, fine. So if you see this unconjugated bilirubin, it means we usually know, like once the baby born, and this RBC will break down and it will convert from this hemoglobin, fetal hemoglobin, to an adult one. Okay, so during this breakdown, there will be increased level of unconjugated bilirubin will be there, and it should be converted into the conjugated one. But we know this uridyl glucuronidase transferase enzymes, they available in very limited quantity. So because of this very limited availability, this leads to this increase in this unconjugated bilirubinemia. This is usually what? This is usually physiological in nature, and we know it is water insoluble. That's why it is manifesting into the skin as yellowish. Fine. This is the physiological jaundice. So it will appear after 24 hours, and it will be always unconjugated in nature. So as it is unconjugated, it won't go into the urine, means it won't be water soluble. So the child won't be having any urinary features. There will be no urinary features. Okay, and followed by this, if you see, it will resolve within 1 to 2 weeks. Fine. This is the physiological jaundice. अगर आप pathological jaundice के बारे में बात करोगे, then if you see about this pathological jaundice, this can be either unconjugated hyperbilirubinemia or conjugated. Unconjugated क्यों sir? Because in such cases, for example, there will be some neonatal conditions, like for example, yesterday we studied, right? Crigler-Najjar syndrome, okay, then Gilbert syndrome. They can be causing this unconjugated one. Or if there is any cases of erythroblastosis fetalis, okay, where there is increased RBC lysis. Okay, so in such cases there will be unconjugated bilirubin will be increased. So increased RBC lysis like erythroblastosis fetalis, or if there is any enzyme defect. Okay, enzyme defect. Okay, fine. This is the usual things. Whereas in a case of conjugated hyperbilirubinemia, it will be increased. In a case of biliary atresia, it can be increased, or in a case of our favorite DR syndromes, like two syndromes, which is this DR, Dubin-Johnson and Rota syndrome, and biliary atresia. Okay, biliary atresia, there is this what the bile is found, but it is not unable to come into the duodenum part. That is the biliary atresia part. So okay, fine. So usually this pathological jaundice, it can be both unconjugated and conjugated in nature, and it will be it can appear within 24 hours. Can appear, okay, it can appear within 24 hours, and it will persist for a longer period of 2 to 3 weeks. It can persist for this longer period of 2 to 3 weeks. बस आपको ये सारी चीज याद रखना, फिजियोलॉजिकल को पैथोलॉजिकल्स के हम केस से डिफरेंशिएट करेंगे. ओके, recently, as I told you, right, recently they won't ask you about this calculation, mainly about this conceptual and theory part they will ask you, fine. And for such cases, okay, we'll convert this unconjugated bilirubin into this conjugated bilirubin by this phototherapy, and within this phototherapy will convert this unconjugated bilirubin to a compound which is known as 𝗵𝗵𝗶𝘀 by this mechanism known as structural isomerization. Okay, then how will you tell? Because means there is a scale we use which is known as Cramer scale, and we use this transcutaneous bilirubinometry. We can use this blood also, but for easy assessment we will use this transcutaneous bilirubinometry. So this is the instrument which is known as transcutaneous bilirubinometry, fine. And next, in severe cases, we know if it is we'll have this criteria. If it is more than 15 within this specific time, then we should go for this exchange transfusion. Exchange transfusion will do. See, that's correct. Dr. Puneet, if you see, during this phototherapy will cover this eyes and along their genital regions, okay, eyes and genital regions for prevention, okay, for prevention of this discoloration and things, fine. And usually the wavelength we use, it is 450 to 470 nanometer, and I told you the mechanism is what? It is the structural isomerization, converting this unconjugated bilirubin to 𝗵𝗵𝗶𝘀, which is water soluble in nature, and it can be excreted, water soluble. Okay, इतना याद रखो. Then what are the side effects? क्या हो सकता है? One, the baby may become bronze. It is known as bronze baby syndrome. So we are exposing to this light, so there might be dehydration, watery diarrhea, and hypocalcemia, and sometimes gonadal and retinal toxicity. So इसी वजह से we cover the eyes and this gonads. So eyes and gonads बहुत important है, तो इसीलिए we'll cover this eyes and gonads. Remember. Then we discussed yesterday as well. Like if you see this conjugated bilirubinemia, okay, I told you it is DRC. Okay, doctors are always conjugated. Okay, doctors are always conjugated. So Dubin-Johnson syndrome and Rotor syndrome, these are these two conjugated hyperbilirubinemias. And if there is any biliary tract obstruction or biliary tract disease or what, or this biliary atresia, fine. And this unconjugated, it is usually physiological in nature, and it can be due to this increased RBC lysis. As I told you, what it is because of this erythroblastosis fragilis, or it is because of this Gilbert syndrome and Crigler-Najjar syndrome. Okay, Gilbert syndrome and Crigler-Najjar syndrome. Okay, इतना याद रखो. So this is the thing you should know in the case of hyperbilirubinemia. ठीक है, jaundice के बारे में आपको इतना at least तो पता होनी चाहिए. Fine. And there is one more jaundice which you know is breastfeeding jaundice. Okay, and remember this breastfeeding jaundice, it occurs due to this decreased breastfeeding. Okay, breastfeeding jaundice may they will tell you will decrease the breastfeeding. Is it true statement or not? No, we won't decrease the episodes. We will actually increase the episodes of breastfeeding. बस थोड़ा आप याद रखना. Okay, means conjugate or unconjugate में क्या समझ में नहीं आ रहा? Please brief it. Fine. Then about this respiratory, फिर आगे बढ़ते हैं. Few neonatal conditions. One of them is what? One of them is this respiratory distress syndrome. If you see about this respiratory distress syndrome, it is most commonly seen in a case of preterm baby. We will call them preterm baby if it is less than, if it is preterm baby, it is less than 37 weeks, we will call them as preterm. Okay, and if it is very much preterm, like less than 34 weeks, then the lung is not yet matured completely. If there is no proper lung maturement, फिर क्या होगा? Then the baby will start having the respiratory distress. So usually they will tell there is a 33 weeks old baby or 33 weeks gestational age baby has been delivered, and now he is presenting with features of respiratory distress after 3 hours of its birth. And what will be your initial stage of management, or what will be your diagnosis? The X-ray of the baby has been done here. So what you will think? What is the disease? Is this? Dr. Puneet. good doctor. And Punit, yeah, good. It is what it is. This white out lung, also known as ground glass opacities, which we are able to see here, and this is classical feature of this respiratory distress syndrome, also known as this हाइलाइन मेम्ब्रेन डिसीज, also known as this हाइलाइन मेम्ब्रेन डिसीज. इसको प्रिवेंट करने के लिए हम माँ को देंगे, क्या देंगे, हम माँ को स्टीरॉइड्स देंगे. विल गिव स्टीरॉइड्स टू द मदर टू प्रिवेंट दिस रेस्पिरेटरी डिस्ट्रेस. व्हेयरएज इफ द बेबी विल बी डिलीवर्ड, फिर तब हम क्या करेंगे, वी नीड टू गिव सर्फेक्टेंट, क्योंकि हमें पता है इट इज ड्यू टू द डिफेक्ट इन दिस maturation of the surfactant which is produced by this type 2 pneumocytes. तो हम इनको पॉजिटिव प्रेशर वेंटिलेशन देंगे और बाद में सर्फेक्टेंट भी देंगे. ठीक है, फर्स्ट विल स्टार्ट विद दिस CPAP which is the positive pressure ventilation and followed by this surfactant replacement therapy and shifting them into this mechanical ventilation with ET tube. Okay, so this is the usual scenario. So there is a child who is having this premature birth, and along with this there is a respiratory distress within or less than 6 hours of birth. Then we'll consider of as respiratory distress syndrome. Fine. And now you saw a child, you saw a newborn which is having the features of tachypnea, and asking history, the mother tells, means are the family members tells, they delivered the baby with cesarean section. Yeah, with C-section. Okay, we know when there is a normal vaginal delivery, the baby need to be compressed while coming out. So the baby will get compressed while coming out. लेकिन in the case of cesarean section हम तो आराम से बेबी को उतार लेंगे. So because of this, there will be fluid collection inside the lungs, lead to this kind of feature which is known as what, transient tachypnea of newborn. So if you see this transient tachypnea of newborns, इसमें भी हम बिल्कुल कुछ नहीं करेंगे, इसमें भी will give this conservative management with either oxygen support or just will monitor the baby. So it is known as transient tachypnea of newborn. Okay, yeah, good Dr. Punit, good Dr. Henry Hamath, yeah, good. So it is what it is, this transient tachypnea of newborns. So here you will be able to see there is this presence of fluids. Here you will be able to see this presence of fluids in this interlobar fissures, and this sometimes this can be associated with this pleural effusion. As I told you, pleural effusion में हमें क्या देखेगा, there will be blunting of this costophrenic angle, का blunting देखेगा. और in the case of Klebsiella pneumonia, see what is the in the case of Klebsiella pneumonia, what is the X-ray sign you will see? Yeah guys, can you please answer in the chat section? कल हम पढ़े थे. Yesterday we studied what is the sign you will see in the case of Klebsiella pneumonia. In the case of Klebsiella pneumonia, remember, it is also causing these changes in the fissure. Okay, like see in the case of here in transient tachypnea newborn, you will be able to see there is this fissure will be having the fluids that is known as fluid in the interlobar fissure. Whereas in the case of Klebsiella pneumonia, there will be typical X-ray sign, there will be a red currant jelly sputum, and there will be a typical X-ray sign where if you see, then you will tell, yeah, it is the disease which is being caused by this Klebsiella pneumonia. Okay, so it is what it is known as bulging fissure sign. It is known as bulging fissure sign. It is known as bulging fissure sign, which is seen in a case of Klebsiella pneumonia. Okay, on X-ray, yeah. Good, yeah, good Dr. Punit, yeah, good Dr. Anar, yeah, good, nice. Fine. Next, you saw this baby who is presenting with the features of, now the baby is delivered at 42 weeks. At 42 weeks the baby is delivered. Now the baby is having the features of respiratory distress. Okay, respiratory distress. So in the case of more than our postpartum babies, if you are able to see, in the case of postpartum babies, they are more prone to, the postpartum babies, they are more prone to what? They are more prone to this type of aspiration, which is known as meconium aspiration syndrome. And in the case of meconium aspiration syndrome, you will be able to see this type of opacities. This type of opacities you will be able to see, and there will be what? There will be chemical pneumonitis. So remember अगर वो बहुत मतलब if it is preterm baby and respiratory distress, आपको पहले सोचना है it is the respiratory distress syndrome. If it is postterm baby and presenting with respiratory distress, then you will think of meconium aspiration syndrome. Yeah, good Dr. Medicine, good Dr. Anar. Yeah, super, fine. And then we'll move on to the next part. If you see, there is a child who is presenting with these features of bowel loop, this type of bowel loop present in the thoracic cavity, and along with this, like usually it will be the baby will be having the features of respiratory distress, and there will be this scooped out abdomen or scaphoid abdomen. scaphoid abdomen. Okay, scaphoid abdomen. And on X-ray, you will be able to see the presence of this bubble loops into this thoracic cavity. And in the case of this, which of the following is contraindicated? ET intubation or bag and mask ventilation? ET intubation or bag and mask ventilation? Yeah, good Dr. Shanvas, good Dr. Hemant, yeah, good Dr. Ansh, yeah, Anar, good Dr. Aishi. Okay, about Puneet, Dr. Puneet, I will tell you just a second, okay. It is left side, yeah, remember, yeah. Which of the following is contraindicated? Yeah, good Dr. Anar, quinine, Mohammed Ansh. It is what? It is this bag and mask ventilation. Bag and mask ventilation is contraindicated. Bag and mask ventilation is contraindicated. Ventilation is contraindicated in the case of congenital diaphragmatic hernia. So in the case of congenital diaphragmatic hernia, the bag and mask ventilation is contraindicated. So we'll do ET intubation, ET tube. Okay. So remember, this is this type of congenital hernia, which is most commonly occurring at this left side. So remember, it is the right, this is the left. So this is the left side. So this is the left sided pleuroperitoneal defect. Pleuroperitoneal defect. And this will be manifesting as this type of congenital diaphragmatic hernia, which is known as 𝗏𝗏𝗃 hernia, which is known as 𝗏𝗏𝗃 hernia. Badia. Yeah, good Dr. Puneet. Yeah, good Dr. Shanvas Khan, good Dr. Nandini, good Dr. Medicine, good Dr. Quinine. Okay, fine. Whereas in right side, it is less common. Whereas right side, if you see, are behind the sternum, if you are able to see, this is known as 𝗏𝗏𝗃 hernia, which is occurring on the right side. Whereas तुम्हें उसका याद रखने की जरूरत नहीं है. You should know this one, then you can rule out them. Right? For example, this is this 𝗏𝗏𝗃 hernia, which is occurring on the left side, where you will be able to see this bubble loops on the left side. Okay, bubble loops on the left side. ठीक है, इतने याद रखो. Fine. And next, you will be able to see there is a child. It is not infant. Now there is a child who is presenting with features of tachypnea and cough. Okay, and here you will be able to see there is this perihilar consolidations. Along with this hyperinflation, means you will be able to see more ribs than the usual. So if there is any peribronchial consolidations along with this hyperinflations, this is the typical for this bronchiolitis. Okay, this is for this typical for this bronchiolitis. Okay, can anyone tell me what is the most common causative agent for this bronchiolitis? Yeah, guys, what is the causative agent for this bronchiolitis? It is what it is, this respiratory syncytial virus. It is the respiratory syncytial virus. Yeah, respiratory syncytial virus, which is causing this bronchiolitis. Okay, mostly we'll give this supportive care. Okay, supportive care. And for prevention, what we'll do? For prevention, what we'll do? We'll give a drug which is known as 𝗵𝗲𝗻𝗔. Okay, fine. 𝗵𝗲𝗻𝗔. Yeah, sure. For 19 subjects, you can make this as your revision notes in your final part of time. And for short subjects, if you didn't touch, you can use this. Okay, there will be very minimal notes, and make sure you are attending it, because if you see, notes is everywhere. You can download notes, you can see notes, you can use books, notes is everywhere. But thing is that understanding and how the questions are approached to the questions. If you know these things, then only you will be able to do. That's why I will ask you to attend the session, because I am giving the PDF because it will give you orientation what we're going to discuss. But if you don't know the connecting the dots, it will remain as dots. And in exam, you should connect one dot between one dot. Fine. And these short subjects, they are very much high scoring. Once you do this, you do 2 revisions of this, 2 to 3 revisions of these short subjects, just few more PDF writes, few more pages. If you do this, then mostly you will get all your questions correct. Okay, don't worry. Welcome. Yeah. Then what is the most common cause of, if you see the most common cause of, yesterday also we discussed the most common cause of pneumonia, it is this Streptococcus pneumonia. Whereas second most common of this bacterial type, it is what it is, this 𝗵𝗵𝗃 influenzae. And viral pneumonia and bronchiolitis, it will be caused by this respiratory syncytial virus. Okay, whereas in neonates, it is group B Streptococcus more common than E. coli. Group B Streptococcus than the E. coli part. Fine. Whereas we know in the case of HIV patient, it is what it is, Pneumocystis jirovecii. And which of the following organism will cause pneumatocyl formation? Bacteria. Okay, here bacteria. Pneumatocyl formations we saw in medicine part. Which of the organism will cause? Yeah, good Dr. 𝗏𝗃𝗁𝗏, it is what it is, this Staph aureus. It is the Staph aureus. Okay, and in a case of pneumonia, radiologically we will be able to see this air bronchogram. Air bronchogram. See, this is the normal lungs. We'll be able to see here. In a case of pneumonia, everywhere there will be, means, see, imagine this white as this fluids collection, or this because of inflammatory fluids. Whereas here you will be able to see proper airways, which is known as air bronchogram. Okay, air bronchogram. Yeah. Now, 𝗲𝗃 I told you it can cause small pneumonias, but it mostly in HIV patients. Whereas the Staph aureus, it is responsible for pneumonia by a bacteria and causing this pneumatosis and causing the pneumatosis. Yeah, good Dr. Henry, good Dr. 𝗏𝗏𝗀𝗀𝗀𝗀 Ritturaj Shanwas. Good. Fine. Then we'll move on to this congenital heart disease part. If you know about this congenital heart disease part, mostly they will try to ask you, either giving X-ray, they will ask you to diagnosis, or they will ask you, is this cyanotic heart disease or it is a non-cyanotic heart disease or acyanotic heart disease. बस आपको इतना differentiate करना. Remember about this cyanotic heart disease, आप कैसे differentiate करोगे? The most of the, remember, it is most of the cyanotic diseases, it will be having this name in their T in their name. Okay, so if you see first one, there will be two separations in this. One is this decreased blood flow, okay, decreased blood flow to the lungs, and one there will be increased blood flow to the lungs. For example, in the case of tetralogy of Fallot, first see this mnemonic, all of them T, tetralogy of Fallot, tricuspid atresia, okay, and here the pulmonary valve stenosis. Next, that is the transposition of great arteries and 𝗃𝗶𝗃, yeah. 𝗃𝗶𝗃, yeah, good. That is the T, which is this cyanotic heart disease. Good, guys. Then if you see in a case of tetralogy of Fallot, you understand the physiology. We know there will be pulmonary stenosis. Agar pulmonary stenosis hai, how the blood will go from the heart to the lungs. So there will be no or very less blood will be flowing to the lungs. So stenosis की वजह से, so there will be because of decreased pulmonary flow. फिर उसके बाद tricuspid atresia. Okay, tricuspid, from right atrium to the left atrium, we need to have this tricuspid valve. If there is no valve, then it will go by this shunting or by this ventricular septal defects only. So there will be, obviously there will be a less blood to there. Whereas increased blood flows in a case of transposition of great arteries. If the great arteries, what are the two great arteries? This pulmonary artery and this aorta. If instead of originating from this right ventricle, the pulmonary artery, if it is originating from this left ventricle, of this aorta, instead of originating from this left ventricle, it is originating from the right ventricle, means they are transpositioned. Instead of like this, they are transpositioned. It is known as transposition of aorta, and because of this, this pulmonary artery will be connected to the left ventricle. और हमें पता है, in a case of left ventricle, it will pump more blood than compared to this right ventricle. Okay, just remember this thing. Okay, next. Fine. This is transposition of great arteries. Then total anomalous pulmonary venous return means instead of usual return, what will happen is all of this blood, it will come and return to this unanimously to this atria. Okay, because of this, what will happen is the same circulation. Instead of going to the left atrium, it will come into the right atrium only. So same circulation under this pulmonary circulation will happen. So there will be a more blood flow. Okay, fine. Yeah, Bajrang, I will check for the PDF. I guess it is shared. If it is not shared, let me make sure that it will be shared during the break session. Fine, because so we have, that's I told you, we have the process, like we are in studio. From studio it should go for the processing, and from processing it will be shared to you. Okay, whereas this unnoted PDF, it is from my end, I will be directly sharing to the team. Fine. So there is some small processing is there, that's why it takes sometimes, so just bear with us, but we for sure will share you the PDF. Okay, don't worry about it. Fine. Yeah, right. This is the congenital heart disease which are cyanotic part, whereas acyanotic, all other than T ones, like for example our ventricular septal defect, our atrial septal defect, or atrioventricular septal defect, or this endocosion defects. Fine. Next, this patent ductus arteriosus. Fine. Can you tell me patent ductus arteriosus? In this ductus arteriosus, it is which arch of artery? Yeah, guys, it is what? It is this left sixth arch artery. Yeah, good Dr. Medicine. It is the left sixth arch artery. Good Dr. Quinine. Yeah, good. Yeah, good Dr. Atul. Yeah, good. Yeah, indomethacin हम देंगे. Good. Fine. Yeah, good Dr. Aishi. Good Dr. Shanwas. Good. Fine. Then obstructive lesions like aortic stenosis, pulmonary valve stenosis, and coarctation of aorta. Most of them, they are also acyanotic. And these are these X-ray findings they will give, and they will ask you. For example, if you are able to see this side of egg of string or egg on side appearance, It will be suggestive of transposition of geriatrics. It is suggestive of transposition of geriatrics. Yeah. In the case of patent ductus arteriosus, you will see this continuous machinery murmur. It will be mentioned. You will be able to see the continuous machinery murmur. What is the drug you will give? Ibuprofen more than the indomethacin. Okay. It is which arch artery? It is the left sixth arch artery. आपको बताना. Next, because of this total anomalous pulmonary venous return to this right atrium, it will be in this shape which is known as 8 or this snowman appearance. Okay. Snowman appearance are also known as figure of 8 appearance. Yeah, good Dr. 𝗚𝚲𝗃, good Dr. Ansh, good Dr. Pune. Fine. Next, if you are able to see, there is no segregation of this ventricles and everything. So here leading to this atrialization of this ventricle. Atrialization of this ventricle causing this box-shaped heart which is known as Epstein's anomaly. Atrialization. Okay, yeah. It is due to this lithium use. Yeah, it is one of the causes, this lithium use in pregnancy. It is the atrialization of ventricle. Atrialization ventricle. Fine. Yeah, good guys. Fine. Yeah, it is the box shaped heart. Next, we'll move on to the next part. If you're able to see this type of symmetry appearance, it is what it is. Instead of total, if it is just partial, it is known as partial anomalous pulmonary venous return. It is known as 𝗔𝗵𝗏. It is known as 𝗔𝗵𝗏. Okay. Next, if you're able to see this type of goose neck deformity, like this goose, there is this neck formation. It is known as what? It is seen in a case of endocardial quotient defect. And we know this endocardial quotient defect, it is most commonly seen or typically seen in a case of Down syndrome. Down syndrome. Okay. Okay, pata. Yeah, good. Fine. Next, if you're able to see, yeah, good Dr. Medicine Ansh, yeah, good Dr. Anna, good Dr. 𝗚𝚲𝗃, good. Fine. Yeah. Next, if you're able to see this formation of 3, okay, formation of 3 or this reverse 3 sign, it will be typically seen in a case of coarctation of aorta. And in the coarctation of aorta, you will be able to see there is this presence of this inferior rib notching. There will be presence of this inferior rib notching. There will be presence of this inferior rib notching as well. Fine. And next is the 𝗔𝗏𝗏. Okay, 𝗔𝗏𝗏 also known as core ends about, are also known as boot-shaped heart. Boot-shaped heart, it will be having this VSD, overriding of aorta, right ventricular hypertrophy, and along with this there is a pulmonary stenosis. Can anyone tell me what is the most important or which of the following feature in this 𝗔𝗏𝗏 will define the severity of this 𝗔𝗏𝗏? Yeah guys, which of the following will define the severity of this 𝗔𝗏𝗏? It is what? It is this pulmonary stenosis severity. Yeah, good Dr. Medicine. Okay, good. Yeah, good Dr. Quanin, Anna. Yeah, good, nice, Aishi. Yeah, I'm very happy. Yeah, good Dr. Shanwas Khan. Fine. Then we'll move on to this score which is known as Abgas score. In Abgas score, first A for appearance. Okay, the minimum score is 0. Okay, and the maximum score is 1, 2, 3, 4, 5. 5 into 2, it is what? It is 10. Fine. It's 10. Fine. Next, so appearance. If the appearance of the baby is just blue or completely cyanotic, then we'll give 0. Cyanotic. Then if the baby is having cyanosis over this limbs or the end of the limbs, we'll call them as acrocyanosis. So acrocyanosis will give 1 point. Okay, whereas in a case of just normally pink baby, if it is just this pink baby, then we'll give a score of 2. Fine. And in case of pulse, we'll see if there is no pulse. If it is, then we'll give 0. If it is less than 100, we'll give 1. If it is more than 100, we'll give 2. Fine. Next, about this grimacing. When you stimulate with this either with nasogastric tube, then if the baby is not responding, if you are stimulating with this nasogastric tube, usually the baby will cough or sneeze. Fine. So if the baby is not responding, it is 0. If the baby is making some odd facial expressions, it is known as grimacing. Fine. It is known as grimacing, which will be given 1 point. Whereas if the baby is coughing or sneezing, then it is what? Then it is this score of 2. Okay, score of 2. Fine. And next, score of 2. The pink means it is 2 only. Okay, that is pink means it is 2. Remember. Then about this activity, it is what? It is this no movement, some movement, and active movement. Means when you stimulate or when you see the baby, if there is no movement, it is what it is. If the child is flaccid or something, it is score of 0. Or if there is only a few movement or something movement is there, it is 1 score. And if it is active movement, it is this 2 score. Okay, 2 score. And about respiration, if there is no breathing or if there is weakened irregular breathing, and if the baby is having the strong cry or shrill cry, then it is 2. Okay, remember about these 2 points only. Okay, first appearance, it is completely blue and the limbs blue to the pink. Next pulse 0 or absent. If it is less than 100, it is 1. If it is more than 100, it is 2. Then about grimacing, there is no response, 0. If it is having some grimacing experiences, it is 1. And if the baby is able to cough or sneeze, it is 2. Fine. Next about activity, if there is no movement, it is 0. If there is some movement of flexion, it is 1. And if it is normal movements, it is 2. Fine. Next about the respiration, if there is no breathing or apnea, it is stages 0. And if there is any few breathing efforts or irregular breathing, it is score of 1. And if it is normal breathing along with this shrill cry or this rapid cry, it will be having a score of 2. Okay, okay, the maximum score of each part it is 2 and the maximum score is 10. Fine. It is used to assess this, how the baby will progress based on this resuscitation. Okay, remember. Fine. Next about this FMGE guidelines for this. Good. For this FMGE guidelines, you will see about this pneumonia and dehydration management. You should know this. Fine. In a case of pneumonia, if there is no signs of pneumonia or no signs of very severe disease, or if there is no signs of fast breathing, or if there is no signs of chest interaction, just this common cold and thing, we'll consider it is not pneumonia. We'll just give them the home remedies and we'll send home for the treatment. Fine. And if there is presence of fast breathing component, okay, how will you tell it is a fast breathing? See, in the case of fast breathing, if the child or if the infant is less than 2 months of age, then we'll tell if the breathing is less than 60 or if the breathing is 60 breaths per minute, we'll tell if the child is having fast breathing. And if the baby is 2 to 12 months of age and if the baby is having more than 50, so remember till 2 months it is 60 and 2 to 12 months it is what it is, this 50 breaths, whereas 12 to 5 years it is what it is, this 40. Okay, so 60, 50, 40, 60, 50, 40. If it is more than 40 in a 5 years old child or 3 years old child, will tell them that the baby is having tachypnea or fast breathing. So once there is a presence of fast breathing, then you need to intervene. We'll diagnose it as pneumonia. Then if we diagnose it as pneumonia, just simple pneumonia, then you should tell about the danger signs. What can be the danger signs? The child won't eat. If the child is not eating for a few days, or if the child is not drinking water for a few days, then bring to us immediately. So that like that you will counsel to the mother. Like I say देखो, you will counsel them. Once you counsel them, and you will give them antibiotics like amoxicillin for 5 days, and you will send them home. Okay. And next, if you are able to see if there is presence of this both any of these danger signs along with this chest in drawing or stridor in a calm child, then you will think it is a case of severe pneumonia or very severe disease. There is no such classification of very severe pneumonia. It is severe pneumonia, also known as very severe disease. Okay. In such case, what you will do, if you are in very much periphery, you will give first dose of ampicillin or first dose of antibiotics or amoxicillin. Okay. First dose of amoxicillin or any antibiotics, are usually amoxicillin will prefer, then we'll send to this higher center. Fine. Then to the higher centers. Fine. Previously we used to have this chest in drawing, either fast breathing or chest in drawing, but now we usually consider only fast breathing as a component. Okay, remember. In the case of fast breathing, just pneumonia, we'll call them after 2 days. Okay, it is categorized as yellow, whereas in the case of severe pneumonia, it is categorized as pink, and after giving this first dose, if you are in the periphery, it is referred to the higher center. Okay, this is the usual component. Fine. Punit, that is very, that is correct. Chlorophynical leads to the Brown-Forman syndrome. That's correct. Next, about this development of milestones. Fine. We'll see about the dehydration part soon. Then we'll see about the development of milestones. See, if you see about this development of milestones, you need to know this also happens in cephalocaudal progression. Okay. First, the baby will start holding its neck at 3 months. Then, around 6 months and 4 months, it will roll and turn around. It will turn around 4 months, and 6 months it will sit with support. Remember, 6 months sit with support. Once it starts sitting with support, then it should sit without support. So around 8 months it will, it is a tripod position, and 8 months it will sit without support, and 9 months it will what? It will stand with support. So remember, 6 months sit with support, 8 to 9 months, 8 months it is sitting without support, 9 months it is standing with support, and 12 months it is stand without support. Okay, 12 months it is standing without support, and after 15 months it will start walks independently, and 18 months it will start running. And 2 months or 2 years it will start climbing the stairs with 2 steps. Okay, 2 steps per foot. Okay, 2 steps per foot it will start climbing. Whereas 3 years, what it will do, it will go up with alternate foots, but it cannot come down. And 3 years it also rides tricycle. And around 4 years it can go up with alternate foots, like 1 foot here, 1 foot here, 1 foot here, 1 foot here. It can go up also, and it can come down also. It can come down also at the age of 4 years. Okay, just remember about this. These are the important motor milestones. First, the baby will start holding neck around 3 months of age, and 4 months the baby can turn, and 6 months what will be, it will be sitting with support, and around 8 months it will sit without support, then it will stand with support, then it will stand without support, and 12 months it will stand without support, because it's her birthday. Okay, so it's need to cut the cake, right? So it will, without support only it will cut the cake. So around 15 months it will be start walking independently, and around 18 months it will start run. Then around 2 years it will go alternate, means it will go along with this 2 foots per step. Whereas at 3 years it will go alternate steps in the upstairs directions. Fine. Whereas it cannot come down. Whereas in the case of 4 years it can go also with 1 by 1 foot, and it can also come down. Okay, and at the same time the 3 years what will happen, it will draw the circle and it will ride a tricycle. Round. Fine. Bas itna yaad rakho. Yeah, I will like this is a sequential involvement. I'll tell few mnemonics when it's necessary. Okay, see this 3 years it is 3 try. So 3 years में क्या करेगा, ट्राइसाइकिल राइड करेगा. 2 years में क्या होगा, 2 years में 2 foot per step रहेगा. Okay, and about a few important ones I will tell a story so that you can remember the important one at least. Fine. फिर उसके बाद पहले मुझे बस basics आपको मोटा समझा देता हूँ, then I will tell you the mnemonic if you are unable to remember all these things. Fine. Then about this language milestones, 3 months the third alphabet C, so it will be squeeing. Then 6 months it will be ma pa करके, means एक ही करके बोलेगा ma pa. 9 months it will say by syllable, it is mama papa. Okay, it is mama papa. Okay, yeah, 3 months it is cooing. Okay, then around 1 year it will speak 1 to 2 words. If they say what, around 1 year they will say happy birthday, so it should tell 1 to 2 words thank you. Okay, it will tell thank you. Okay, so that is what in that is 1 to 2 words. Fine. Then about 15 months it will speak very randomly. Okay, that is known as jargon speech. कुछ भी बकेगा. It is around 15 months. Then around 18 months it will speak around 8, like 10 plus 8 it is 18. So 8 plus 8 to 10 words it will speak. And 2 years क्या करेगा, 2 sentence की words बनाएगा. It will make 2 sentence words. Okay, it makes 2 sentence words. And 3 years में it will know 3 things. 3 years में वो it know 3 things. It can tell its name, age and gender. Age, name and gender. ठीक है. फिर उसके बाद about this social milestones. ठीक है. Around 3 months it know mother's regard, like mother's regard, and 6 months it is S for S, it is the stranger anxiety. Yeah, around 3 years it can ask questions, and 4 years it can tell stories as well. Fine, stories as well. Fine. Around 9 months it will tell bye bye, and 12 months it can play with a simple ball, and 2 years it will play parallelly, and 4 years it will do ground play, so group play. So that's why in 4 years what we'll do, we'll start sending to this pre-KG classes. Fine, that is the 4 years. And about this next one, it is this motor milestones. And about this motor milestone, it is also sequential. For example, पहले क्या करेगा, hand records या क्या है, अपनी हाथे करके it will just see, यार मेरे पास हाथ भी है करके it will see. Fine. Next one क्या करेगा, जो भी तुम दोगे उसको वो palm से पकड़ेगा. Okay, it will start grasping into this palm. It is known as palmar grasp. Okay, next around 5 months जो भी आप दोगे, it will start holding in 2 hands. It is known as what? It is known as bidextrous grasp. अगर around 5 months it will, around 4 to 5 months it can hold a thing with both the hands. ठीक है, support के लिए. फिर उसके बाद क्या करेगा, इसको इस हाथ में देगा. So and 6 months it will be what? It will be unidextrous grasp. It will be what? It will be unidextrous grasp, means एक ही हाथ में पकड़ means with one hand it will hold it. Fine. Around 9 months there will be this, see, this is mature pencil grasp, like this mature है ना, ठीक है ना, जैसे हम लिखते हैं. Whereas if you see like this, if the child holds it is known as immature pencil grasp. इसका नाम है immature pencil grasp. Okay, immature pencil grasp. Whereas around 12 months this will be this like mature like you. So it is what it is, mature pencil grasp. Fine. And जैसे फिर तो पेन तो उठा लिया, फिर उसके बाद क्या करना है, it will start scribbling. It will start scribbling by 15 months and फिर उसके बाद it will start making something. तो क्या क्या करेगा, तो अराउंड 18 मंथ्स जैसे स्क्रिबल कर रहा था तो उसका एक सैचुरेशन पॉइंट हो जाता. तो व्हाट विल डू, इट विल स्टार्ट अ लाइन, इट विल ड्रा अ लाइन अराउंड 18 मंथ्स, इट विल ड्रा अ लाइन अराउंड 18 मंथ्स. ओके, एंड या ऑन 15 मंथ्स इट विल बिल्ड 2 क्यूब्स. ऑन 18 मंथ्स से रिमेंबर इट इज 15 प्लस 3 इट इज 18 मंथ्स में 3 क्यूब्स बिल्ड करेगा. ओके, एंड इट कैन फीड विद स्पोर्ट. ठीक है, देन अराउंड 2 years क्या करेगा, it also start to copy the lines as well. Fine, around it can build up to इसको बाद means after this you need to multiply with this number. So if it is 3 cubes in 18 months, then 2 into 3 it is 6. Then around if it is 3 years, then it will be around building around 9 1. Okay, so it around 3 years क्या करेगा, it will copy a circle. So remember 3 years it will write a tricycle, third alphabet tricycle, and 3 years. See, this is the circle. It will form the face, right? So you should keep the years. Okay, years. So remember, it is years. It will tell the year. So it is the 3 year. It will make the circle. Circle at 3 years. ठीक है, फिर उसके बाद क्या बनेगा? Means it will उसका गर्दन होगा. गर्दन में means it will be wearing this मतलब इसका cross. Okay, the cross it can make it around 4 years. Okay, फिर उसको जैसे गर्दन होता, then the body should come, right? So in the body, what will do? It will make this kind of rectangle. So it will be what, it is the 4.5 years age, it will make this rectangle. ठीक है, rectangle. ठीक है, तो जैसे बॉडी बनाएगा तो नीचे के भी बनाना ना, तो it will make first before making it will make up the dress. ठीक है, तो around 5 years क्या बनेगा, it will make up the skirt which is in triangle shape. This triangle it will make up at 5 years. ठीक है, after फिर उसके बाद नीचे क्या रहेगा, बूथ तो नहीं है ना, तो there will be पैर, so there will be leg. So this leg it is in diamond shape, so it will be it will be around 6 years it will make this diamond. Okay, 6 years it will make the diamond. Okay, so these are the fine motor milestones you should remember. अगर आपको इतना सारा याद रखने में थोड़ा बहुत दिक्कत हो रही है तो just see a few things. For example 3 months में पहले गर्दन को means it will hold neck, and 3 months, okay, month. ठीक है, तो because of this 3 months it is third alphabet, it will do cooing. ठीक है, कूइंग करेगा. ओके, एंड नेक्स्ट इज द 6 months. ओके, 6 month. रिमेंबर 6 months में सारे एस से शुरू होगा. रिमेंबर 6 months में, ठीक है, इट इज लाइक अ सिंगल आर दिस सख्त लौंडा आर दिस सिंगल चाइल्ड आर दिस मींस सिंगल मींस इन द सेंस ऑफ सिंगल एंड कम्युटेड, वो वाला सिंगल. ठीक है, इट इज सिंगल. अगर वो सिंगल है वो क्या करेगा, व्हाट इट विल डू, इट विल यूज हिज हैंड्स. ठीक है, कैसे, इट विल ट्राई टू ग्रास्प हिट्स फोन एंड इट विल ट्राई टू टेक्स्ट. ओके, इट विल ट्राई टू टेक्स्ट. सो इट इज व्हाट, it is the single one, it will uses the single hand to take his phone and text. Okay, so it is what, it is this unidextrous grasp. It is this unidextrous grasp. और अगर सिंगल है तो किससे बात करेगा, किससे टेक्स्ट करेगा, किससे बात करेगा, वो माँ से और पा से. ठीक है, सो इट विल बी हैविंग दिस मोनोसिलेबल्स, इट विल बी हैविंग दिस मोनोसिलेबल्स. या गुड, देन अगर मोनोसिलेबल से बात करेगा फिर कुछ टाइम के बाद क्या होगा, वो थक जाएगा. Means once he gets tired, okay, or because of this using his single hand for this phones, कुछ टाइम के बाद थक जाएगा, then he will be sitting with support. So he will be sitting in tripod position. ठीक है, tripod position which is this sitting with support. ठीक है, सपोर्ट के साथ सिट करेगा. जैसे वो सपोर्ट के साथ सिट किया, फिर उसके बाद क्या होती, अगर वो घर में बैठा है, ठीक है, तो कोई ना कोई तो घर में तो रिश्तेदार आ जाते हैं. अगर लौंडा 25 साल का है तो मीन्स इफ द बॉय इज अराउंड 25 years एंड इफ इज स्टिल सिंगल, सारे क्या जो रिश्तेदार आते हैं वो सारे मार्क करते रहते हैं. तो इसीलिए अगर जैसे वो रिश्तेदार आया वो भागने का कोशिश करेगा. तो सी इन अ केस ऑफ दिस 6 months यू विल एबल टू सी व्हाट, यू विल एबल टू सी दिस स्ट्रेंजर एंजाइटी. स्ट्रेंजर एंजाइटी, रिश्तेदार सारे स्ट्रेंजर्स होते हैं ना, तो रिमेंबर इट इज द स्ट्रेंजर एंजाइटी. ओके, रिमेंबर. सो इट विल बी 6 months सिंगल हैंड unidextrous grasp. फिर उसके बाद इट विल से मोनोसिलेबल्स मा पा, and it will be sitting with support in a tripod position and it will be having this stranger anxiety. ठीक है, good. I guess it is making you to remember. ठीक है ना, at the end of the day तुम्हें याद रहना. ठीक है, then we'll move on to this next part. 12 month पे क्या करेंगे, 12 मंथ पे द बेबी मीन्स आपका बर्थडे आया, ठीक है, बर्थडे आया तो पहले डस्टअप अच्छा से करना, फिर उसको क्या करना, केक कटवाना है। अगर केक कटवाना है तो यू शुड नो मीन्स हाउ टू कट इट जेंटली, राइट? एंड बिफोर कटिंग द केक यू शुड मीन्स इट्स नॉट लाइक इफ आई सिट एंड कट इट वोंट बी गुड लुकिंग गुड, राइट? सो आई शुड स्टैंड एंड थिंक, सो रिमेंबर इट इज स्टैंड विदाउट सपोर्ट अराउंड 12 मंथ्स, ठीक है, स्टैंड विदाउट सपोर्ट करेगा। एंड उसको या सर यू लर्न हिंदी इन, या आई लर्न हिंदी विथ माई फ्रेंड्स, okay? So if you see about this cutting of this cake, if you see the cutting, मतलब अगर immaturely कट कर देंगे ना तो थोड़ा गेट नहीं है ना यार, 1 साल हो गया, फर्स्ट बर्थडे है, ठीक है ना, देन व्हाट यू डू, यू कट विथ जेंटली, ठीक है ना, जैसे पोस्टली, ठीक है। सो इट इज व्हाट इट इज नोन एज मैच्योर पिंसर ग्रास्प, मैच्योर पिंसर ग्रास्प। हम जैसे वो बोलेंगे बेटा कंग्रेचुलेशंस बेटा, तो क्या बोलना है, एक दो शब्द तो बोलना ना, यू शुड टेल 1 to 2 words, दैट इज व्हाट अराउंड 12 months इट विल स्पीक 1 to 2 words, ओके, 1 to 2 words बोलेगा। फिर उसके बाद जो भी आएंगे, ठीक है, ठीक है, जो भी आएंगे तो यू विल स्टार्ट वॉकिंग। सो जस्ट रिमेंबर ऑल दिस थिंग्स, स्टैंड विदाउट सपोर्ट, मैच्योर पिंसर ग्रास्प एंड 12 words, एंड फाइनली वो किसके पास जाएगा, वो मामा और पापा। सो इट विल टेल this bisyllable words, it is mama papa, okay, just remember। and next we'll move on to 18 months। remember 18 साल पहले हम सारे घर में थे, क्या करते थे, क्योंकि हम बच्चे थे, ठीक है, we were inside the home or we were limited with few things because we were very kids, or we were kids, we just finished our intermediate just 18 months back, but like around this 18 years, remember this 18 years to 18 months, okay? So just correlate with your lifestyle, then we know after 18 months क्या होगा, तो हमें क्या होना कि घर से बाहर आके पढ़ाई करना है, मीन्स यू शुड कम आउट, इधर यू शुड गो अब्रॉड, यू शुड स्टडी, सो दैट, तो इसलिए आपको क्या करना है, घर से भाग के आना है, यू शुड रन एंड यू शुड कम आउट ऑफ इट। तो ठीक है, तो उससे पहले आपके साथ एक लिमिटेशंस थी, तो लिमिटेशंस मनाने के लिए एक लाइन के अंदर थे आप, ठीक है, आपकी जिंदगी, तो इफ इट इज योर एंटायर लाइफ विद इन अ लाइन, फर्स्ट यू शुड नो हाउ टू मेक अ लाइन। सो अराउंड 18 months इट विल मेक अ लाइन, ठीक है, देन इट विल ट्राई टू क्रॉस द लाइन, सो इट विल क्रॉस बाय रनिंग, so it will runs around 18 months, ठीक है, भाग के बाहर आएगा। when you come out of it, then you know the values of your mother and values of your family, ठीक है। तो अगर if you come out, you know you need to do work with your hands, ठीक है, you need to do work। तो कैसे आप काम करोगे, means if you do work, it is what it is, you're building the cubes, you will build 3 cubes, then you need to prepare food, ठीक है ना। ये जैसे आप बाहर आएंगे तो खाना भी आपको बनाना है, बर्तन भी आपको धोना है, मीन्स यू शुड वॉश योर यूटेंसिल्स बाय योरसेल्फ ओनली, नो मम्मी आके तो नहीं धोंगे। तो रिमेंबर यू विल डू दिस थिंग व्हिच इज नोन एज डोमेस्टिक मिमिक्री, मतलब द स्मॉल चाइल्ड व्हाट इट विल डू, इट विल स्टार्ट टू मिमिक हिज पेरेंट्स, लाइक वॉशिंग द डिशेस, वॉशिंग द क्लॉथ्स, इट विल स्टार्ट टू मिमिकिंग। सो डोमेस्टिक मिमिक्री इट विल बी हैपनिंग एट द एज ऑफ 18 months। 18 months फिर तो सबसे तो मतलब मेन चीज हम किस चीज के लिए बाहर रहे, मींस व्हाट इज द मेन रीजन, यू कम आउट ऑफ योर होम, आपको पढ़ना है। सो द बेबी विल स्टार्ट flipping the pages, so it will start flip 1 to 2 pages, yeah। तो and I told you right, डोमेस्टिक खाना भी आपको खुद बनाना है, बर्तन भी आपको खुद धोना, तो इसीलिए इट विल स्टार्ट फीडिंग विथ स्पून, ठीक है, वो स्पून से फीड करेगा, ओके, स्पून से फीड करेगा, और लोग से बात भी करना, तो इट विल बी हैविंग दिस 10 + 8, so there will be 10 + 8 words, ठीक है। तो रिमेंबर इट विल रन, इट विल मेक a line and it will be having build cube of 3 cubes, and it will do all these domestic jobs which is known as domestic mimicry, and it will turn 1 to 2 pages। तो it is the mnemonic for the 18 months। फिर उसके बाद आते हैं 3 years पे, ठीक है, अराउंड 3 years, ठीक है, 3 years मैंने बोला द बच्चा विल राइड ए ट्राईसाइकिल, ठीक है, राइड ए ट्राईसाइकिल, ठीक है, जैसे ये बच्चा ट्राईसाइकिल चला रहा था, ठीक है, क्या हो गया, मींस द बेबी वाज राइडिंग द ट्राईसाइकिल, नाउ द ट्रैफिक पुलिस ही गॉट द अटेंशन, सो ही केम टू द बेबी, ठीक है। इफ ही केम टू द बेबी, अगर जैसे पुलिस इनके पास आता है, तो व्हाट आर द 3 क्वेश्चंस ही विल आस्क, नाम क्या है, ठीक है, देन व्हाट इज नेम, एज एंड जेंडर। सो एट 3 years it can tell 3 things, which is this name, age and gender, ठीक है, नेम, एज एंड जेंडर, ठीक है, या इट कैन टेल 3 things which is नेम, एज एंड जेंडर, ठीक है, ठीक है। तो पूछा लाइसेंस दिखाओ, तो देन इट टोल्ड व्हाट इज योर नेम, एज एंड जेंडर इट टोल्ड, देन फिर भी वो ट्रैफिक पुलिस नहीं माना, क्योंकि ये छोटा बच्चा कैसे चला सकता है, तो इसीलिए ही टोल्ड यूजुअली for us to get license will make 8, लेकिन ये छोटा बच्चा है 8 तो नहीं बना सकता, तो इसीलिए क्या बोले ठीक है चलो तुम एक सर्कल बना के मुझे दिखा दो. तो around 3 years it will make a circle. So around 3 years it can write a tricycle. It knows 3 things, which is age, name and gender, and it can form a circle. Fine. So these are the 3 things you should remember from this 3 years of age. Okay. If you are unable to remember all other things, just remember these things. It will be helping out. Okay. It will be helping out during your examination part. Okay. If you fill it out, please let me know. We'll help you out. Fine. Yeah. Thank you, Dr. Medicine. Yeah. I hope you are enjoying and you are getting things correct. Yeah. Yeah. 3 into 3, it can make a cube of 9 cubes. Yeah. 9 cubes. Yeah. Good, Dr. Puneet. Yeah. Fine. Next, about this few syndromes. If you see about this Down syndrome, here also have a small story. Fine. I'll tell you. Fine. If you see this Down syndrome guy is down at 21 years. Is down at 21 years. Q? Because why is down? Why is sad? The 6 months old salary. Is single. Okay, see, there will be always one person in every gang, either your roommate or your classmate, who will be always talking to the either boy or a girl. But if you ask, kya hua? Means are you committed? They will tell, no, I'm single. Okay, so this people will be, there are few exceptions will be like that. So during preparation part, they actually become single. So when you ask them, are you single now? At 21 years, how will you be single? But the answer for them, there is no answer they didn't told. They just showed their hand. Okay, yeah, see, I'm single. Like with hand, how will you tell it is single? We can tell. See, if you see this hand, there will be this Down syndrome baby will be having this hand which is known as single simian crease, like 𝗵𝗄𝗏. Okay, see, if you see, there will be what? There will be single simian crease. So there will be single simian crease. Yeah, simian crease. And why it is single now? Because it had only one girlfriend or a boyfriend. Okay, the child had only, like, remember it is a boy, so only it has only one girlfriend, and someone took away her girlfriend. Okay, his girlfriend. So who is that? Okay, so if you see who, because the girlfriend broken his heart. So here you will able to see this cardiac condition which is known as endocardial cushion defect. Because his heart is broken because of this endocardial cushion defect. Who broken his heart? Because this Robertsonian translocated his girlfriend. So this Robertsonian translocation is seen here. Because क्या हुआ, कौन इसका दिल तोड़ा? क्योंकि रॉबर्टसोनियन ने इसका गर्लफ्रेंड को उठा लिया, तो उसने इसका दिल तोड़ दिया. So having this heart feature, which is what was this endocardial cushion defect, because of this Robertsonian translocating his girlfriend. So remember, it is the Robertsonian translocation. Fine. And next one, if you see, he'll be single. He won't be roaming in good kapade. Means he won't be roaming in good clothes. He'll be roaming with this simple sandals. So he will be having this sandal toes. And in some part of time, he tries to remember everything. Okay, so he will be having what? He'll be try to forget everything. So he will try to forget all. So the most common type of leukemia, it is what? It is ALL. It is the most common leukemia in the case of Down syndrome. It is the ALL. And so because if you want to forget, the God will give you his varam. So that is what that is. This pre-senile Alzheimer's. Okay, Alzheimer's. Remember, yeah, pre-senile. Kandipa Salla. Okay, so that's what, like, when he shows his hand, he will tell, like, find me whether I'm single or not, like that. Like, I will see and tell he's single. Then he will ask 𝗵𝗄𝗏, like 𝗵𝗄𝗏. Okay, then about this one, there will be what? There will be this pre-senile Alzheimer's. Fine. So these are the things. Like here you will able to see this heart condition which is known as endocardial cushion defect. And why there is heart condition? Because the Robertsonian translocated his girlfriend, which is known as Robertsonian translocation, and he tries to forget everything. That the most common leukemia, it is ALL. And then if you are able to see preclinical Alzheimer's, like pre-senile Alzheimer's, so that he will get Alzheimer's in very early age. It is not 𝗃𝗄𝗏, it is 𝗵𝗄𝗏. Means there is a meme, it is known as 𝗵𝗄𝗏, like that. So you just go and see. Okay, it is a Tamil meme. Okay, means 𝗵𝗄𝗏 means 𝗵𝗑𝑑, means how. Okay, so there is a small child, it will be doing some thing, like it will be playing with the rubber band, and while doing, it will remove it. So it will ask you 𝗵𝗄𝗏, means how it is happened. Okay, the same thing. Okay, so likewise we'll see the hand and we'll diagnose likewise 𝗵𝗄𝗏, how you diagnose with the hand. Okay, See, so the patient will be, the patient will be having this sandal toes. Okay, the patient will be having this sandal toes. Okay, and we know this usual Down syndrome features, which is this macroglossia. There will be this Mongolian slant of eyes. Mongolian slant of eyes. Yeah. नहीं गाली तो अभी तो नहीं दे सकते ना. So, okay, so these are the features you need to know about this Down syndrome. Next, आगे बढ़ते this syndromes. Okay, so these are the Down syndrome का features है, तो इतने आपके याद रख लिया. फिर उसके बाद है Turner syndrome. Okay, Turner syndrome. Yeah, Turner syndrome. So if you see here, we talked about this boy which is Turner. Okay, next we saw about this, we'll see about this Turner syndrome. ठीक है, Turner एक लड़की है. ठीक है, Turner एक लड़की है, वो छोटी सी लड़की है. लोग प्यार से हम like चुटकी बुलाते हैं ना, तो like there will be a small girl, ठीक है, and she'll be roaming in the classes. So she'll be roaming in the classes like this. So one day this boys and some other girls, class girls, they try to mock her. Okay, कैसे mock करते? Oh, like that they will call this girl, and whenever she crosses. So it is what it is, 45XO. It is what it is, 45XO. So they will call this child as oh. So it is 45XO. And one day, means it is not every day, it is her like she's got already mad and pissed off with it. So she tried to reply them back. How? She want to turn and to reply them back. But while she was trying to turn, she unable to turn. Why? Because she was having this necks. So she was having this webbed neck, she is unable to turn. So remember this, she is turning, so it is this Turner syndrome, and she will be having this short stature as I told you. Okay, chutki. So she will be having this short stature, and then she is trying to turn. It is known as what? It is known as Turner syndrome. Turner syndrome. Okay, and here there is but she's a girl, she is not single, so she is mingle. Why? Because she also having a heart defect which is similar to his boyfriend, which is this Noonan syndrome. Noonan syndrome. In the case of Turner syndrome, it is associated with this bicuspid aortic valve and coarctation of aorta. Whereas the male counterpart of this Turner syndrome, it is what it is, this Noonan syndrome, which will be having this pulmonary stenosis, pulmonary stenosis. Okay, and both of them, they maintain streak in the snapshot. So she will be having the streak ovaries. She will be having the streak ovaries. See, Turner syndrome, it is especially seen in ovaries, whereas the male counterpart of it is known as Noonan syndrome. Whereas this Noonan syndrome can be seen in both males and females. Both males and females. So Turner, everyone is calling OO. She is trying to turn, so that is Turner syndrome, and she is unable to turn because she was having the webbed neck. Okay, she was having this webbed neck, but she want to reply back. So that's why she called her boyfriend. How they became boyfriend? Because both of them, they have similar characteristics. She had this heart problem, which is this bicuspid aortic valve and coarctation of aorta, and he had the pulmonary stenosis, and both of them, they try to maintain the streak in the snapshot. That's why she will be having a streaky ovaries. Okay, so itna yaad rakhna. I guess you will able to correlate what are the features of the Turner syndrome. Okay, yeah, Noonan, it is the male counterpart of Turner syndrome, which can be seen in both males and females. Okay, fine. And next about this Klinefelter syndrome. This Klinefelter syndrome, it will be having this one. Just remember this 2 to 3 features. This one of them is this gynecomastia. Okay, gynecomastia, and there will be large testis. Okay, if it is a male, so there will be small testis will be there. There will be small testis. Yeah, good. Yeah, that the IQ will be normal in the case of Turner syndrome, and it will be associated with a thing which is known as lymphedema. So the neck, like instead of web neck, you can also tell there is a swelling here. It is known as lymphedema. Fine, lymphedema. Yeah. In the case of Klinefelter, you will be able to see this bare bodies. Okay, fine. Yeah. Next, if you are able to see this Edward syndrome, see, remember Edward, it is the 18. Edward 18. Okay, in everywhere in Edward, it is everything is elongated. So elongated hands. If the hands are elongated, then we cannot hold it inside. So what will happen? There will be overlapping of fingers. Fine. And then the child will be having this rocker bottom foot, and elongated kidneys, which is this horseshoe kidneys. Fine. Yeah, what is the question, Puneet? Fine. Next, if you're able to see about this next one, where there is a presence of this R central defects, this like cleft palate and cleft lip, and along with this there is this heart defects which is VSD, which is mostly seen in both VS means 𝗏𝗏 syndrome and Edwards syndrome. Fine, 𝗏𝗏 syndrome and Edwards syndrome, and here there will be more dactyly, which is known as polydactyly. Fine. Like in clinical it will be mostly hypogonadism, doctor. Like it is the hypogonadism. Okay, hypogonadism at the level of testis means testis will be small. Okay, whereas if we see about this here at the level of pituitary there will be more action. So this is what it is, this hypergonadotrophic hypogonadism. So hypogonadism will be there, but it is because because the problem is at the level of testis, but whereas the pituitary function will be normal. Okay, just remember. Whereas in the case of Kalaman syndrome it is hypogonadotrophic hypogonadism along with this anosmia, remember. Fine. And about 𝗏𝗏 syndrome, 𝗓𝗏, so it is the trisomy of 13, and they will be having this P, all these P features, cleft lip, cleft palate, and we saw one more thing which is the coloboma, which is this colobosoma. Yeah, there will be low testosterone, like usually if it is low testosterone then the FSH and LH will be more. Okay, remember. Yeah, Kalaman will be so hypo along with this anosmia means loss of smell. Okay, and this 13 will be this 𝗏𝗏 syndrome. Fine. And about next important part about the CNS of this pediatrics one, it is the febrile seizures. Okay, if you see this febrile seizures, it will occur from around 6 months to 6 years of child. And what are the what are the risk factors can be associated? And if there is any case of this febrile seizures, it will be managed. It will be having this kind of features where it will be managed with this rectal diastema. So if there is any active seizures, हमें पहले एयरवे देखना है, फिर उसके बाद क्या करना है कि बेंजोडाइस्पिन देना है. मोस्टली हमें पेरेक्टल बेंजोडाइस्पिन हम देंगे, ठीक है, बेंजोडाइस्पिन देंगे, and mostly will start intervention if it is more than 5 minutes, ठीक है. And for intermittent prophylaxis के लिए हम oral clobazam देंगे, fine, oral clobazam देंगे. And what are the risk factors for this recurrence of seizures? Like in few cases this febrile seizures may occur again and again. What are the risk factors? If the age is less than 1, we told it is with around 6 months to 6 years it may occur, but if the age is around 6 months only, if it is less than 1 year, then there is a major risk factor. And if the duration of fever is less than 24 hours, if it is more than, it is fine. If it is less, it is not fine. Then the fever is around maintaining the range of 38 to 39 degrees Celsius. So it is one of the major risk factors. The minor include there might be a presence of family history and family history of other seizures like epilepsy, or if there is any complex febrile seizures, or if the baby was left in a daycare with there is less caring. Okay, and if there is a male gender, and if there is increased sodium at the type of presentation. So all of these features, they can be a minor factor for this recurrences, whereas major one, it is the age less than 1 year and the temperature between 38 to 39 and the duration of fever, it is less than 24 hours. So these are the few risk factors you should know of. Fine. And next about this epileptic seizures. ठीक है, epileptic seizures में हमें पता है neonates में the most common one, it is the subdural seizures, and the most common cause of this neonatal seizures क्या है? It is the hypoxic ischemic encephalopathy. It is this hypoxic ischemic encephalopathy, याद रखना. Next, what is the drug of choice of this neonatal seizures? इसके लिए हम देंगे phenobarbital. ठीक है, तो most common one it is a subdural seizures, और most common cause क्या हो सकता है? It is this hypoxic ischemic encephalopathy. And next, if you see what is the drug of choice, it is the phenobarbital. Yeah, fine. Next, if you see a 8 years old female who is presented with features of this vacant look, ठीक है, जैसे तुम गए थे, means if when you were sitting in a pediatric OPD and when the baby came and it starts giving you this vacant look, this kind of silent and vacant look, okay, and along with this post-ictal confusion, it will be typically seen in a case of absent seizures. Okay, absent seizures. Yeah, fine. And here you will be able to see this EEG finding of 3 Hz spikes. You will be able to see this EEG finding of 3 Hz spike. Okay, and this is the typical features of this absent seizures. Okay, absent seizures. And we know in a case of absent seizures, अगर बच्चे हैं तो we'll give this 𝗧𝗵𝗶𝗀, or we can give in later part, or if it is in adults, we'll give this 𝗵𝗵𝗆. So remember this absent seizures, this vacant look, and it can predispose, or we can create the seizures by telling the patient to hyperventilate. You give this fan, like in childhood you will be having this small fan kind of thing, right? Like when you show with the ear, like air, it will be running. So you will tell the patient to You will tell them to blow the fan. So when the patient is hyperventilating, then this episode will occur. So mostly it will be described in the questions, and EEG there will be showing this 3-head spike pattern, 3-head spike pattern, and it is seen in a case of absent seizures. और उसको treat करने के लिए हम क्या देंगे, 𝗏𝗏 देंगे, ठीक है. Then if there is a male infant who is presenting with these features of delayed milestones and jerks involving the head neck like a 𝗧𝗵𝗶𝗀 seizure, so ECG is showing this hips arrhythmia. It will be seen in a case of, yeah, good, it is seen in a case of West syndrome, okay, or which is this infantile spasm. और infantile spasm में हम क्या देंगे, will give this high dose of ACTH, will give this high dose of ACTH. अगर if infantile lesion, if it is associated with this tuberous sclerosis, अगर tuberous sclerosis है तो हम क्या देंगे, TB देंगे. तो remember, it is the tuberous sclerosis will give TB, that is this 𝗵𝗵𝗿𝗺. It is this 𝗵𝗵𝗿𝗺 will give in a case of infantile spasm with in a case of tuberous sclerosis. ठीक है. Then you say a 13-year-old female with complaints of jerks in the hands leading to frequent fall of objects, means it is causing this myotonic jerks. So if you are able to see this type of myotonic jerks, and along with this EEG, there is a presence of this polyspike pattern. There is a presence of this polyspike pattern. It is be suggestive of juvenile myoclonic epilepsy. It will be suggestive of juvenile myoclonic epilepsy. It is be suggestive of juvenile myoclonic epilepsy. Fine. Then what is the treatment for this juvenile myoclonic epilepsy? It is the treatment versus this 𝗵𝗲𝗀 or levetiracetam. It is this 𝗵𝗲𝗀 or levetiracetam. Okay. Let me ask you a question from the medicine and pharmacology part. You say a female who is willing to conceive and she is on valproate. Up, what you will do? What you will do now? Will you tell, yeah, no problem, just take this valproate, or will you change them into this levetiracetam or 𝗵𝗲𝗀 especially? What you will do, guys? Yeah, will change. If the female, she is having this idea, मुझे pregnant होना है, तब हम क्या करोगे? Then you will change into 𝗵𝗲𝗀. Then if there is already, वो मन बना के pregnant भी होकर आई है तेरे पास, तो तुम्हें क्या करना है? तो आपको क्या करना होगा? आपको करना है, ठीक है, आप तो फेनेटोइन कर रहे हैं, कोई दिक्कत नहीं है, वैल्प्रोएट ले रहे हैं, just take up more doses of folic acid. ठीक है, बस आप इतना करो, don't change the tablet. ठीक है, बस इतना करना. Yeah, good doctors, fine. Yeah. Then about this few conditions, like if there is any seizures, ongoing seizures चल रहा है, तो हमें पहले करना है, पहले हमें airway check करना है. मतलब airway, मतलब we should, like if the patient is going, then we should move them into this left side, okay, left lateral position in the left side. Then once we secure the airway, we'll check for this breathing and circulation. If everything is fine, हमें IV access करना है. IV करने के बाद we need to send for this blood investigations, क्योंकि sometimes this electrolyte imbalance can cause this. फिर उसके बाद हमें पहले benzodiazepines देना है. For example, if there is lorazepam से शुरू कर सकते हैं या मिडास से शुरू करते हैं, but midazolam will avoid in a case of liver failures and things. Fine. Second line, हम child को हमने एक benzodiazepine दी है, फिर भी then the seizure is not stopping, then we'll give this IV phenytoin. Fine. Whereas if it is adults, we'll go for this levetiracetam. अगर ये भी देने के बाद भी, means if after giving this phenytoin or levetiracetam, if it is still occurring, then we'll go for the valproate. ठीक है, याद रखो. So this is the thing you want to remember about this management of the seizures and this epilepsy part. Okay. Yeah, good Dr. Hans, good Dr. 𝗏𝗵𝗶𝗀 Puneet Anar. Fine. Then you need to see about this short stature. Yeah, if there is no availability of, that's what, like if there is no levetiracetam, 𝗵𝗲𝗀 available नहीं है, तब आप phenytoin दे सकते हैं, means like valproate दे सकते हैं, ठीक है ना? So that is the one. Yeah. Fine. Remember. Yeah, good Dr. Puneet. Then about this short stature, there are two types of short stature. Means there will be this upper segment and lower segment ratio. अगर दोनों maintained है, तो उसको बोलेंगे proportionate stature. Okay. Upper segment, lower segment. ठीक है. And if it is not, one side is big, one is small, it is known as disproportionate short stature. तो क्या क्या हो सकता है? One is this abnormal short limbs. क्या है? For example, in the case of achondroplasia, there will be this trident hand will be there, and there will be this champion glass pelvis. Okay, trident hand and champion glass pelvis in a case of achondroplasia. Or in a case of mucopolysaccharidosis, हमें पता है mucopolysaccharidosis, what is the classical presentation? There will be this core spaces will be there, and there will be corneal clouding will be there. Okay, corneal clouding will be there, and on bones they will be having this deformity which is known as Erlen-Meyer class deformities. तो थोड़ा बहुत उसको ये करना, मतलब mainly remember about the facial features like our Hurler syndrome. These are this mucopolysaccharidosis. Fine. फिर उसके बाद this will come to this proportion. कुछ टाइम पे ये नॉर्मल हो सकता है. फॉर एग्जांपल फैमिली में नॉर्मल है, तो द चाइल्ड ऑब्वियसली विल बी हैविंग नॉर्मल. normal, and it will be short in nature, so it is obviously normal one. Or else there will be a constitutional delay in short stature. मतलब कुछ time तक the बच्चा will be small, like okay, the child will be small. After some time, during this adolescent age, the बच्चा will be having this peak growth. So it is what it is, this constitutional delay. ठीक है. And next about the pathological, कुछ prenatal cause हो सकते हैं. For example, some of the drugs which causes intrauterine growth restrictions, okay, or any infections की वजह से, okay, वो हम पढ़ेंगे. और नहीं तो any other disorders, for example, in the case of Turner syndrome, the child will be small, will be having the short stature. So all of these things will lead to this proportional short stature. Whereas पैदा होने के बाद क्या हो सकता है, शायद उनको खाना कम मिला, उसको बोलते हैं कि अंडर न्यूट्रिशन, या नहीं तो क्रोनिक इलनेस. फॉर एग्जांपल इन केस ऑफ कार्डियोवास्कुलर डिसीज, या नहीं तो फिर इन केस ऑफ हार्ट फेलियर, और इन केस ऑफ किडनी डिसीज, और एनी अदर डिसीजेस, इट मे लीड टू दिस शॉर्ट स्टेचर. ठीक है. एंड देयर इज दिस endocrine causes like especially this growth hormone and hypothyroidism. Growth hormone and hypothyroidism, ये भी एक करा सकता है. Okay, ये भी एक करा सकता है. But most common one you should know, it is this, the proportionate short stature. ये क्या है? It is what it is, this familial short stature. Means not familial, it is this constitutional delay in development. Constitutional delay in development or constitutional delay in development में at the end of the day, finally the baby will be having this normal stature. ठीक है, ये इतना याद रखो, the baby will be having this normal stature. ठीक है, fine. Then we'll come on to this SAM का definitions. Okay, stunting कब बोलेंगे? stunting मतलब short रहना. ठीक है, तो there is a low height for age. Wasting मतलब weight को लेंगे, तो low weight for height. तो low weight for height in a case of wasting. Whereas underweight कब बोलेंगे? there is a low weight for age. There is this low weight for age. Fine. And about interpretation, अगर stunting है means if there is height decrease है, तो it is because of this chronic malnutrition. Whereas in wasting means if there is relation to the weight, it will be what? It will be mostly acute in nature. Okay, acute in nature. So wasting, it will be what? It is acute malnutrition. Whereas if it is weight, it is acute. Whereas height, ठीक है ना, height बढ़ने के लिए बहुत देर लगता है, लेकिन 3 महीने में वेट बढ़ जाएगा, 3 महीने में वेट कम हो जाएगा. फॉर एग्जाम्पल आपका तो अभी तो आपका वेट बढ़ रहा होगा because of this depression stress. जैसे आप internship में जाओगे, then your weight will start reducing. So but your height is not like that. Your height will be almost similar. तो height के लिए time लगता है. तो remember, the height will be manifested as a, or the height changes are manifested as a chronic malnutrition process. तो इसीलिए stunting में will count for this height for age, which is this chronic malnutrition. Whereas in a case of wasting, we'll use this weight part, which is this weight for height, which is seen in a case of acute malnutrition. ठीक है. Whereas underweight कब बोलेंगे? Which when there is a weight for age is less. ठीक है, which is the acute and chronic malnutrition. ठीक है, या वही मतलब ड्यूरिंग दिस प्रिपरेशन पार्ट टेंशन में थोड़ा बहुत ज्यादा ही खाना खा लेते हैं और थोड़ा बहुत ज्यादा ही सो लेते हैं. ठीक है, कोई ना अभी 30-40 दिन का, फिर उसके बाद तो मन ही नहीं करेगा खाने का. ठीक है. देन अबाउट व्हाट आर द डेफिनेशंस यू नीड टू नो अबाउट दिस SAM. या अबाउट दिस SAM you need to know the weight for height if it is less than 3 standard deviation, or if there is any features of severe wasting, or this mid-arm circumference which you measure using this 𝗧𝗃𝗃 tape if it is less than 11.5 centimeter, or if there is presence of edema, if there is presence of edema of the bilateral field. ठीक है, तो इतने सारे definitions आपको याद रखना about this severe acute malnutrition. Fine. And in next questions they will ask you what are the complications can be associated with this severe acute malnutrition. So remember, it is the हाइपोग्लाइसीमिया, हाइपोथर्मिया, इन्फेक्शंस हो सकता है, नहीं तो लाइक इट विल बी नोन एज शील्ड चेस्ट. ठीक है, शील्ड चेस्ट. ओके, रिमेंबर अबाउट दिस शील्ड. एस फॉर शुगर. ठीक है, शुगर. तो H for hypothyroidism will be there, I for infections will be there, E for electrolyte imbalance will be there. Okay, shield. Okay, C for electrolyte imbalance will be there, and D for dehydration will be there. So all of these features will be seen as a complication of this SAM. Okay, seen as a complications of the SAM, and all of the following should be taken care during its treatment or treatment modality. Okay, so remember, and the fluid of choice will give is this oral with 5% dextrose. Okay, once hospital में आ गए तो they should get discharged, but when you will tell the patient is okay for discharge, once you discharge them they will gain their weight. तो तब आप कब बोलोगे कि if the edema component has improved, fine, and if there is an adequate weight gain per gram, and the child should get the food orally. It is not TPN. The child should eat orally and the appetite should become normal. And the caretaker should be confident enough to handle the child. Okay, ऐसे नहीं कि मतलब they think like still कुछ नहीं होगा, then obviously कुछ नहीं होगा. लेकिन when you start thinking, yeah, मुझसे हो सकता है, FMG निकाल सकते हैं, ठीक है ना, then the same with the child. Like the mother will tell, हाँ मेरी बच्चा है, मेरी बच्ची है, तो I will take care of this. So then when the confidence come, then you need to discharge them. Okay, confidence along with these features. Only ऐसे नहीं confidence हो गया बच्चे सही हो जाएगा, बिल्कुल नहीं. ठीक है, confidence भी होना चाहिए, उसके साथ साथ काम भी होना चाहिए. So you should have confidence as well as you need to read the notes, you need to do questions, then only you will able to get or you will come out with flying colors. ठीक है, ऐसे नहीं है नोट्स सारे खरीद के रखे, सारे प्रिंट करा के रखे, आंख बंद कर लेंगे, एग्जाम में जाएंगे और पास हो जाएंगे. ऐसे बिल्कुल और कभी नहीं होता. मेहनत करने वाले को बिल्कुल अच्छा रास्ता और सही रास्ता मिलेगा. सो जस्ट put your efforts in the right directions and go ahead with the right part. You will get the right thing for sure. ठीक है, बस इतना ही. Yeah, it was a PVQ. Yeah, good, Dr. Anar. Yeah, nice notice. Fine. Next, about two things you need to know about this kwashiorkor and marasmus. If you see about this kwashiorkor, see, if this child is sitting like this, here its belly will be like this. So remember this K, it will be having this belly. It will be having this belly. Okay. So it is what? It will be having the edema present. Okay. This belly edema will be present in a case of kwashiorkor. Okay. So kwashiorkor, it is mainly due to this प्रोटीन malnutrition. अगर प्रोटीन malnutrition की वजह से the child will be having the less appetite होगा. Okay, and child will be floppy. अगर आप उसको खाना भी दोगे ना वो नहीं खाएगा. Okay, then if it is case of marasmus, it will be a vigorous baby and skinny baby. It is because of this energy. It is because of this both energy and protein malnutrition. Remember, okay, and they will ask these two signs where you will see this flaky pain dermatosis. Okay. हाँ वही है, ये PVQ का ही है. ठीक है, so if you see it is this flaky pain dermatosis, you will see in a case of kwashiorkor. ठीक है, and next this flaxen also will be seen in the case of kwashiorkor. ठीक है, so if you see this kwashiorkor part, I told you it will be having this edema present and pedal edema because decrease protein है. So protein decrease है तो क्या होगा? If there is decrease in protein, then there will be decrease in osmotic pressure. Osmotic pressure decrease होगा तो edema होगा. So there will be presence of edema. Okay, there will be presence of edema. The child will be lethargic. आप जितना भी खाना खिलाओ बेटू बेटा बेटी, then it won't accept it. Whereas marasmus, आप बस खाना दिखा दो वो खा लेगा. ठीक है, so there will be voracious appetite and along with this the child will be active in nature. बस इतना याद रखो. Yeah. SAM में हम reosmolar दे सकते हैं. Yeah, good. We can give this rehydrated osmolar solutions in a case of SAM. Yeah, that's good. Fine. Next we'll see about this MCD, minimal changes. We told MCD it is the most common cause of nephrotic syndrome in children. Okay, whereas PSG it is the most common cause of nephritic syndrome in children. Okay, then minimal changes में we know it is a nephrotic syndrome. The protein loss होगा, there will be a presence of edema. Okay, so there will be a presence of massive proteinuria. तो blood में protein का level कम होगा. So this and also this leads to this concurrent increase of this hyperlipidemia. और हमें पता है लाइट माइक्रोस्कोप में हमें कुछ नहीं मिलने वाला है, तो इसीलिए हम जैसे when you do this electron microscopy, you will see this effacement of podocytes. ठीक है, podocytes. ठीक है. Next about this part which is this post streptococcal glomerulonephritis. ठीक है, there will be a history of sore throat and after 14 days of sore throat, the child is presented with this cola colored urine which is the hematuria. और हमें पता है in a case of nephritic syndrome हुआ hematuria, oliguria, hypertension and azotemia. तो these are the features seen in a case of nephritic syndrome और वही ये PSG ने भी manifest करेगा and PSG ने भी वही manifest करेगा. So there will be presence of this hematuria which is this cola color urine and some level of proteinuria will be there and hypertension and ASO levels also will be high and it is because of this streptococcus pyogenes, so there will be anti-DNase antibody levels will be more. ठीक है, बस आपको इतना याद रखना है और PSGN वो अपने आप सही हो जाएगा. आपको कुछ नहीं करना है, आपको घर बैठे बस देखना है. ठीक है, बस इतना काम करो. ठीक है, या गुड डॉक्टर पुनीत, या गुड डॉक्टर शानवास खान, गुड डॉक्टर अंश, या गुड डॉक्टर अना. नेक्स्ट अबाउट दिस डायरिया कंपोनेंट और दिस डिहाइड्रेशन. ठीक है, सी if there are 3 levels of dehydration: no dehydration, some dehydration and severe dehydration. ठीक है, in a case of no dehydration there will be मीन्स द चाइल्ड विल बी हैविंग द एपिसोड्स ऑफ वॉमिटिंग और डायरिया. लेकिन क्या हुआ, मीन्स इन अ केस along with this there if you see this signs, the eye node will be sunken, and if you see this tongue, it will be wet with the salivations, it will be wet, and when you do the skin pinch it will go normally. So सब कुछ नॉर्मल है. तब क्या होगा, इट इज अ नो डिहाइड्रेशन पार्ट. तब हम क्या करेंगे, कुछ नहीं बेटा, बस ORS पी लो. ठीक है ना, जूस पी लो नहीं, इट इज ORS पी लो. ठीक है, जूस पी लो मौसम्बी का नहीं, इट इज ORS पी लो. ठीक है, जस्ट ओके fine. And next about this some dehydration part, if you see about this some dehydration part, then if you able to see here, the child will be restless. The child will be restless or irritable, and it will be having this sunken eyes, and it will be, and जैसे आप उसका मौसम्बी का जूस में, when you will give this ORS to this child, then it will drink this water very eagerly. ठीक है, so in a case of some dehydration, the child will be thirsty and it will drink eagerly. और जैसे आप स्किन का टेस्ट करोगे, then it will be what, then it will be decrease, but not to a very much level, it will just glow, it will go very slowly. Okay, it will go slowly, it will not go very slowly, and there will be small sunken eyelids, and the child, main differentiate picture क्या है, the child will be thirsty, मतलब उसको प्यास लगेगा. ठीक है, जैसे आपको पानी पिलाओगे वो अब it will start drinking the water. ठीक है, whereas in a case of severe dehydration में, in a case of severe dehydration में, the other signs will manifest. Thus the fontanelles will be sunken, the child will be what, it will be very much lethargic and unconscious, the eyes will be sunken हो जाएगा. ठीक है, and the child will not able to drink water. और जैसे आप स्किन पिंच करके छोड़ोगे, यूजुअली इट विल गो नॉर्मली, एंड इट विल टेक मोर देन 2 seconds टू गो इटसेल्फ. ठीक है, तो वो बहुत स्लोली जाएगा, वो स्किन का टर्गर चला जाएगा. ओके, सो दिस आर द थिंग्स यू विल सी इन अ केस ऑफ सीवियर डिहाइड्रेशन. ठीक है, तो व्हाट इज द मैनेजमेंट, आप क्या क्या करोगे. ठीक है, इफ यू सी इन अ केस ऑफ नो डिहाइड्रेशन, बस कोई पानी पी रहा है, बस उसको पीने दो. ठीक है, यू विल गिव व्हाट, यू विल गिव जस्ट ORS. बस इन केस ऑफ सम वी आल्सो गिव ORS, बट लेवल में आपको बताता हूँ कैसे क्या करना करके, और उनको घर भेज सकते हैं. ठीक है, घर भेज सकते हैं. ठीक है, देखो आपका बेटा का थोड़ा बहुत डिहाइड्रेशन तो है ही, आप ORS पिलाओ. अगर आपको जो भी डेंजर सेंस, अगर बच्चे नहीं खा रहा है, नहीं पी रहा, सीजर्स ऐसे कुछ आ रहा है, तब आप लेके आना. मीन्स इफ देयर इज एनी डेवलपमेंट ऑफ एनी ऑफ द डेंजर साइंस, लाइक इफ द चाइल्ड इज नॉट फीडिंग वेल, इफ द चाइल्ड इज बिकमिंग अनकॉन्शियस, और इफ इट इज बिकमिंग वेरी मच रेस्टलेस, तब आपको लेके आना है. ओके, रिमेंबर. So then, whereas if it is in a case of severe dehydration, you should refer to this pediatric available hospitality, and you should manage them. Okay, fine. And until unless it is lab confirmed, you won't give antibiotics. Okay, so we'll see how this main dehydration part can be done. See, in a case of plan A, इट इज नो डिहाइड्रेशन, कुछ भी नहीं है. ठीक है, कुछ भी नहीं है. ठीक है, लेकिन वो माँ कभी मानेगी बिल्कुल नहीं. ठीक है ना, सो द मदर वोंट एक्सेप्ट इट. सो व्हाट विल गिव, देयर इज अ नो डिहाइड्रेशन पार्ट, बट बिकॉज ऑफ द वॉमिटिंग देयर विल बी फ्लूइड्स कंपोनेंट विल बी लॉस्ट. So we need to replace the fluids with the ORS. We need to replace the fluids with ORS. Okay, we'll give 200 to 200 ml of ORS. So ORS, which is, we will tell them like 1 लीटर का बॉटल लो, और उसमें ORS का सैशेट, like just mix it, and whenever the baby asks, or whenever the baby goes for a loose stools, give them this ORS ka water. Okay, ORS ka water, fine. So this is one. Okay, this is to replace, matlab ulti ki, dobara pi, dobara ulti ki. So this will be the phenomena. When in a case of some dehydration, we'll give this plan B. Okay, what we'll do here also, we'll prefer giving this ORS, but with a more advanced, like with usual one, with ongoing loss will give, and along with this we need to give this drugs. For example, we'll need to give this fluids as 75 ml per kg. Okay, in first 4 hours we need to give 75 ml per kg for this child. Okay, because there will be more loss, and we need to replace this ongoing loss because the child will be having a level of some dehydration. Okay, in a case of severe dehydration, mostly मैंने बोला the child will be lethargic, so the child won't able to drink, so we need to give only IV. So we should start IV fluids in the case of plan C. ठीक है, plan B में the बच्चा is drinking water, so we'll go with ORS. ठीक है, तो पर केजी के हिसाब से 75 ml करके कैलकुलेट करेंगे, and if not, then we'll go for IV. Whereas in the case of plan C, straight away we'll start with IV fluids, and mostly we'll give the same ringer 5% dextrose with RL. Okay, 5% dextrose with RL means more preferred than compared to normal saline. ठीक है, फिर उसके बाद उसका मेंटेनेंस डोज देंगे. ठीक है, उसके पहले हम क्या करेंगे, उसका जो भी डिहाइड्रेशन कंपोनेंट को करेक्ट करने के लिए we'll use this formula. ठीक है, तो वी नीड टू गिव 100 ml per kg, ठीक है। तो उसमें if the child age of the child is less than 1 year, then what will give will split this 100 ml into 30 ml per kg and 70 ml per kg, ठीक है। ये 30 ml को हमें पहले 1 घंटे में देना है। if the child is less than 1 year will give within 1 hour, 1 hour less than 1 year 1 hour, and rest the 70 ml of kg, ठीक है। for example if the child is what, if the child is around, मान लो कि if the child is 4 kilogram, then it is 4 liters, like 4 kilograms, then it is 400 ml. तो 400 ml में see if it is a case of 400 ml, then per 30 kilogram 4 3s are 12, like around 120 ml will give in 1 hour, then rest will give in like next 5 hours, ठीक है। if it is more than 1 year, then will give total in within 3 hours only. so first 30 minutes में हम around 30 ml per kg देंगे, फिर उसके बाद हम 70 ml per kg करके इसको split करके देंगे, okay fine। and additionally what we'll do, will give this dose of zinc, ठीक है। हमें पता है if there is diarrhea होता है, then this superficial epithelium, ठीक है, this superficial epithelium it will erodes of this and comes off. so ये epithelial को अच्छा करना, मतलब this epithelium should regrow. so for this regrowth will give zinc as a supplement, and zinc supplement if the child is between 2 to 6 months of age, फिर उसको हम 10 mg per kg per day देंगे। अगर if it is more than 6 months, फिर हम 20 mg per day के हिसाब से देंगे, ठीक है, बस इतना ही। if it less than 6 months, then it is what, then it is 10 mg per day, and if it is more than 6 months, it is 20 milligram per day, ठीक है। yeah, and finally, ठीक है, we need to give, means these are this for this dehydration component। फिर उसके बाद उसको तो daily doses of usual fluids भी चाहिए ना, तो उसको कैलकुलेट करने के लिए हम ये हॉलिडे सिगर फॉर्मूला यूज करेंगे। फॉर एग्जांपल if the baby weight is 5 kilogram, then we'll use just like 100 ml per kg, so it is 500 ml. whereas if it is more than, if it is 0 to 10 kilogram, then we'll use 100 ml per kg। अगर जो भी आपका उसके बाद अगर if it is 11th kilogram to this 90 to 20th kilogram, तो हम extra 50 ml। for example if the child weight is 10 kilogram, तो 1 लीटर देंगे, ठीक है। फिर उसके बाद if it is more 1, will multiply is with 50, okay। तो क्या है, तो it is 1050 ml, ठीक है। and if the child is, if it is more than 20 किलोग्राम, फिर उसके बाकी 1-1 किलो के लिए हम 20-20 ml का वाटर देंगे। 20-20 ml का 20-20 ml will increase if it is after more than 20। see if it is within 0 to 10 kilogram, will give 100 ml per kg। after each 1 kilogram of weight, then we'll give add 50 ml per kg, and if it is more than 20 kilogram, then we'll add plus 20 ml per kilogram wise, ठीक है। तो it is the formula for this maintenance fluid calculation, ठीक है। then we'll come to a few extra aids in the pediatric part। extra aids में क्या क्या देखेंगे, if you see there are few congenital infections which can result into this changes into the child, ठीक है। क्या क्या हो सकता है, we'll call them as torch infections। टॉक्सोप्लाज्मियासिस में हमें हाइड्रोसेफलस मिलेगा, कोरिया रेटिनाइटिस मिलेगा, और पैरेन्काइमल कैल्सिफिकेशन। सी मोस्ट ऑफ देम दे विल बी हैविंग दिस सीएनएस कैल्सिफिकेशंस, लेकिन आपको डिफरेंशिएट करना होगा। सी दिस टॉक्सोप्लाज्मासिस, ओके, टॉक्सोप्लाज्मासिस, देन इट विल बी व्हाट, देन विल बी हैविंग दिस पैरेन्काइमल कैल्सिफिकेशंस, ठीक है। अबाउट 15 kg, सी इफ द चाइल्ड इज 15 kg, देन split first 10 kg, then 5 kg। तो फर्स्ट 10 kg के लिए हम 100 ml के हिसाब से देंगे, तो 10 into 100 1000 ml। देन नेक्स्ट 5 kg के लिए 50 के हिसाब से देंगे, तो इट इज 250 ml, ठीक है। सो दिस विल बी व्हाट, दिस विल बी 1250 ml, ठीक है। 1250 ml हम देंगे, ठीक है। यू गॉट इट राइट, आई गेस, ओके, फॉर दिस डे। yeah, good Dr. Ansh, yeah, good, you have good mathematical skills, yeah, good, fine। then in a case of Zika virus infections, you know, like they will tell the history that they are living in Kerala, or mostly they are living in where, in a case of Malaysia, where there is a availability of this palm sap, ठीक है ना। Kerala there will be kallu will be available, where if you are able to drink this kallu or this like from this palm sap or this coconut sap, they will be secreting this liquids which is being contaminated with the bats. It will lead to this feature which is known as what, microcephaly, okay, microcephaly। I will tell you what is vulnerability disease, wait till dermatology, fine, just wait, okay। then if you see about this Zika disease, you will be able to see there is a presence of contractions also present, and there will be calcification at the level of gray matter and white matter junction. It is simple, nothing, it is the tuberous sclerosis Bonnevelli means, okay, don't worry। then varicella, there will be presence of cicatricial scarring, and along with this there will be features of limb hypoplasia, limb will be hypoplastic in a case of varicella, like the simple chicken pox one, okay। then for this, if there is susceptible, then if the if it is being infected just 5 days before delivery or 2 days after delivery, then we need to give varicella immunoglobulin. We need to give varicella immunoglobulin. Yeah, that is HHV3. Good guys. Then about HSV, it will be having mostly, it will cause this skin infection sometimes, or mostly it will cause encephalitis in the neonates. Fine. And parvovirus B19, हमें पता है, it will cause non-human fetalis hydrops. Okay, non-human hydrops fetalis. Then it can cause this aplasia as well. ठीक है, pure red cell aplasia, याद रखो. Okay. Then about next syndrome, which is this congenital rubella syndrome, it will be associated with this cardiac defect, and there will be presence of this deafness. Okay, and there is a presence of cataract. So your main senses, like your feelings on the heart, it will be affected in the case of rubella. Okay, then your eyes, means you used to see the ruby, so your eyes will be affected, and you will able to hear the voice of ruby. So all of this thing will be affected. So there will be a deafness, cataract, and yeah, and there will be PDA. Yeah, प्यार में दिल टूटा, प्यार के बाद there will be अंधा, बेरा and दिल टूटा. Okay, the three things. Okay, so there will be features of this eye and ear and the heart one. Okay, and then eye also you will able to see this salt pepper retinopathy, and in skin you will able to see this blueberry muffin rash. Okay, kind of muffins, there will be this small blue color का rash होता. ठीक है, blueberry जानते हैं ना, तो वैसे थोड़ा बहुत. ठीक है. Then about the CMV, there will be presence of this CMV small. Okay, there will be CMV small wala. So small head will be there. It is known as microcephaly, and it is associated with this periventricular calcification. It will be associated with this periventricular calcification. ठीक है, याद रखो. So these are the things. Yeah, पहले के प्यार में अंधा बहरा और बच्चा नहीं, बच्चा बस ना हो. ठीक है. Then it is the CMV. Then just remember, this is all about this pediatric part. Means for everything in your life, like it is just take for this FMGE examination or everything in the life. Like isonic means you think like यार नहीं होगा यार, उसका नहीं हुआ. Don't compare everything to the other sides, because तुम अलग हो, you are unique. Okay, so as you are unique, you need to work on yourself, and you know only your potential. So don't think of others and don't compare yourself with others. ठीक है, और ऐसे नहीं सोचना है ठीक है यार कल से रिवीजन चालू करेंगे, कल से क्वेश्चन लगाना चालू करेंगे. I will start from tomorrow. நாளையில இருந்து क्वेश्चन पढ़லாம். So when this tomorrow, it's never come. Okay, so just try to start as early as possible and start today. Okay, so just have a start, you will be great for sure, and you will pass this examination for sure. Okay, have this mindset. फिर उसके बाद आगे बढ़ते हैं next subject. Yeah, tomorrow never comes. And tomorrow I also won't come. Today is the last day for me. Okay, for this session. No break. Okay, what is the time? It is 11:52, right? We'll complete psychiatry and we'll take a break at 12:15. Okay, yeah, psychiatry we'll take. Yeah, exam will come. Yeah, for sure. Fine. We'll take our break around 12:15. Psychiatry wala. Okay, it is just very small. I guess very small. Okay, and if not also, we'll take around 12:15. We'll have the break. Okay, that will be our start. Okay guys, we'll start with this psychiatry part of our game changer session. The first thing you need to know is about this antipsychotic drugs. This antipsychotic drugs, if you see, it is integrated with both pharmacology and psychiatry. Okay, तो मैं both in and out आपको जानना चाहिए. ठीक है, first psychiatry तो वैसे easy peasy है. ठीक है, so if you see about this antipsychotic drugs, like this antipsychotic drugs, हमें पता है the psychotic, it is due to this increased level of dopamine. ठीक है, तो here हमें डोपामिन को ब्लॉक करना और डोपामिन को हमें कम करना. ठीक है, डोपामिन को हमें कम करना. सो दिस इज द यूजुअल थिंग ऑफ दिस व्हाट दिस टिपिकल एंटीसाइकोटिक ड्रग्स डू. ओके, दैट टिपिकल एंटीसाइकोटिक सही करता है, लेकिन दिस एंटीसाइकोटिक्स इट मे कॉज फ्यू साइड इफेक्ट्स एंड इट कैन बी एसोसिएटेड विद दिस अदर सेरोटोनिन फीचर्स एज वेल. ठीक है, तो उसी वक्त हम क्या करेंगे, हम एटिपिकल, नाउ वी स्टार्टेड यूजिंग दिस एटिपिकल एंटीसाइकोटिक्स बिकॉज ऑफ दिस टिपिकल साइकोटिक्स का साइड इफेक्ट्स की वजह से. तो व्हाट आर द टिपिकल साइड इफेक्ट्स आर टिपिकल एंटीसाइकोटिक ड्रग्स. दिस इंक्लूड्स अवर D2 blockers. ठीक है, डोपामिन रिसेप्टर D2 blockers which is this haloperidol and weak D2 blockers which is this chlorpromazine. So two drugs, haloperidol, chlorpromazine, ये दोनों तो आपको याद रखना ही रखना. ठीक है, पर बाकी जो भी पढ़ेंगे it will be come under this atypical side effect. Yeah, clozapine, olanzapine, ziprasidone, सारे हम पढ़ेंगे. ठीक है, रुक जाओ. ठीक है, देन अबाउट व्हाट इज द साइड इफेक्ट. ठीक है, इसको हमने ज्यादा यूज नहीं करते हैं क्योंकि इसका साइड इफेक्ट है. क्या साइड इफेक्ट हो सकता है. ठीक है, फर्स्ट द मोस्ट कॉमन साइड इफेक्ट इट इज द akathisia. ठीक है, देयर विल बी पीपल राइट, लाइक देयर विल बी शेकिंग, लाइक they will be always restless. ठीक है, they will be always restless. So this kind of restless feature after taking this kind of drug, it is what it is, this after taking this kind of typical antipsychotic drugs, it is known as akathisia. It is the inner sense of restless. It is tremors, like it's not exactly tremors, like they will feel like kuch ho raha hai, ठीक है, they will feel restless, they won't sit in a small place, in a single place they won't sit, like जैसे हाथ कांप रहा है ना, तो वैसे they will be having this inner sense of restlessness, ठीक है, it is known as akathisia. और इसको ट्रीट करने के लिए हम क्या करेंगे, प्रोपरनॉल देंगे, इसको ट्रीट करने के लिए हम प्रोपरनॉल देंगे, ठीक है. देन बिकॉज ऑफ this antipsychotic drugs, it can go on decrease the acetylcholine, okay, and it means and it also go on decrease. हम डोपामिन को ब्लॉक कर रहे हैं, अगर डोपामिन ज्यादा हो गया तो इट लीड्स टू साइकोसिस, अगर डोपामिन कम हो गया इट विल कॉज पार्किंसोनिज्म, एंड इट इज नोन एज ड्रग इंड्यूस्ड पार्किंसोनिज्म. एंड इन केस ऑफ ड्रग इंड्यूस्ड पार्किंसोनिज्म हम क्या देंगे, हम एसिटाइलकोलिन, मतलब हम पैरासिम्पैथेटिक ड्रग्स देंगे, एग्जांपल benzoxal, especially the benzoxal bipyridine, which also known as was trihexaphenadiol, which is the benzoxal. Remember, it is benzoxal will give in a case of dystonias and parkinsonisms. Okay, dystonias and parkinsonism के लिए हम benzoxal देंगे, ठीक है. Then about this tardive dyskinesia, there will be this odd facial expressions, or there will be this sounds and tics will be produced, and for them we'll use this valbenazine. Okay, तो tardive dyskinesia के लिए हम क्या करेंगे, the same TV, it is the valbenazine will use. Then there is one more syndrome. After using the drugs, the patient will be started having this fever. There will be a fever will be there, and there will be this elevated liver enzymes, okay, and elevated neutrophil count, and along with this CPK counts will be elevated. So all of this thing will be suggesting of a condition which is known as neuroleptic malignant syndrome. Neuroleptic malignant syndrome. और उसको ट्रीट करने के लिए हम क्या देंगे, dantrolene देंगे. So neuroleptic malignant syndrome के लिए हम dantrolene देंगे, akathisia के लिए propranolol देंगे, पार्किंसोनिज्म के लिए हम बेंजोहेक्सोल देंगे, ठीक है, और टार्डिव डिस्काइनेसिया और डिस्टोनिया के लिए हम यूजुअली क्या देंगे, बेंजोहेक्सोल देंगे, ठीक है. सॉरी. नेक्स्ट अबाउट द नेक्स्ट ड्रग व्हिच इज दिस टिपिकल एंटीसाइकोटिक्स. ओके, टिपिकल एंटीसाइकोटिक्स क्या करेगा, इट आल्सो विल गो ऑन ब्लॉक दिस डोपामिन रिसेप्टर्स, और इट विल टेक केयर ऑफ दिस अदर रिसेप्टर्स एज वेल. तो क्या क्या है, यू कैन रेफर दिस रोस CQ और cos or Q. Okay, cos clozapine, like risperidone, olanzapine, ziprasidone, and clozapine and aripiprazole. Rosca, or else you can remember. Okay, just forget what is this exact one. So remember, it is this Rosca. It is what? It is this. Yeah, Cos-Rock. Yeah, good, Dr. Hans. It is what? It is the Cos-RAQ. Yeah, it is the Cos-RAQ. Okay, it is Cos-5. Thank you. It is Cos-RAQ. So see, this it is what it is, this olanzapine, clozapine, olanzapine, clozapine, olanzapine, then ziprasidone, clozapine, olanzapine. Yeah, clozapine is an atypical one. So now we are discussing about the atypical. ठीक है, तो typical one it will just go and block this dopamine receptor. तो इसलिए इतने सारा side effects है. तो now हम क्या करेंगे, तो dopamine को भी block करेंगे, फिर उसके साथ साथ जो भी है, जो भी extra added है उसको भी हम block करेंगे. ठीक है, इतना याद रखो. ठीक है, so here it will be clozapine, olanzapine, ziprasidone, risperidone, aripiprazole and 𝗏𝗏𝗏. Aripiprazole and 𝗏𝗏𝗏. So these are the drugs which will be classified as typical antipsychotics. और typical antipsychotics के भी side effects होते हैं, लेकिन it will be of other system side effects, like systemic side effects, like there is elevated level of sugar, hyperglycemia होगा, there will be increased weight causing this obesity, and there will be sedation. So sedation, weight increase, and there will be increased sugar which is hyperglycemia. ठीक है, and the next one it is the this clozapine. It is the drug of choice for this treatment resistant schizophrenia. I will tell you what is this treatment resistant schizophrenia. आप बस इतना याद रखो, treatment resistant schizophrenia और schizophrenia with suicide tendency, ये सब के लिए हम क्या देंगे, clozapine देंगे, हम clozapine देंगे. and remember, and this causes this maximum weight gain, it causes the maximum weight gain. ठीक है, और इसमें ये क्या क्या कर सकता है ना, ये दिल को और दिमाग को, ठीक है, it will affect both heart and the CNS. So that's why it will cause myocarditis, ठीक है, and seizures. Myocarditis and seizures will be caused by this clozapine, and it will cause one more thing which is known as what, agranulocytosis. Okay, it will increase, this means it will decrease the level of this, especially this granulocytes, like okay, neutrophils. Okay, agranulocytosis, which is one of the most dangerous complication. ठीक है, और जो भी इसके साथ साथ जो agranulocytosis करता है, उस ड्रग्स को इसके साथ हम नहीं देंगे. ठीक है, So this is a typical and atypical one. Atypical में तुम्हें बस drugs याद रखना, which is cos-rock, which is this clozapine, olanzapine, ziprasidone, and risperidone, aripiprazole, and quetiapine. Okay. Then the side effects which include dimaco or dilco. Okay, it is what it is, this seizures and myocarditis, and along with this blood, which is this A granulocytosis, and it will cause this maximum weight gain. It will cause this maximum weight gain. Fine. So remember all these points. फिर उसके बाद आते हैं डिप्रेशन का ड्रग्स, ठीक है, जो हमें अभी जरूरत है, ठीक है, ठीक है. So see if about this drugs of the depression, which includes this SSRI, TCA, and SARI. See this typical typical मतलब we usually used to use previous times. Now we have this reduced their use. The typical which includes this MAO inhibitors, which is this 𝗏𝗏𝗏. Okay, MAO inhibitor, which is this 𝗏𝗏𝗏. बस इतना याद रखो. Next one we used to use before the TCA, but we are reducing this use because of its side effect. TCA मतलब tricyclic antidepressants. Tricyclic antidepressants. Okay, it will act on these three receptors. Fine, and it include imipramine, dacipramine, imi, and ami. Imi, daci, ami, and nortriptamine. Okay, imipramine, dacipramine, and amitriptyline, and nortriptyline. Amitriptyline, nortriptyline. Imi is a daci. Okay, imipramine, dacipramine, amitriptyline, and nortriptyline. And what are the side effects? The side effects which include, if it blocks this acetylcholine receptors, it will result into this dry mouth, like daturame, dry mouth, blood visions, and it is contraindicated in the case of glaucoma. ठीक है, तो इसीलिए it is contraindicated in the case of glaucoma में, ठीक है, and it can lead to this posterior hypotension and sedation. And the most lethal वाला क्या हो सकता है ना, it can cause this heart involvement causing arrhythmias, and the major thing which is this metabolic acidosis. ये क्या करा सकता है, metabolic acidosis. तो इसीलिए to treat this TCA toxicity we'll use sodium bicarbonate. There will be a history. There is a patient who is on there is a patient who is presenting with features of depression. As a psychiatrist, you started with a TCA drug, and now the patient is presenting with metabolic acidosis. What is the next line of management you will give? You will give this sodium bicarbonate. ठीक है, sodium bicarbonate. ठीक है, इतना याद रखो. We will give sodium bicarbonate to correct this metabolic acidosis part. फिर उसके बाद है SNRI, सेलेक्टिव नॉरएड्रेनालिन रीअपटेक इंहिबिटर्स. ठीक है, ये नॉरएड्रेनालिन को रीअपटेक करने में इंहिबिट करना, तो इसीलिए उसमें नॉरएड्रेनालिन का लेवल और सेरोटोनिन का लेवल दोनों बढ़ जाता है. ठीक है, दोनों बढ़ जाते हैं. ठीक है, तो इट इज द ड्रग ऑफ चॉइस फॉर सीवियर डिप्रेशन. इट इज द ड्रग ऑफ चॉइस फॉर सीवियर डिप्रेशन. वरस यूजुअल के लिए हम SSRI यूज करेंगे, वो हम देखेंगे. ठीक है, वरस फॉर सीवियर डिप्रेशन इट इज दिस SNRI. It is the severe depression, which includes mainly venlafaxine, duloxetine, and desvenlafaxine. Venlafaxine, duloxetine, and desvenlafaxine. These are the three drugs which are come under this SNRI, which used for this severe depression. ठीक है, फिर उसके बाद आगे बढ़ते हैं SSRI. So all the cases of this selective serotonin reuptake inhibitors will use these drugs. Like all the cases of this depression and few other conditions will use this SSRI. So this includes fluoxetine, fluoxamine, and citalopram. Okay, fluoxetine, fluoxamine, and citalopram. Fine. And this drug will be having this sexual side effect. So because of having the sexual side effect, okay, will use for this sexual treatment. For example, if there is premature ejaculation, this drug what will do this as a sexual side effect in females, it will decrease the libido part. And males it will delay the ejaculation. So we'll use them as a treatment for delayed ejaculation. So SSRI maybe will use especially this depoxetine. Okay, depoxetine is used for delaying the ejaculation. Okay, remember depoxetine delays ejaculation, तो इसीलिए इसको हम premature ejaculation में यूज करेंगे. ठीक है, and SSRI I told it is the drug of choice for this most of the depression, which includes this mild and moderate. ठीक है, severe के लिए हम SNRI यूज करेंगे like venlafaxine. Okay, and SSRI it is also drug of choice for this generalized anxiety, OCD, bulimias, phobias, PTSD, and impulse control disorder. ठीक है, and it causes delayed ejaculation, तो इसीलिए हम depoxetine को हम प्रीमेच्योर एजैक्शन के लिए यूज करेंगे. ठीक है, एंड इट कैन लीड टू दिस सिंड्रोम व्हिच इज नोन एज डिसकंटिन्यूएशन सिंड्रोम. ठीक है, जैसे आप SSRI लेना छोड़ दोगे, यू विल बी एबल टू सी दिस डिसकंटिन्यूएशन सिंड्रोम व्हिच विल बी हैविंग दिस फ्लू लाइक इलनेस. ठीक है, जैसे नेजल स्टफीनेस हो जाएगा, ऐसे होगा. ठीक है, इट इज नोन एज डिसकंटिन्यूएशन सिंड्रोम. ठीक है, एंड देयर आर फ्यू मोर एटिपिकल एंटीडिप्रेसेंट्स व्हिच इंक्लूड bupropion. ठीक है, वी नो दिस mnemonic like bupropion and sutopion. Okay, so this bupropion is used as an anti-smoking drugs, and then
Amitriptyline, it inhibits reuptake of 5-hydroxytryptamine, the same with trinipon. So remember in this, remember mainly about this bupropion and vortioxetine. Okay, these two drugs. And in a case of severe depression, which is resistant to these drugs, then we can try with this ketamine. Okay, our anesthesia ketamine, which as a nasal spray, which is known as ketamine, it is used as a nasal spray. Fine. And this brexanolone, which is used as a postpartum depression. Okay, postpartum depression में हम brexanolone देते हैं, brexanolone हम देंगे. ठीक है, इतना याद रखो. Then about this schizophrenia component. Fine. Okay, schizophrenia. If you see about the schizophrenia, we need to know there are different types of schizophrenia. Mostly what they will give this diagnosis. Like they will ask you to diagnose this schizophrenia component. How will you diagnose? See, there will be what? There will be telling there is a patient who is having these features of hallucination. Okay, he's seeing new things. He's able to see, able to hear sounds, auditory hallucinations. Okay, and his personality is well preserved. Okay, his personality is well preserved, and yeah, the criteria is more than 6 months. It should be present. Okay, his personality is well preserved, along with this strong belief that Russian agency is spying on him, or this Chinese agency is spying on him, and he's having this presentation of hallucinations. So all of this thing will be typical for this type of schizophrenia, which is known as paranoid type. Means paranoid mein personality will be preserved. Whereas in the case of catatonic, if you see, catatonic will be having this motor movements, like this 𝗵𝗲𝗀𝗀𝗀 flexibility and catalepsy. 𝗵𝗲𝗀𝗀𝗀𝗀, catalepsy, all of these things, they are the motor features, are grimacing, odd movements, it is known as grimacing. These are these features which is seen in a case of catatonic schizophrenia, and it will be have the best prognosis. ठीक है, अगर किसी को कैटाफ्रीनिया बहुत बढ़िया, ठीक है ना, उसको बेस्ट प्रोग्नोसिस है when we treat it. Next one is known as 𝗵𝗵phrenic schizophrenia. 𝗵𝗵phrenic will be having this negative symptoms, and there will be severe deterioration of this personality along with the bad habits. Okay, remember 𝗵𝗵phrenic, it is the severe deterioration, okay, with bad prognosis, and personality will not be maintained. Okay, बहुत गंदा. Okay, 𝗵𝗵phrenic, it is the ganda one, and it will be having this ganda prognosis. Remember, and next it is the residual one. Okay, from an early stage of division to this लेटेस्ट स्टेज विथ मोर नेगेटिव, मतलब ईयरली में जो भी पॉजिटिव सिम्टम्स, फॉर एग्जांपल हैलुसिनेशन हो गया, डिल्यूशन हो गया, वो ईयरली में, मतलब पहले बहुत अच्छा, जैसे इन एवरी पार्ट ऑफ रिलेशनशिप एवरीथिंग लुक्स वेरी मच ब्यूटीफुल. ठीक है, तुम हंस रहे हो, बहुत अच्छा लग रहा है. ठीक है ना, तो देन तुम रो रही हो, मतलब ये भी बहुत अच्छा लग रहा है. देन लेटर ऑन you will feel the change. So the initial part you will able to see the in yearly pace there will be more type of positive symptoms like delusion and hallucination, and then in later part you will able to see this 𝗚𝗚𝗀𝗀𝗀𝗃, okay, evaluation. So all of these negative symptoms to be coming up. Okay, so it is known as residual schizophrenia. Okay, and finally it is a simple schizophrenia which happens with mostly of negative symptoms. It looks simple, but it is very complex because of its negative symptoms. Okay, remember. Okay, and it has the worst prognosis. So 𝗵𝗵phrenic, it will be having this bad personality but bad prognosis, whereas worst will be what will be the simplest guys are the worst guys. Okay, and next, this schizophrenia, once you treat, you think the patient is recovering, but at certain point of time while recovering itself, what will happen? There will be an increased risk of suicide. Okay, the patient will be good till yesterday. Once you discharge him, he will go and jump from the 5th floor and he will die. Okay, so this type of suicides will be associated with this post schizophrenic depression. Okay, and there are few other types of schizophrenia which include prof schizophrenia, which is seen in a case of mental retardation along with schizophrenia. So prof, which is schizophrenia with mental retardation, and von Gogh schizophrenia, which is presenting with this self-mutilation, like Lee-Snehal syndrome, we'll be able to see this self-mutilation. Likewise, the von Berg, there will be schizophrenia patient, he'll be eating his nail, eating his finger, eating his ears. Okay, so this is this von Gogh syndrome. Whereas Onirad means it is a dream-like state. So this is a dream-like schizophrenia. That is 𝗔𝗵𝗔 deficiency. Good. Right? Yeah, in adolescent age, there will be, you will be able to see one more thing which is known as copycat suicide. Good guys. Then what are the symptoms you will tell that he is having schizophrenia? Those Shinadin proposed this 11 first rank symptoms. This include 3 thought phenomena. Someone is inserting thought, or someone is checking how to start, or someone is broadcasting. ठीक है, वो सोच रहा है कि अभी noodles बनाऊंगा, तो someone is broadcasting there is a noodles making video. So it is what? It is three: thought insertion, thought withdrawal, and thought broadcast. And made phenomena, he made to do it. Okay, your father made to study MBBS. Okay, this is the made phenomena. And made effect, he made to change my mood. Okay, and he made to make this impulsive act. Fine. And three audible hallucinations, the voice, two voices, first they will argue and they will give running commentary. ठीक है, वो अभी गेम चेंजर सेशन देख रहा है, फिर इसके बाद अभी चाय पीने जाएगा, ठीक है, फिर उसके बाद वो दोबारा गेम चेंजर सेशन देखेगा, फिर शाम को आकर रिवीजन करेगा, फिर PAQ करेगा, फिर एग्जाम में पास होगा. तो दिस विल बी द वॉइस विल बी गिविंग दिस रनिंग कमेंट्री. ठीक है, वेयर इज ऑडिबल थॉट्स, अभी मैं पढ़ रहा हूँ. ठीक है, मींस अभी मैं पढ़ रहा हूँ, तो व्हाट एवर थॉट्स यू आर थिंकिंग, it is audible to you. It is known as audible thoughts. So what are the three auditory hallucinations? The voice will be arguing. ठीक है, वो ये सेशन देख रहा है, वो बढ़िया पढ़ रहा है, अच्छा पढ़ रहा है, तो two of them they will be arguing. ठीक है, and the voice giving running commentary as what you are doing. Okay, yeah, like it is just simple explanation, nothing. Like auditory hallucinations, what you will do, initially will talk, like two voices will be talking about you, like you are studying well, yeah, wow, how he is studying, see how he is changing the page, how she is looking beautiful today. Likewise, two people will be arguing, like arguing. It is known as what? It is known as auditory hallucinations का one part. Second part, they will give you running commentary. ठीक है, she is watching this series, game changer series, she will be doing a questions, she will be passing the examination. Likewise, then about the third one, it is audible thoughts, like whatever thought you think, it will be audible to you. So these are the three auditory hallucinations. Okay, paravala, sorry, fine. Then next there will be this two more things which is known as somatic passivity and delusional perception. Somatic passivity and delusional perception, like when you see this phone, you remember that you are having the test. So likewise, you will be having delusion which is associated with this perception. ठीक है, fine. Next about this treatment of this schizophrenia का usually हम treatment कैसे करते हैं? देखो, means in a case of treating schizophrenia, you will start with atypical antipsychotics. देखे थे RASQ, like clozapine, except clozapine, olanzapine. ठीक है, except clozapine, olanzapine, तो risperidone है, ziprasidone है. We'll start with them. Then after 6 weeks हम देखेंगे. Means after 6 weeks we'll check whether this drug is working for him or not. Okay. So after, yeah, good Dr. Anna, it is this rest drugs. Okay. Then we'll check whether this drug is working for him or not. फिर उसके बाद हम क्या करेंगे? अगर if it is not working, then we'll change to another atypical antipsychotics. ठीक है ना, we have this RASQ drugs, except 2 drugs, we have more 4 drugs. So we'll change them. So we'll see for more 16 weeks. So after see, this is the 6 weeks. After 6 weeks, if after 12 weeks itself, if it is not resolving, then we'll change them into this typical antipsychotics, which include haloperidol or fluoxetine. Okay, we'll change them into a typical antipsychotics. Then we'll see for 6 more months. If nothing works, then we'll change into clozapine. So if it is resistant to this 3, means these 3 weeks, 3 steps of treatment, which is the 3 drugs, like 2 types of atypical drugs and 1 type of typical antipsychotic drugs. Okay, for this 18 weeks, तब हम बोलेंगे it is known as resistant schizophrenia, or in a case of resistant schizophrenia, we'll treat them with clozapine. And in a case of clozapine resistant schizophrenia, हम ECT देंगे, means हम shock देंगे. ठीक है, इतना याद रखो. Then about this drug, which is the lithium. Okay, this is the lithium. See about this lithium, if you see the half-life of lithium, it is what? It is this around 24 hours, about 24 hours. Okay, the half-life of lithium is 24 hours. Okay, and sometimes this lithium may cause toxicity, and the toxicity usually comes with nausea, vomiting, sometimes associated with diarrhea, then ataxia, okay, and dysarthria. Mainly it will come with tremors. It will come with this tremors. Okay, this tremors. And as we saw in pediatrics part, this type of lithium intake during this pregnancy can cause this atrialization of ventricle. It is known as what? It is known as Epstein's anomaly. A good Dr. 𝗵𝗶𝗀𝗆. It is what it is. This Epstein's anomaly. It is the atrialization. Yeah, lateralization of this ventricle. Okay, and we'll produce this box-shaped hearse. Okay, and we need to know about this because this can lead to this toxicity. So we need to know and we need to monitor the drugs. So it is one of the drug where we do this therapeutic dose monitoring. Will we do this therapeutic dose monitoring? Remember, fine. And next, if you see what are the plasma concentration which we'll use. For example, for treatment of this acute attack of mania, we'll use 1 to 1.5 milliequivalent of concentration, whereas for maintenance it is around 0.8, which is 0.6 to 1.2, whereas for toxicity when we'll tell if it is more than 1.5. So remember, till treatment will use 1.5. If just more than 1.5, we'll tell them it is toxic. Okay, and if it is more than 3, it will cause permanent neurological damage. It will cause permanent neurological damage, and okay, and it may require dialysis. And if it is more than 4, it can lead to death. Okay, so what are the for what it is being treated? We can treat them for the acute episodes of mania, or we can prophylaxis also we can use this lithium one. Okay, and this bipolar disorder also will use lithium. We'll use bipolar disorder also, will use this lithium. Okay, and remember about this Epstein's anomaly in a case of lithium. Okay, and remember about this Epstein's anomaly. Okay, and this can also even lead to this lithium induced diabetes insipidus. Okay, usually in a case of diabetes insipidus, we'll give amyloid as a treatment, whereas here we'll give thiazide diuretics as a treatment, whereas in a case of lithium induced diabetes insipidus, we'll use amloride. Okay, remember. Yeah, good, Dr. Ansh. Next, we'll move on to this few toxicity and withdrawal symptoms. Yeah, it is means it is name itself, it is lithium induced. Okay, it's mostly at the nephrogenic level. Okay, nephrogenic. Yeah, good, Dr. Ansh. See, and next about this drugs like opioid and alcohol, we already seen in forensic medicine. So just I don't want to repeat them so that you will get these things same. So I added few more drugs. For example, you need to know about this cannabis. Cannabis we already saw, it is this Indian hemp which will be having this active compound which is known as tetrahydrocannabinol, and it is the most common illegally used drug. Okay, most common illegally used drug in India. Okay, most common illegally used drug in India. Good guys. Then this cannabis can lead to this synesthesia, means crossover of sensations. I can see the music. Okay, I can hear the camera. Okay, so like this will be there. So the two sensations which is being having mixed, it is known as synesthesia. And sometimes this what will happen is this, they will tell this beat you yaar, beat you. So this bad trip will be usually seen in the case of cannabis. Okay, if like you plan to do these things to enjoy, but you returned with a horrible experience. Okay, good. Yeah. Thank you, Dr. Rajneesh. Okay, it feels very much immense to have you here, and thank you for motivating. And next, you will be able to see this one more phenomena which is known as flashback phenomena. Means what is this flashback phenomena? Okay, no, you or your friend, you abused cannabis 2 days back. Okay, they abused 2 days back, but now you feel this usage of this cannabis, or you will feel this euphoria without using the cannabis, because this cannabis they will go and store into this adipose tissue. It will go and store into this adipose tissue. Okay, so that way it produces this phenomena which is known as flashback phenomena, and it will produce one more phenomena. One more thing which is known as run amok. Means run amok means the patient will be like this normal only, but because of this cannabis induced psychosis, he will go with rage and anger. He will do anything, like he will in Tamil Nadu happened one thing with this euphoria. He drove this bus from a bus stand to this police station. ठीक है ना, अगर बस चलाना है तो like road पे चला लो यार, क्यों police station के क्यों लेके आ जाना है, ठीक है. So he drove like this. So he did like some others, they will do this killing. Okay, they will make others to die also in this run amok phenomena, and so and after this they will feel, yeah, I'm nothing, like I'm unable to remember this pharmacology, what I will do, how I will pass the examination. They will feel this amotivational. So all of these things, bad trip, flashback phenomena, run amok, and amotivational syndrome, all of this thing will be seen in a case of cannabis. Okay, cannabis. Okay, and about next one which is known as phencyclidine, which is known as angel's dust. Angel's dust, just remember one thing, it will block NMDA receptor, and it will be similar to schizophrenia. It will be yeah. That is one more angel. Like that is not typical angel, it is sophisticated angel. That is angel mosquito. Okay, which will be having the spots on their wings. It is angel dust. Okay, na? There is star dust. Okay, likewise it is angel dust. Okay, next about this amphetamines. If you see about this amphetamines, like usually you need to know, it also mimics some kind of delusions, or it can even results into this formation of these delusions. Okay, there will be presence of this paranoid delusions, like there will be a suspicion. Okay, delusion of persecution. Okay, the Othalo syndrome. Okay, Othalo syndrome. Okay, and this auditory hallucinations even seen in a case of amphetamines use. Okay, amphetamines use. Fine. Next about this tobacco, it is the most common substance used in India before. Like now, there is some controversies. It will be more than alcohol. Will you are using tobacco more than alcohol? It is based on recent studies, but okay, just have it. Yeah. That is the jealousy. Yeah, jealousy. It is Othello syndrome. Good. And we know in a case of De-Clermont syndrome, also known as fantasy lover syndrome. Okay. It is what? It is the delusion of love. It is a delusion of love. Pyar ki chakkar. Okay. Then this is the tobacco one. Yeah, Dilbag. Yeah. Then about this tobacco, there will be withdrawal of this tobacco. Means उसको तो सुट्टा चाहिए. So after 2 hours he'll be having this withdrawal symptoms. So उसके लिए हम nicotine replacement therapy और medication देंगे, और will give in the sense of gums, patches, inhalers and sprays. and medications में हम bupropion, sotopion वो हम दे सकते हैं, या clonidine, nortriptyline and varenicline. So 2 drugs you should know. One is this bupropion and varenicline. Okay, this also I have written in a separate one, because this anti-smoking drugs they ask in each and every examination. So don't forget about OCD. You know, it is this recurrent thought like hath dhona, means you need to wash your hands. It will be producing this intrusive thoughts. So you will be having this recurrent intrusive thoughts. Okay, or impulses. Or if you didn't do this hand washing, then you will be having this anxiety. So you will be having this anxiety. So it is known as what? It is known as obsession. Whereas compulsion, जैसे आपने हाथ धो लिया, when you wash the hands, you will have this sense of satisfactions, or this thing which you do to suppress it. Okay, and you know it is you are not doing correct. ठीक है ना? जैसे आपका हाथ तो गंदा नहीं है, means your hand is clear, it is not contaminated, but you still these thoughts are coming and disturbing you. So you feel it is disturbing for you. It is ego dystonic. Yeah, good, Dr. Rituraj. Fine. Next, yeah. Then it will be decreased by this compulsion. Okay, you will perform in response to this obsession. Fine. And symptoms, it should persist for 2 weeks to make a diagnosis. हमें पता है, for this we can use SSRI as a treatment. Okay, and it can be associated with depression. ठीक है, ये मैं क्यों नहीं कर रहा हूँ? देखिए, why I am washing these hands for this much long. Fine. And for pharmacotherapy you can use SSRI, and for psychotherapy you can use cognitive behavioral therapy, like exposure and response prevention is the best modality, or else there will be this flooding will be there. Likewise you can use. Okay, just remember, mainly this cognitive behavioral therapy, especially this export, you just make his hand ganda and you tell, don't wash for a while, see what happens. Nothing will happen. Likewise you will expose and you will prevent his response. Okay, yeah, good, Dr. Ansh, good. They're still washing. About this eating disorders, you should know. Eating disorders, there are different types, but you should know these 2 difference between is anorexia and bulimia nervosa. Anorexia nervosa mein, you see, there will be a presence of weight loss, so the BMI will be decreased. बस इतना याद रखो. There will be features of there is a female who is thinking she is motive, means she is fatter than usual. She is fatter than usual. So, but she is actually slim. Okay, she is fatter than usual. So, but she stopped eating things. And if she eats also, she tries to pour this out. So keep this thing separate. She stops eating. Because of stoppage of eating, then her BMI will be decreased, and this BMI may even result into this hormonal changes and amenorrhea as well. Okay, so this is a simple explanation of this anorexia nervosa. So there will be a female who is not eating, okay, or eating very less. Whereas in the case of bulimia nervosa, like means it is, imagine it is your friend's party. ठीक है ना, वो friend खर्चा कर रहा है, ठीक है, when your friend clears the neetpg, or like for example your friend scored a good marks, okay, and you also pass the examination, तो वो क्या कर रहा है, friend तो party दे रहा है, party तो लेनी ही चाहिए, तो then you need to go, then you are going for the party, then अपने गर्दन तक खा लिया, means you have eaten till your root of the tongue, okay, you are the base of the tongue. Then after coming to your home, you realize it means I should not eat this much. Then you are putting your hands and you are vomiting. Okay, this is known as what? This is known as bulimia nervosa. लेकिन आप होटल से या KFC से इधर तक आ गए, means you came from KFC to your home. So in the meantime, there will be a digestion taking place. So few of the nutrition will be absorbed. So इसीलिए he will be having this weight loss. There will be no weight loss in होगा. Whereas in the case of anorexia, he won't eat itself. If you ask for party, he will go and take a piece of food and he will smell, हो गया आज का खत्म करके. Okay, so just remember these things. Fine. Okay, so this is these things like anorexia nervosa and bulimia nervosa. So mostly konja tamil sollu kalapadu. Okay, so don't worry, like we'll try to be in neutral one. So some explanations like it will be in bit Hindi, so that it will be in track. Okay, so don't worry, there is no unnecessary information I will tell. Okay, in English, in Hindi, don't worry. Fine. Then so this is the anorexia nervosa. The patient itself, he will not eat. Whereas in the case of bulimia nervosa, the patient eat, but he or she will purge, or he will do vomiting and other methods to prevent her weight gain. But actually here the BMI will be normal. So this is the two differentiating feature you should think of. Okay, so first one, it is the anorexia nervosa and bulimia nervosa. In bulimia nervosa, the weight loss will not be there. Okay, will not be there. So in such cases, if you see, once the patient is putting hand and doing vomiting, then this teeth will come and cause damage to these knuckles. Come and cause damage to the knuckles. It is known as what? It is known as Russell sign. Okay, there will be a repetitive trauma, and after this repetitive trauma, what will happen? There will be, because of this scarring will be there. It is known as Russell sign. And to treat this, we'll use 𝗓𝐶A or SSRIs. 𝗓𝐶A or SSRIs. Fine. And next, we already saw the smoking cessation drugs. This one is this nicotine replacement therapy, as chewing gums or Lorentz, or we can use these drugs which include bupropion, varenicline, and bupropion and varenicline, and bupropion is like it can be used as an anti-anxiety as well. Fine. Whereas varenicline, it is the most effective anti-smoking drugs. It is the most effective anti-smoking drugs. Okay, don't worry. Good. Okay. And about these three things, which is this postpartum blues, depression, and psychosis. Remember this BPD. Okay, blues, psychosis, and depression. Okay, depression, it is the worst part. See, it will happen around 3 days. Okay, yeah, psychosis, it will be for 3 weeks, whereas depression, it will happen after 3 months. Okay, between 3 months. See, blues मतलब कुछ नहीं, ठीक है, बस रोती रहेगी. Means the female will be crying, nothing. Like she will feel very low at this moment. Okay, that's it. Okay, there is this emotional ability, and sadness and tearfulness will be there, and she'll be having the sleep disturbance. That is blues. ठीक है, that is the blues. Like she'll be having the low mood. ठीक है, खाने का मन नहीं कर रहा है. Okay, then she's unable to eat, so then she'll be having the feeling of to cry. Okay, and there will be sleep disturbance. This is the blues. Whereas in the case of postpartum psychosis, okay, there will be what? There will be the tendency to harm the baby. Okay, na? He means there will be psychotic will be there, and the psychosis means he want to kill the baby because or someone has stole his baby. Someone has stole his baby, like a hallucination. They will someone stolen his baby in the womb, like that. He'll be having the hallucination. That is the postpartum psychosis. It will be happening around 3 weeks. Okay, whereas in the case of postpartum depression, she will tell like, no, it is not the child, it is not the child I have given, it is replaced. So she will go into the depression and thought of suiciding herself, and also suiciding or causing damage to the body. So she also will die, thinking to die, and she also harm the baby. So it is the postpartum depression. So इसीलिए so we'll give a drug in a case of postpartum depression, and along with this psychotherapy we'll do for this all 3 ones. So इसके लिए हम क्या करेंगे? We'll give this psychotherapy as well as we'll give this drug which is known as brexanolone. It is known as brexanolone. It is known as brexanolone, which we use in a case of postpartum depression. Okay? Right. These are the things you need to know about this postpartum changes. Fine. And next about this disorders which is known as generalized anxiety disorders and other anxiety disorders and PTSD. In a case of generalized anxiety disorders, the one of them is what? This first one, it is the panic disorder. Panic disorder means there is a sense of impending doom. So everything is going to stop now. The world is going to break now. So they will be having this feel. Okay, they will be having this feel now. Okay, fine. So the onset of palpitations, choking sensations, and dizziness, and everything, the world is going to end and I'm going to die. So this feeling will be mentioned in the questions, and this may mimic this myocardial infarction. Okay, myocardial infarction. So it is the typical feature of this panic disorder will be mentioned. Yeah, there is a feature of impending doom. Next one, there is this generalized anxiety disorder. There will be inner sense of restless, like there will be floating anxiety. Okay, hey, kar le to nahi hoga. Means what will happen if I didn't do this? If I didn't do this topic, what will happen? I should solve from Telegram. I should problem this app, that app. So you'll be having this free flowing anxiety. तो इसके लिए हम क्या करेंगे? We'll use benzodiazepines to calm her. Okay, and SSRIs and CBTs. तो इतना याद रखो. ठीक है. Then about post-traumatic stress disorder, it will be usually following a traumatic event, for example, any accident or any war events. So it will be happen mostly after more than it will be happen more than 1 month, and it should be If it is present after or more than 1 month, it will call them as PTSD. If it is less than 1 month, we'll call them as acute stress disorder. Acute stress disorder. Fine. For treatment, we'll use SSRIs and cognitive behavioral therapy, and we'll use one more method which is known as eye movement desensitization and reprocessing, EMDR. EMDR in the case of PTSD. Okay, EMDR will tell them to imagine and will tell them to eye movement. Okay, and by this the anxiety level will reduce. Okay, they won't go back to the place where this event or this war has happened, where this car accident has happened. They'll be having this intrusive thoughts, this again this gonna happens. Okay, or they'll be having this, once they hear the sound of car, they will think the accident gonna happen, like that. Okay, so this is the post-traumatic stress disorder. Fine. And the final part of the psychiatry means, yeah, it is the child psychiatry. If you see about this child psychiatry, it is what? It is a, there are different diseases. One is this ADHD, which is this hyperkinetic disorder. And in case of hyperkinetic disorder, the main, it is what? It is this pharmacological. We can use two drugs. One is the stimulant and non-stimulant. Stimulant ke liye will use methylphenidate, whereas non-stimulant will use atomoxetine. Means, for example, if the child, it is a small child like 10-12 years, but now if you see some part of India, in some schools there will be abusing of this drugs will be there. For example, cocaine abusing or alcoholic abuse. So in such abusers, we won't give methylphenidate. So in the case of those abusers, will give non-stimulant drugs like atomoxetine. Like atomoxetine will give them. Fine. And okay, just remember, and we also do give them social psychosocial interventions, and will give some social skill training for them. Okay, and how to behave in environment in a case of ADHD, which is a hyperkinetic disorder. Okay, and there are few more diseases you should know. One is this autism, Rett syndrome, HELLES syndrome, Asperger syndrome, and learning disability. See, autism, there will be what? There will be poor imagination, there will be a low IQ. Okay, and there will be a language deficits, and along with this behavior also will be affected. And the main thing here, it is the social interaction. Social interactions will be there, and sometimes like there will be IQ defected, sometimes there will be over IQ developed. There will be over IQ developed. Okay, this is the features of autism. Whereas Rett syndrome, it is typically seen in females where there is a regression of this, brain growth and causing this microcephaly. There will be microcephaly and regression of this brain growth. So it is due to a mutation which is known as 𝗵𝗶𝗀 gene mutation. 𝗵𝗶𝗀 gene mutation, which is seen in a case of Rett syndrome. There will be features of autism along with these features of microcephaly and brain or growth retardation changes, especially seen in females. इसको treat करने के लिए we have invented drug which is known as trofinetide, which is used in a case of Rett syndrome. Then HELLES syndrome क्या है? It is seen especially mostly in males, and it is this decrease in acquired skills. ठीक है ना, जैसे जो भी acquired skills, for example writing, scribbling, okay, making cubes, this acquired skill will be lost in this child, and along with this there will be a loss of control of bowel and bladder movements. There will be a loss of control of bowel and bladder movements will be seen in a case of HELLES syndrome. Remember, hell, what is the hell? The hell is here is that there will be a bowel and bladder involvement. Okay, and in a case of Asperger syndrome, it is autism minus means social interaction. So there will be just social interactions will be affected in a case of Asperger syndrome. In a case of learning disability, everything will be normal, but his exam scorecard will be abnormal. Okay, everything will be normal except his exam scorecard. Okay, that is this learning disability. Yeah, good. Next, the final one, the psychology one, psychiatry one, it is this psychosexual stages. Oral stage, it will be from 0 to 1.5 years. Anal stage, it is from 1.5 to 3 years. Remember, if there is any fixation at this anal stage, it will result into this OCD. Fixation of this anal stage results in OCD, whereas phallic stage, there will be two things: Oedipus complex, Electra complex. This Oedipus complex and Electra complex fixation. Okay, this Oedipus complex and Electra complex fixation at the level of phallic stage, which is from 3 to 5 years, it leads to this hysteria. It will cause hysteria. Okay, hysteria. Good. Fine. Next one, yeah. Next one, there is this later stage which is from 5 to 12 years. Okay, then here he will be able to focus mainly on this learning and gaining skills, whereas on E he will be knowing about the sexual and adulthood things. Okay, maturation of genital functioning. So it will be around 12 years. So remember about this mainly is oral stage 0 to 15, 0 to 1.5, anal 1.5 to 3, and phallic it is 3 to 5 years, and latent stage it is 5 to 12, and general stage it is 12 years. Fine. And remember, anal stage fixation causes OCD, whereas phallic stage fixation causes hysteria. Okay, so this is all about this psychiatry, or the most important point the psychiatry you should know. And also remember about this hallucinations, okay, and about this delusions, especially like delusion of love, which is known as erotomania, erotomania, like yeah, auto driver, he is a lover of who we can tell Aishwarya Rai. Okay, Aishwarya Rai. Okay, it is not. It is known as love, which is known as erotomania, and delusion of pathological doubt. Okay, okay, which is known as what? Infidelity, also known as Othello syndrome. Okay, Othello syndrome. Okay, Othello syndrome. Okay, and there is this. Just remember about this delusion of reference means everything happens because of me. Okay, and reference means referring him. Okay, referring him, like the world is circling because of me, circling because of, or circling or rotating because of me. Okay, and enormity, if I sneeze, I'll blow Delhi. Okay, so I will sneeze very calmly. Okay, so these are the delusions: delusion of love, delusion of infidelity, and delusion of this reference, and delusion of enormity. So just remember about this, all these delusions for part. Okay, yeah, about this phallic state, just remember there are two things, like female feels there is this penis, which is an extra organ which is not present in her, so she have a adaptation, or she has a love towards his father. Okay, this is known as what? This is known as Oedipus complex. Whereas male, it will be having an attachment to the female, it is known as Electra complex. Okay, these are two complex you should know: Oedipus complex and Electra complex. And if there is any fixation, like if there is any fixation at this stage, it happens, it leads to this hysteria. Okay, or any other type of neurotic illness. Okay, just remember this thing. Okay, it is not these are fixation stages, means like at this stage if it fixed, it will lead to hysteria. Okay, their mind will be very much kind of simple. Okay, yeah, that's it guys, that's it about psychiatry. We'll have a good break, we'll meet up around we'll take a 15 minutes break, we'll meet up around 12:50 we'll meet up. Okay, and we'll do small subjects, then we'll take up a good lunch break at 1:45. Okay, bye. See you guys. If you need doubt, please post in the chat section. Hello doctors, welcome back to the Game Changer series by Dr. 𝗶𝗶𝗀𝗀, and this is our radiology part, and I guess everything is clear. Is my audio and visuals are clear? Can you please confirm in the chat section, guys? Yeah, Dr. Ed, yeah, I will share all this annotated PDF. I told you, right, because of this thing, I'll share it. I also informed them in the break. You will get it for sure. Like before lunch, they'll be sharing you. Okay, don't worry. Okay, sure, don't worry. Yeah, thank you, Dr. Anar, for confirmation. Thank you, Dr. Venki, and thank you, Dr. Quinin, for the confirmation part. Fine. We'll go ahead. We'll be having this radiology and orthopedics now, and after this, we'll having a lunch break, and after this, we'll have 2 more subjects left, and we'll be done with for the day. Fine, are done for this all 19 subjects. Okay, and about this radiology part, there will be that the usual number of questions in the radiology, it is 10 to 12. Okay, see, it seems much more when you see this radiology as a very small subjects, but it is hugely integrated with all the subjects like medicine, pedia, they have radiology part, and ortho, it is one of the majorly dependent on radiology one, and then say medicine, surgery, OBG, everything, it will be mixture of this radiology. That's why the question numbers will be 10 to 11, sometimes it can go up to 15. But the minimum number, it will be 10. Okay, and there will be the general radiology part will be having 2 to 3 questions, or I guess just 4 to 5 questions will be present from this general radiology part, whereas the rest it will be from the mostly integrated and systemic radiology only. Yeah, then we'll move on to this first part about this radiology, which is about this effects and the side effects of radiation. If we see about the first effects of radiation, there are 2 effects. One is known as stochastic effect, and another one is known as deterministic effect, which is also known as non-stochastic effect. So what is this effect signifies? For example, in few conditions will tell, right, because of this dosage of radiation, this happened. Okay, whereas in few conditions will tell, right, this cancer happened because of this radiation exposure. We won't tell about the dosage. For example, in a case of carcinoma, we won't tell about the dosage. It is just this radiation exposure which is leading to the cancer. Whereas in a case of side effects, for example, skin erythema at this dose, and there is a bone marrow suppression as this dose, and GI suppression, like there will be skin erythema, GI suppression, and along with this neural damage and bone marrow suppression, there is a sequential involvement. Okay, so these are the 2 different effects that you need to understand. So if you see about this stochastic effect, there will be a linear increase. So linear increase. So if it happened, it is just happened. If it is happened, it just happened. So it is known as stochastic effect, and it is not dose dependent. There is no D in the name, so it is not dose dependent. So if it is happened at this point, it is happened. For example, cancer of this thyroid, like especially we studied, right, papillary carcinoma thyroid. Papillary carcinoma thyroid, which has happened after neck radiation or breast radiation. Fine, radiation. Okay, and we know this radiation after this ALL, these all based on this stochastic effect. Yes, okay, fine. And deterministic effect, it needs a threshold. Okay, yeah, good, Dr. Anar. And deterministic effect, it needs a threshold. For example, we saw from physiology, there is an action potential, right? So there will be small sub-threshold stimulus, and there will be a small, this stimulus will reach a threshold, and once it reaches a threshold, it will spike up. Okay, the same thing here. Like there will be small doses, it will be nothing will be happening. Okay. Okay, whereas here there will be this when there is exposed to its large doses, it will manifest as a symptoms. Okay, because of this over threshold. Okay, and the severity is different. For example, initially if low doses, it will be causing skin erythema as manifestations, whereas in high doses it may cause GI, then followed by this bone marrow suppression. Okay, itna yaad rakhna. So this is the 2 effects of radiation you should remembering of. Okay, one is the stochastic, which is not dose dependent, which is leading to teratogenicity and cancers, whereas this deterministic, leading for the side effects like skin erythema, skin erythemia, and other GI manifestations, bone marrow manifestations. Fine. Yeah, skin is the first one. Then what are the side effects of radiation? If you see the side effects, the most common side effect, it is what is this skin erythema. And if you see the most common cancer after radiotherapy, it is the leukemia. And as I told you, the most common thyroid cancer following radiotherapy, it is this papillary carcinoma thyroid. And they will ask you, what is the most common bone tumor after radiotherapy? It is the osteosarcoma. It is the osteosarcoma. Fine. It is the osteosarcoma. Okay. And they will and just see from this table, like what are the changes can also be seen. For example, in the case of bone marrow, you can see there is a decreased blood counts, there will be aplasia will be there, there will be fibrosis will be there. In brain, it may lead to the usual scenario of nausea and vomiting. Okay, and in a case of esophagus, it may lead to this dysphagia because of stricture or radiation induced fibrosis and causing dysphagia. Fine. And in a case of purulent bladder, it may lead to this small mucositis, which is leading to this what, diarrhea and vomiting. Okay, diarrhea and vomiting. But the most common one, it is the skin first. Okay, and can anyone tell me which of the following is the radio sensitive phase of cell cycle, and which is the radio resistant? Okay, remember, yeah, there. Is this G2S or G2M? Yeah, it is quinine. Correct, quinine. Yeah, good try, Dr. Annar. Good, Dr. Prototype. Good, Dr. Yeah, Mohammedan. See, the radio sensitive. Remember, sensitive won't have S. Okay, the sensitive peoples, they won't show they are sensitive. Like they won't tell they are sensitive. They actually cry. So remember, this radio sensitive one, they will be having, means it is due to this involvement or this radio sensitive phase of the cell cycle, it is G2, whereas S is the radio resistant. Okay, S, the single people, they will be resistant to everything. So S is the radio resistant phase. So radio sensitive is the G2M, radio resistant is this S phase. Okay, whereas this gonadal cells, they are radio sensitive. Gonadal cells are radio sensitive, whereas this neurons, they are radio resistance. Yeah, good. And we know this in the case of in the case of blood cells, if they ask this WBC, which is having this nucleus, they are more radio sensitive, whereas RBCs and platelets, which lacks nucleus, they are more radio resistant. ठीक है, अब थोड़ा बहुत इतना याद रखना, क्योंकि like they will ask you which of the following is the radio sensitive phase, which of the following is not a radio sensitive phase, like that they will ask you. Yeah, good. Yeah, Ewing sarcoma, it is one of the bone tumor which is radio sensitive in nature, whereas osteosarcoma, it happens because of radiation, so it is radio resistant in nature. Okay, it is radio resistant in nature. Okay, then about this size, this what is the usual lead apron thickness you will wear? So you will wear around 0.5 millimeter. Okay, 0.5 millimeter. Yeah, Mohammed Anas, it is the worms. Yeah, worms you will wear. Wilms tumor, Ewing sarcoma, and seminomas, you will able to see these are all what? These are all this radio sensitive tumors. Fine. And next one, if you able to see, this is the TLD batch, or also known as thermoluminescent dosimeter. Okay, here this they will ask you where you will keep this TLD batch, outside your lead apron or inside your lead apron. See, this TLD batch will assess this radiation exposure after this lead apron. So remember, you will keep inside the lead apron. So like imagine this as a lead apron. So we'll keep this TLD batch inside the lead apron. Remember, it is the inside the lead apron, and the size of the lead apron, it is what? It is this 0.5 millimeter. You will keep it inside the lead apron. Inside lead apron. Fine. And you see this this TLD batch, it is made up of lithium fluoride, and in India it is made up of calcium sulfate. It is in India it is made up of calcium sulfate. In India it is made up of calcium sulfate dysprosium. Fine. And see, this TLD batch, it is given for every 3 months. Every 3 months. It is given for every 3 months. Itna yaad rakho. Fine. And then you need to know a few more things. For example, this ionizing radiations and non-ionizing. ठीक है, non-ionizing पहले याद रखो, ultrasound and MRI, they are non-ionizing, whereas our X-ray, CT, mammography, and our this radionuclide imaging, okay, which uses this gamma rays, they are what? They are this ionizing radiations, whereas non-ionizing is ultrasound and MRI. So see, if a children is presenting to you, if a children or pregnant female is presenting to you, then your first identification modality should be used. It is either ultrasound modality or MRI modality to prevent from this radiation exposure. Fine. Next, they will ask you if there is a female who is pregnant and she don't know that, and without knowing that she is pregnant, she took a X-ray. So what you will think? If she took a X-ray, what you need to do? Like you will tell to abort, or you can continue the pregnancy. What you will do? So if X-ray also taken, don't worry, just reassure her and tell her to continue the pregnancy. Okay, we don't abort it. We'll do what? We'll continue the pregnancy. Okay, remember, yeah. Good guys, you are good. Good Dr. Ansh, good Dr. Teja, good Dr. Rituraj, good Dr. Quinin, good Dr. Naresh, good Dr. Parul and Prototype. Yeah, good Dr. 𝗶𝗶𝗀𝗀. Good guys, you are doing well. Fine. Next, we'll move on to this next part, which is this foreign body. See, this foreign body is being repeatedly tested because there is more emergency as well, it is a radiology as well, and it is a EMT as well. Fine. If you see about this tracheoesophageal foreign body, see, write this word as esophagus. Esophagus. Okay. And esophagus, how we are seeing this esophagus? We are seeing in front of, means this iPad or the phone, it is in front of you. So this is, if it is in complete coin in AP view, so esophagus, if it is complete coin in AP view, it is what it is, this present, the foreign body is present in the esophagus. Fine. So if it is what it is, this complete coin view, whereas in a case of lateral view, you can see this is this slit formation if it is in esophagus. Fine, esophagus. See, if they will tell there is a coin in the esophagus, the patient is presenting with dysphagia. Okay, then you can what you can do, either if it is crosses this cricopharyngeal junction, cricopharyngeal junctions, then you can wait and watch. Okay, if they tell if there is a coin in esophagus or coin in trachea. So if there is coin in esophagus and if it is crossing this cricoesophageal junction, then you can wait and watch. Wait and watch. Okay, whereas in a trachea you need to remove immediately because it will cause what? It will cause dyspnea, okay, or difficulty in breathing, and the patient even may die. Okay, this is a coin case. Whereas if you see this one, which is this double ring sign, like if you're able to see, if you're able to see this coin which is showing this one more double ring sign, or there is two elevations, it is what? It is not coining. If it is a circular body which is having this type of arrangement, it is what? It is this disc battery. Disc battery. So remember, if disc battery is anywhere, yeah, it can lead to this alkali injury. If disc battery in esophagus, is disc battery in trachea, coina, okay, if anywhere it is there, you should do immediate removal. You should do immediate, good, Dr. Rituraj, it is this disc battery. You should do immediate removal, because it will be made up of alkali, it can cause perforation of the esophagus, and if it is trachea, it can cause perforation and also respiratory distress. So this they will mention. This coin battery means the following foreign body is being shown, where you will see two densities, two level of densities, one ring outside, one ring on the inner side, and you will be able to see that is a battery. So if it is in esophagus, what you will do? The first option, and it is crossed cricopharynx. If it is crossed, uncrossed, we don't matter. If it is disc battery, we'll remove it immediately. Okay, we'll remove it immediately. Fine. And if it is any foreign body in the trachea, we'll remove it immediately. If it is coin or if it is disc battery. Fine. The opposite of this will be seen in a case of trachea. Opposites of this will be seen in a trachea. In trachea, AP view, you will see formation of slit. Means it's based on the level. Mostly we'll do rigid bronchoscopy because if you do flexible, means it won't flux and take up. If it is in the other bronchi level at very distal level, then we can use this flexible one, whereas it will be mostly in the upper part because these are large structures. Then we'll use this rigid wala bronchoscopy and we'll remove it. Fine, we'll use this rigid bronchoscopy and remove it. Whereas if it is in esophagus, we'll do esophagoscopy or our usual endoscopy and we'll take it out. Fine, okay. So then tracheal antibody, the T पे भी दिख रहा है, ठीक है? अगर trachea esophagus में तुम्हें confusion, बस उसका नाम को just see its name. Esophagus, it is, you're welcome. Esophagus, if it is in the anterior aspect, so if you see here, so it is what it is, the anteriorly we'll be able to see the full cone view. Whereas if you see the trachea, it is T, like a tie. So in anterior posterior view, it will be having this slit shape. ठीक है? Don't try to memorize lot of things and forget the necessary things. ठीक है? तो इसीलिए हो सकता तो एक को याद रखना, नहीं तो दोनों याद रखोगे तो it will be good. If you are able to remember two things, it's best. If not, at least remember this esophagus and forget about this trachea foreign body. So in tracheal foreign body, on the AP view, it will be slit in nature, whereas in the case of lateral view, it will be a full coin view. It is a full coin view. Fine. It is a full coin view. Yeah, you're welcome, Dr. Rituraj. Fine. Next, about this few neurological imaging, if you see, you will be able to see this type of sign, where you will be able to see this tails of the dura. So this type of dural tail sign will be classically seen in a case of meningioma. So you will see this dural tail sign in a case of meningioma. ठीक है? और हमें पता है what is the name of the bodies you will see in a case of meningioma? Yeah, guys, which is a dystrophic body. It is what it is. This 𝗬𝗮𝗧 bodies. It is the 𝗬𝗮𝗧 bodies. Yeah, good guys. It is the dystrophic calcification. calcification. Yeah, good, Dr. Quinin, Anar Mohammadanash, yeah, well said, fine. Yeah. It is seen in a case of papillary carcinoma, thyroid, meningioma, serous adenoma, ovary. Okay, remember, good. And papillary arthritis as well, yeah, PSM, good. Then if you're able to see this type of mass, there are you're able to see this type of mass, okay, which is around this shape of 8, okay, around this shape of 8, it is what it is, this pituitary adenoma, okay, pituitary adenoma, okay. There are two things. If you are able to see this type of cystic lesion, if this present means fluid containing, if there is a presence of fluids, along with this there is a calcification. अगर दोनों है, cyst भी है, calcification भी है, then it is what? Then it is craniopharyngioma. लेकिन if it is just a 8-shaped mass, it is what it is? This, which is the pituitary adenoma. It is the pituitary adenoma. And can anyone tell me if the pituitary adenoma causes compression over this optic chiasma? अगर ये optic chiasma के ऊपर compress कर रहा है, it will produce which type of visual field defect? That will produce which type of visual field defect? Visual field defect. Yeah, it is the bitemporal hemianopia. Good, Dr. Quinin, Nash, good, Dr. Rituraj, Dr. Anar, yeah, best. Bitemporal hemianopia, also known as heteronymous. Yeah, good, Dr. Bhargav, it is the heteronymous hemianopia. It is also the heteronymous hemianopia. Okay, yaad rakho. Then, if you are able to see this type of ice cream cone appearance, it is seen in a case of on gadolinium enhanced MRI. It is seen in a case of aquastic schwannoma. It is seen in a case of aquastic schwannoma. Okay, aquastic schwannoma. Next, if you are able to see this type of necrosis, okay, and if it is, sometimes it will involve this bilateral lobe, it is known as what? It is the glioma, especially this glioblastoma multiforme. Yeah, glioblastoma multiforme. Yeah, for Nandini, yeah, correct. Will in a case of this pituitary adenomas, we can use cabergoline, good, and Bhargav, yeah, good, and quinine, good, and good, yeah, it will produce butterfly, yeah, you remember, yeah, it will produce this butterfly, good. Like I'm happy that you are able to recollect and do things. Like the same thing will be happening in your exam as well. Just make sure your things are coming there in correct part. Okay, I will pray for the same, and make sure you are keeping things simple and you are getting the questions correct. Okay, bas itna karo. Yeah, there will be presence of this serpentine necrosis, okay, yeah, sure, yeah, I'll be keeping you in place, don't worry, fine. फिर उसके बाद है this hemorrhage, so SDH, EDH and subarachnoid hemorrhage, okay. So you see the first thing, this SDH will be what? It will be banana shaped, it will be banana, okay, it will be banana. See, if you see this banana shaped, this crescent shaped, it is seen in a case of subdural hemorrhage. And this subdural hemorrhage, it is due to the damage to this bridging veins. It is due to damage to the bridging veins, okay? And it is most commonly seen in children, where you will shake the baby, right? Shaken baby syndrome, okay? Children you will see, and also it is seen in a case of elderly. Elderly also you will be able to see, okay? These are the two things you will see, fine. Next, it is this EDH, okay? EDH is epidural and extradural hematoma. EDH, remember? This EDH, remember it is which shape? Yeah, good Dr. Ernst, good Dr. Prototype. Yeah, quinine. Yeah, you are telling. Yeah, fine. See, okay. EDH, see, it is idli shape. Okay, idli shape, or this one, which shape? Which is this? Yeah, they are the bridging emissary veins. Yeah, they are around the same. Emissary vein, it is one of the bridging vein. Okay, so see. This is the idli shaped one, or this len shaped. Okay, so remember, who will make the best idli? Okay, who will make the very soft fluffy idli? Yeah, who will make the best and soft fluffy idli? Our ma. Okay, so remember, the idli will be made by our mother ma. So it is ma. So it is middle meningeal artery, which will be responsible for bleeding in a case of epidural hemorrhage. So it will be idli shaped and ma will make this soft idli. But हम क्या करते हैं? हम प्यार के चक्कर में माँ को भूल जाते हैं. So there will be interval in your life where initially means you will be unconscious, there you will get conscious, and again you will become unconscious. Okay, so this is known as what? This is known as lucid interval. It is known as lucid interval. Will be seen in the case of EDH. And this middle meningeal artery, it will bypass with this foramen, which is known as foramen of spinosum. Okay, it will be passing through this foramen, which is known as foramen of spinosum. And there will be classically tell there is a trauma occurring at this region. Yeah, somebody already told this trauma at this region, which is known as terion, okay, which is known as terion. Fine. And next, you saw a patient who is presenting with features of hypotension with thunderclap headache. Okay. This is the classical feature of this subarachnoid hemorrhage. Where you will able to see the sulcal spaces which are being filled with the blood. Okay, sulcal spaces which are being filled with the blood. Okay, so and in a case of any stroke, case of stroke, let me ask you a few questions. In a case of stroke, what is the first investigation you will do? Guys, is it NCCT or CECT? See, in a case of any emergency management, whatever you do, it should be simple and it should not be time consuming. So what we'll do NCCT. Wow, best, Dr. Ansh, Nandini, Anwar. Yeah, it is what? It is the NCCT. Good, Dr. Quinin Parul. Yeah, good, Dr. Bhagav, Naresh, best one. It is what it is, NCCT, because we do NCCT because it will be very quick. That's it, done. We'll just bring the patient out. So this NCT will be taken in minutes, and this NCCT will be able to differentiate or tell it is which type of stroke. There are two types of stroke. One is hemorrhagic stroke, next one is the ischemic stroke. In the case of hemorrhagic stroke, it will be showing this hemorrhages. Okay, it will be showing this hemorrhages. Whereas in the case of ischemic stroke, it may be normal. Or it may be suggestive of some hypodensities. Okay, so if there is a hemorrhage present, hum sochenge, yeah, it is a hemorrhagic stroke. Then we need to look into the causes. Like if it is hypertension, we'll check for the BP, then we'll control, and along with this, we'll give what? We'll move for this, which vessel is bleeding, and we go on leg out it. So this is this hemorrhagic stroke. Whereas in the case of ischemic stroke, if there is ischemia, mostly it is due to the formation of clot formation will be there, and we need to go and break the clot. Okay, we need to go and break the clot. So we'll do NCCT if it is hemorrhagic. Good, guys. If it is hemorrhagic, what we'll do? We'll go for its further management, like with reduction in BP and also clipping of the vessel which is bleeding. And next, if it is what? If it is ischemic stroke, the NCCT will be almost normal. Okay, normal, sometimes there will be changes. So in such cases, we'll go for thrombolysis. But thrombolysis will, before that, we'll check for BP. Okay, for prevent of, yeah, that's a management part, right? There will be cerebral edema, we'll decrease cerebral edema by providing mannitol. Okay, we'll give supportive care, supportive therapy. Okay, and we'll check for like whether the patient is hypertensive, whether the patient is a diabetic patient. If it is hypertensive, we'll measure blood pressure and we'll reduce him gradually. Like if it is more than 180, then or 160, then we'll start giving thrombolysis. So there is this management protocol. Yeah, that's correct. Yeah. Within there will be this golden period where within 4.5 hours you should give this thrombolysis. Okay, fine, just remember. Next, if you're able to see this type of finger-like projections near the ventricle, which is especially seen on the fluid attenuation and inversion recovery sequence, it is suggestive of Dawson's finger, which is suggestive of this multiple sclerosis. And then if you're able to see this sagittal sinus, like sagittal sinus, especially the superior sagittal sinus inside, if you're able to see this type of empty delta sign, it will be suggestive of this cerebral venous thrombosis, especially the superior sagittal sinus thrombosis. Yeah, good, Dr. Quinin, and good, Dr. Ansha. Good. Yeah, one is the drug which we use here in a case of multiple sclerosis. It is natalizumab. Yeah, natalizumab, omalizumab we can use. Fine. And next, if you're able to see here, this type of sign where air anywhere, for example, in the case of pneumo in the intestine, okay, or pneumoperitoneum, or in the case of pneumothorax, or even in the case of pneumothorax, in the case of air anywhere, we'll use CT. So if you see this type of CT image where this is this brain, and there is a accumulation of air in the brain and causing this compression. So we know this air will always tend to go up. Okay, that's why if you see in the case of pneumoperitoneum, we'll tell the patient to stand so that the air will come up under the diaphragm and will take the image. Okay, likewise here also what will be there, this air, when we tell the patient to lay, the air will come into the anterior aspect. Okay, that is the air present in the brain, which is known as pneumocapillus, and if it causing this ventricular constriction or compression of these ventricles. It is known as tension pneumocephalus. Okay, in last May I said they just given this image and they asked what is the diagnosis. The answer is tension pneumothorax. It is the tension pneumothorax. इसमें बिल्कुल गलती नहीं करना है. See, the air is there which is black in color, and see this is the bone is white. It is the CT. It is the CT. Okay, then we'll move ahead. If you are able to see this type of cross Bunsen or hot cross Bunsen, where you will see this hot cross Bunsen. Yeah, you will see in a case of multiple system atrophy. You will see in a case of multiple system atrophy, especially in type C. And next, if you are able to see this type of tram track calcification, this type of tram track calcification is specific for this 𝗏𝗏𝗏𝗏 syndrome. It is specific for this 𝗏𝗏𝗏𝗏 syndrome. Specific for this 𝗏𝗏𝗏𝗏 syndrome. And see, and as yesterday in I guess 2 days back, we in pathology we discussed. Where you will see this tram track. Yeah, that is Port-Wine stain. Yeah, Port-Wine stain. I will show you in dermatology. Okay, tram track appearance on renal biopsy. Okay, on renal biopsy, in which condition we will see this splitting of the basement membrane causing this tram track sign. Yeah, guys, splitting of basement membrane causing this tram track sign. किसमें देखेंगे? You will see in a case of 𝗵𝗵𝗶𝗀, good Dr. quinine. So see, there is membranous glomerulonephropathy, which is the most common cause of nephrotic syndrome in elderly and cancer patients. Whereas there is a P which is separating this MGN, like membranous, we'll call them as MGN. Whereas there is a P is coming and it is separating. Okay, like a train track, it is separating. So it is known as tram track appearance or train track appearance. Okay, whereas in a case of 𝗏𝗏𝗏𝗏, where you will see this tram track appearance on 𝗏𝗏𝗏𝗏. Good Dr. Bhargav, we'll see this tram track appearance on 𝗏𝗏𝗏𝗏 in a case of bronchiectasis. Bronchiectasis, we'll see two things. One is this signet ring shape and another one is the tram track appearance. Okay, if I cut this bronchus like this, it will look like a signet ring. Whereas if it will be going like this, like if I cut like this, it will be what? It will be tram track appearance. It will be tram track appearance. Yeah, good. It is bronchiectasis. Yeah, good Dr. Ansh, good Dr. Bhargav, good Dr. Quinine. Yeah, good. Right. Next, about this pneumoperitoneum. See, I told you this pneumoperitoneum. This pneumoperitoneum will be having this air inside this. Mostly it is due to the perforation or trauma. Especially more commonly it is due to the perforation part. Especially in a case of duodenal ulcer perforation, or in a case of tuberculosis, or in a case of typhoid, there will be a perforation. Okay, there will be ulcer formation and perforation. For example, in a case of Crohn's disease, there will be perforation. So all of these things, it will manifest as pneumoperitoneum. So in the case of pneumoperitoneum, as I told you, the air will come and it will go and sit. The air will come and will sit under the diaphragm. So it is known as air under diaphragm sign. Okay, here you will be able to see there is this air which is sitting under the diaphragm. So okay, so it is the air under diaphragm. Yeah, good Dr. Ansh. Yeah, good Dr. Anna. Yeah, good. Air under diaphragm. It's fine. And as I told you, air anywhere. The diagnosis is kya? Diagnosis is CT. Okay, air sometimes can be present in around the central tendon of the diaphragm. Okay, central tendon of the diaphragm, if the air present, which is known as 𝗵𝗵𝗏𝗏 sign. Okay, if the air is present at the central tendon of diaphragm, which is known as 𝗵𝗵𝗏 sign, which is known as 𝗵𝗵𝗏 sign. Fine. And as I told you, there you will be able to see this air in the diaphragm, and mostly we'll tell the patient to stand erect, because I told you air will come upstairs. Okay, so that's why we'll take chest X-ray erect. Fine. And there might be this air which is present in this hepatorenal pouch. It is known as Doggy's cap sign. And there, if the air is present, bubble inside the bubble, there will be a food and air. So if bubble inside the food also there is air, and outside also there is air, it is known as what? It is known as Wriggler sign. Yeah, it is seen in the case of hollow viscous perforation as well, guys. Yeah, if there is any presence of extraluminal air, it is known as telltale triangle sign. It is not much important. And there are two more signs, like where we are able to see this along this umbilical ligament, it is known as inverted V sign, and if it is along the medial umbilical ligament, it is the Urachus sign. Okay, and the falciform ligament can be visible as well. Okay, if there is air occurring around these ligaments, then these ligaments will be promptly visible. Especially here you need to know about this inverted V sign. Okay, whereas in the case of duodenal perforation, we know we'll keep this, or we'll bring this omentum along with this blood supply and we'll patch it. So it is known as what? It is known as omental patch. Okay, omental patch. Remember, yeah. also known as Graham's repair. Yeah, it is the momental patch or this Graham's repair. Then next about this prenatal USG finding. Okay. Yesterday we saw first what is the first investigations, whatever you will do, it is the CVS, chorionic villus sampling, followed by this amniocentesis, okay, around 30 weeks, okay, here around 16 weeks, and amniocentesis, then chordocentesis around more than 18 weeks. Okay, this is the sequence. Like first you will do chorionic villi sampling, then you will do amniocentesis, then you will do what? You will do chordocentesis. So CVAC, chordocent. First you will be chorionic villi sampling, amniocentesis, and chorionic, then chordocentesis. Fine, just remember. Yeah. Just give me a second. I guess everything is clear. Do you have any other doubts? Okay, good guys, good. Then I guess I can do it. Fine. Yeah. Okay. Thank you, Dr. Anar, and thank you, Dr. Anash Bhaga, for this reply. Yeah, good. See, Prague Crow. Okay, see, yeah, we'll come. See, if you see, we'll do this antenatal USG from this week of 11 to 13 weeks, or 11 to 13 weeks plus 6 days. Usually it is what is the 11 to 14 weeks. Okay, remember. And what is the most, or what is the most accurate thing which will tell that is the gestational age? It is what it is, the CRL, which is this crown rump length. It will tell this exactly. It will tell exactly like what is the gestational age. So the most accurate one, it is the CRL. Okay, and it is done in this mid-sagittal section with neutral flexion. It is not overflex, it is the neutral flexion. Okay, and the nasal tip and parrot should be visible. And here we'll be able to see there is a presence of nasal bone, and along with this, there is this nuchal thickness. There will be thickness around the nuclear thickness, and if there is any hyperdiploidy, like for example in a case of Down syndrome, then there will be a presence of this increased nuchal thickness, and this nasal bone will be absent. Okay, this normal nuchal thickness, it will be less than 3, and if it is more than increased nasal thickness, then there will be, it is a soft marker for this aneuploidy. Then we'll go for this dual marker, triple marker, and quadruple marker testing. Fine. And next they will ask in last examination, where you will see this banana and lemon. See, if there is any spina bifida, or if there is a neural posterior field defects, then this leads to this herniation. So the around the cerebellar vermis, it will become empty. So this is known as what? This is known as banana sign. And at the same time, this skull will become small. So it is like a lemon. It is known as what? Yeah, SDH also banana. That is another banana. But here they are asking where you will see this banana and lemon sign in antenatal USG. You will say in the case of antenatal USG, you will see in a case of where? In the case of spina bifida. Okay, banana sign. Okay, it is this abnormal anterior curvature of this cerebellum. Okay, because and it produces this banana sign. Okay, whereas this lemon sign also seen here. Okay, and usually it will be associated with this 𝗏𝗏𝗀𝗏 malformation. It will be associated with this 𝗏𝗏𝗀𝗏 malformation. Just itna yad rakho. Okay, where you will see this banana and lemon sign, you should tell it will be seen in the case of spina bifida. Okay, next, if the fetus is death inside, then it may lead to this few changes. For example, the brain will undergo this lysis, then the skull bone will start to overlap. Like usually the skull bone will be like this. Okay, the parietal bone, temporal bone, they'll be having the suture, so they'll be having the gap. So after death, what will happen? The skull bone, it will start overlapping. So this overlapping of the skull bone, it is known as cranial bone. It is known as Spalding sign. It is known as Spalding sign. Whereas it will come after 7 days of death. Okay, whereas the first one, it is known as Robert sign. Robert sign is nothing but the large vessels like aorta, vena cava, it will be started to have air. In the case of circulations, we won't be having the air. So if there is presence of air inside this large vessels, it is known as Robert sign. It is known as Robert sign. Okay, gas present in this heart and great vessels, it can be seen as early as 12 hours. As early as 12 hours. Yeah, good Dr. Quinin, good Dr. Ansh, and good Dr. Bhaga. Yeah, good. Fine. And this is your favorite frog which came here. If you are able to see this type of frog eye sign, it will be suggestive of anencephaly. And we know anencephaly is one of the changes which we can diagnose very much early, because we know this cranial, this anterior neuropore, it's not closed. Usually it closes at 25th day. If it is not closed, it leads to this opening and causes this anencephaly. Okay, yeah, good Dr. Quinin. Yeah, good Dr. Mohammed. Yeah, good. fine. And this is this also view which is showing that there is a defect in this. There is a defect. You can see there is a defect here. Okay, so it is what it is, this anencephaly. Anencephaly. Good guys, fine. Next, you just read these things, and I'll give this table. If you could able to remember, just read rest of them also, or else you should at least read them. Okay, fine. Just 𝗓𝗵𝗶𝗀𝗃 will use for this sarcoidosis. Okay, we studied right in sarcoidosis. We'll see asteroid bodies and Schaumann bodies in pathology. Then in a case of lungs, you will able to see in X-ray, if you take, you will able to see this type of sign which is known as lambda sign. Okay, lambda sign means there will be this around this trachea. There will be both side. There will be this around paratracheal lymph node involvement. Okay, and both hilar will be involved, and along with this paratracheal involvement. This will produce this sign which is known as what? This is known as what? Lambda sign. This is known as what? This is known as lambda sign. This is known as lambda sign. And in a case of scintigraphy with 𝗓𝗵𝗶𝗀𝗃 scan, it will produce as this parotid gland enhancement. Okay, which produces this face of panda sign. Which produces this panda sign. Next, this technetium-99m 𝗵𝗶𝗶𝗀 SPECT. It is used for the cerebral perfusion. For example, in a case of after stroke, you need to know whether the cerebral perfusion to the specific areas maintained or not. There you will do 𝗵𝗶𝗶𝗀 SPECT. And next, iodine 123 along with this 𝗵𝗵𝗶𝗀 SPECT. It is used in a case of dopamine transporter scan, like DAT scan. For example, in a case of pheochromocytoma, we need to measure, right, where is this pheochromocytoma is located. There we will use this DAT scan. Next is 18 FDG PET, which is used for this metastasis, usual metastasis. And they will ask you what is the T-half. It is this 120 minutes. It has a T-half of 120 minutes. Yeah, it is especially for the especially for the metastasis, where there is presence of metastasis or not. Okay, remember. And yeah, T11 methionine PET is used for this brain tumors, for their activity, and N13 ammonia, it is most sensitive for this myocardial perfusion. Means after MI, you should know whether this area which is undergoing the infarction is getting perfusion after thrombolysis or not. So there you will do this N13 ammonia PET. So remember 𝗵𝗶𝗶𝗀 PET, which is used for the cerebral perfusion, whereas N13 ammonia PET, it will be used for this myocardial perfusion. Okay, and next, the sodium fluoride. Okay, the sodium fluoride PET, it is used for what? The sodium fluoride PET, it is used for this skeletal metastasis. It is used for this skeletal metastasis. Fine. And DAPA PET, it is also used for this extra abdominal pheochromocytoma. Yeah. Sodium fluoride vacuum drainer, it is green color. It is used for collection of glucose collection. Fine. And technetium-99 MDP, it is used for this detecting the osteolytic, or how to differentiate between the osteolytic or osteoblastic metastasis. Osteolytic or osteoblastic metastasis. Fine. So remember these things. Then yeah, we'll just quickly go through this. If it is HIDA scan, like you know, if there is any biliary atresia, we studied there is a conjugated hyperbilirubinemia. So we need to know whether this bile is transferring or not. Then we'll use this, do the scan which is known as HIDA scan. Okay, it is used in a case of biliary atresia, and also it is used in a case of cholecystitis. Because why it is in cholecystitis, there will be inflammation. In a case of inflammation, the glands will be swelled, and this also won't come down. So this is this cholecystitis. Okay, and with this, for this bilic also we can use this. Okay, biliary atresia, cholecystitis and bilic we can use it. Then technetium-99m pertechnetate scan. This pertechnetate scan, it is used for this thyroid and salivary gland scintigraphy, and also for the Meckel's diverticulum. We know this Meckel's diverticulum, it will be having this ectopic foci from the stomach, thyroid and pancreas. So to detect this, we'll use this technetium-99m pertechnetate scan. Yeah, good guys. Fine. Next, DMSA, as I told you, it is for the structure of the kidney. SA, it is the structure of kidney, all anatomical and scars. And DTPA, it is the physiology. Kidney का function क्या है? Filtrate करना. So it will produce this GFR. So it is used to evaluate the GFR. Fine. And MAG3, it is used for this renal perfusion. Renal को कितना perfusion मिल रहा है और perfusions के साथ वो कितना काम कर रहा है. That is MAG3. So most superior when compared to DTPA to the MAG3. MAG3 is more superior than DTPA. Fine. And technetium-99m 𝗧𝗵𝗶𝗀, it is as in previous FMGE. It is the parathyroid adenoma. But in the case of parathyroid malignancies, we'll use this technetium-99m 𝗧𝗵𝗶𝗀 used for this parathyroid gland. Okay, 𝗵𝗵𝗶𝗀, it is used for pheochromocytoma. And as I told you, there are different studies which is used for this myocardial perfusion, and the most specific one kya? It is this N13 ammonia PET. It is the N13 ammonia PET, whereas thallium also will use for myocardial perfusion. Okay, whereas pyro, it is hot, so it is used to detect this hot, matlab taja, like we will call it hot, garma garam myocardial infarction, means like very hot lesions like myocardial infections. We need to pick it right away. We'll use this technetium 99 pyro, means fire, so pyrophosphate scan. Remember, next RBC scan also for GI bleed. For example, in a case of Crohn's disease or in a case of any GI malignancies, there will be very minimal bleeding that you cannot see with endoscopy, and once you do this stool occult test, this bleeding will be happening, but you don't know where it is happening. So in such cases, you will give this radio labeled RBC to in the blood, and you will see where this RBC are coming in. Fine. Remember. And MDP, we told it is used in bone scan, and iron 11, it is used for this occult abscess. For example, in the case of any mastoid abscess, or in case of any temporal abscess which is complicated, there we will use. And technetium 99M, macro aggregate of albumin, which is used for this ventilation and perfusion scan. Okay, ventilation perfusion scan for this pulmonary thromboembolism. And sulfur chloride scan, it is used to differentiate between these two things. For example, in liver, there will be two conditions will be having this central stellate scan. Yeah, central stellate scan. Okay, stellate scan. So you need to differentiate between you and front and your front, like who looks exactly similar. So because both of them you are wearing the white coat, then you will ask the name and you will ask your properties. So likewise, if you see this focal nodular hyperplasia, it is just this inflammation which is causing this hyperplasia. So in such cases, it will take up more sulfur colloid because of this high macrophageal activity. So it is known as technetium 99M sulfur colloid. It is known as technetium 99M sulfur colloid scan. Fine. And gallium 69, we told it is used in a case of sarcoidosis, and 𝗵𝗵𝗶𝗀 PET for cerebral perfusion, and ifluinospect also we told it is for this dopamine, and 18-FTG for this cancer staging, methionine, ammonin we told, sodium fluoride also we told, dopa PET also we told for extra-abdominal pheochromocytoma. Okay, and activated which is used for neuroendocrine tumors. Yesterday we studied, right, the insulinoma, gastrinoma, and 𝗵𝗵𝗻. Okay, gastrinoma, which is the Zollinger-Ellison syndrome, which will occur in a triangle which is known as Pazurow's triangle, and this is most common site of this gastrinoma. क्या it is the duodenum. Okay, and treatment के लिए हम क्या करेंगे, proton pump inhibitor देंगे. Yeah, good Dr. Nash, good. Then it can be used in a case of 𝗵𝗵𝗻. 𝗵𝗵𝗻, there will be a diarrhea along with this hypokalemia, which is an electrolyte abnormalities, and other electrolyte abnormalities as well. Fine. And DOTA PET, this is also for neuroendocrine tumors, and DOTA TET SPECT for this neuroendocrine tumor, which is both diagnostic and therapeutic as well. Fine. Yeah. In a case octreotide, that is, if we give just octreotide drug, it is used in a case of usmle varices. Okay. Then PSMA PET, it is used for prostate specific one, so it is used for this prostate cancer, and for Alzheimer's we'll use this Pittsburgh component which is known as 𝗵𝗵𝗻 PET. Okay. Then the WBC scan, as I told you, it is used for occult abscess, and Exendin PET, it is used for insulinoma. Okay, remember just a few things, like just go through this, you will just get an idea. Okay. Then about this types of radiotherapy, like we are about to finish radio with the types of radiotherapy. If you see about this types of radiotherapy, there are different types. For example, we studied about this radiotherapy for esophageal cancers, like especially for this ovarian cancer, like we studied for the cervical cancers. Okay, so in such cancers we use this radiotherapy. So this radiotherapy include regular fractionated. It is regularly we are giving and fractionately we are giving. How you are giving? If you see, you are giving this 1 to 2 gray, which is regularly, which is fractionated, like fractionated, which only 1.82 gray will give. And how will you give? You will give for regularly for 5 days per week for a duration of 6 to 8 weeks. So it is known as regular fractionated radiotherapy. Whereas in the case of fractionated radiotherapy, what you will do? You will give 5 fractions per week OD for Monday to Friday. Okay, it is the 5 one. Okay, remember. Whereas here, this dose which is being fixed, and you will give for 5 days per week around the same, and it is 6 to 8 days will give. Okay, it is around the same of regular, and it is the regular fractionated radiotherapy. And about the hyperfractionated will give more fractions. Okay, instead of OD which we are giving here, we give BD, means 2 times a day. 2 times a day will give, okay, and it is being given for this aggressive cerebral gliomas and small cell lung cancers, fine. And hypoproportionated means will give less radiations. For example, in a case of bone metastasis, is very single, only one bone metastasis. So in such cases, will give hypo, like less 5 fractions. Like see here, in a case of a regular, it is 1.8 to 2 gray of radiation, and it is given 5 days per week, once a day. Whereas hyper, it is 5 days or 5 fractions per week, 5 fractions per week, and it is what? And it is given, like it is given twice. It is the hyperfractionated. Whereas hypo, we are already giving only once. In a case of regular, we are giving only once for 5 days. So we'll reduce the days. So it is the less than 5 fractions per week, okay, and it is used for palliative, means just to decrease their pain, especially in a case of single bone metastasis, fine. And accelerated means ruka nahi ja raha, means you cannot even stop. So it is in such cases you will use this accelerated fractionated radiotherapy. For example, in a case here you will use more than 5 fractions. So here the number is 5. 5 to regular. If it is 5 OD, it is regular. If it is 5 BD, it is hyperfractionated. If less than 5, hyperfractionated. If it is more than 5, it is accelerated. Okay, accelerated. Okay, so we use this continuous hyperfractionated accelerated regimen for this non-small cell lung cancer, like for example squamous cell carcinoma and adenocarcinoma. Okay, just see, because they tested two times from this radiotherapy part, so make sure you are reading it, fine. And next, what are the other methods we'll use? This is known as remote after loading. Means you just first, as a surgeon, as a chemo oncologist, what you did, you just put up the empty pellets and you went outside the room and you made the robot to insert this thing. So this is known as what? This is known as remote after loading, which is seen in a case of brachytherapy. See, this is this radiotherapy one, and this is this empty pellets which you already inserted. Okay, fine. Yeah. In a case of CS cervix, we'll use this tandems. Okay, we measured, right, two points, point A, point B, 2 centimeter lateral from this lateral and superior to this external os, and if it is 5 centimeter, it is the point B. Remember, fine. And next, if you give from this outside, it is what is a teletherapy. And for teletherapy, we'll use a instrument which is known as linear accelerator. Means linear accelerator, which uses this X-ray, because gamma rays, they are natural rays. So means, for example, if something is natural, if river is flowing, it will flow in its own way. Okay, but if you are building some canals, you can build by your own way, and you can direct them. Likewise, if you see gamma rays, it is naturally, you cannot reduce, increase, it will produce, it will go off, that's it. Whereas in the case of X-rays, it is man-made, it can be produced. So how will you produce? You will produce based on your need. Okay, that's why we'll use the instrument which is known as linear accelerator, and it will be used for this teletherapy unit. Okay, and we'll use one more therapy which is known as stereotactic radiotherapy. Stereotactic radiotherapy means we'll keep up this radiotherapy probes which is made up of cobalt, and we'll keep in a way so that all of them will focus on this, all of them will focus on the exact tumor material. So it is known as stereotactic radiotherapy. For iske liye we will use this frame which is known as, what is the name of this frame you will use? Yeah guys? Yeah, what is the name of this frame you will use for this stereotactic radiotherapy? It is known as 𝗏𝗏𝗀𝗏 frame. It is known as 𝗏𝗏𝗀𝗏𝗏 frame. Remember, it is known as 𝗏𝗏𝗏𝗏 frame. इतना याद रखो. Okay. So this is the stereotactic radiotherapy. Mostly we'll use in a case of small tumors, or in a case of any, like this one, temporal neuralgia. Yeah, it is known as 𝗏𝗏𝗏𝗏 frame. Yeah, good. In the case of temporal neuralgia, yeah, okay. In such cases we'll use. We know we can use drugs also, but for any vessels, this one we'll use the stereotactic radiotherapy. Fine. And the final one, it is the BI-RADS and thyroids. See, BI-RADS, it is for breast reading, and thyroids, it is for thyroid radiation. Okay. 0 in a case of means, for example, when there is any breast cancer, what you need to do? You need to do yearly, yeah, good Dr. Bhargav, Anna and Mohan, Ansh. Okay? So if you see about this breast cancer evaluation, you need to know triple assessment. You need to do history taking, you need to do clinical examination and radiological examination. And this radiological examination may differ based on this radiologist. So we brought up a uniform. For example, if you are a radiologist sitting in Delhi, if you are a radiologist sitting in Chennai, if you are a radiologist sitting in Hyderabad with me, then these three people should write the same. Okay, if a female come to me in Hyderabad, or if a female who come to me when I'm in college in Delhi, then if I go to home in Chennai, then I should report the same. I should see the reports and it should be similar and it should be uniform. So it is what? It is the BI-RADS. It is the BI-RADS. Okay, it is the BI-RADS. Okay, remember. So for this we use this uniform method. So if it is category 0, then it is what? Then it is need an additional environment. You need more information to tell it is which state it is. But if it is 1, it is negative. If it is BI-RADS 1, it is negative. So we'll go for routine screening. Whereas in the case of 2, it is benign. For example, you see this popcorn appearance on mammography. Where you will see? You will see in the case of fibroadenoma, it is a benign lesion. So in the case of benign lesion also kuch nahi. Until unless it will be very much causing pain or any huge cosmetic defect, you won't do anything. Okay, so fibroadenoma, it is a benign. Yeah, good, Dr. Anna. Then about 3, it is a probably benign. Like you think it is a benign condition, but it may turn into malignant. So in such cases, you will tell them for a short-term follow-up for 6 months. Whereas 4, it is suspicious. When you have a suspicious like paranoid disorder, then you should clear it off, right? So you need to do biopsy and check whether this is malignant or not. So you need to make core cut biopsy, which is the tissue diagnosis. Fine. And next, finally, you means you have this high suspicion, yeah, this is malignancy. Then you obviously go for the tissue diagnosis. Whereas by that 6, it is already biopsy proven malignancy. They come to rule out for any post radiation therapy or post surgical residual disease. Okay, post surgical residual disease. So 0, it is incomplete. 0, it is incomplete. Whereas 1, it is negative. Whereas 2, it is benign. 3, it is probably benign. So you need a short-term follow-up for 6 months. And 4, it is suspicious. So you need to do tissue biopsy. 5, it is probably malignant. You need to do tissue biopsy. 6, it is already biopsy proven malignancy. Okay, you should remembering all these points about this BI-RADS scoring. They will ask. Yeah. That is this clinical staging. You will see pudgy orange in the case of T4B. It is seen in the case of T4B. Whereas inflammatory breast cancer will be seen in the case of T4D. Okay, good guys. Then about this thyroids, which is also around the same. 1, it is a benign, and 2, it is not suspicious, it is mildly benign. Fine. 3, it is mildly suspicious. Okay, if it is 1C, means then it is a cystic lesion. It is a cystic lesion. So as this is cystic lesion, you can aspirate the fluid. Okay, and if it again comes, then you need to aspirate again. So you need to re-aspirate, and you can do these things for 3 times. Okay, remember. And 4, it is moderately suspicious. So you need to have a yearly follow-up. Okay, based on the size of the lump. And thyroids 5, it is the highly suspicious of malignancy. So you need to do tissue diagnosis or fine needle aspiration. If there is follicular origin, then you should do biopsy for sure. Or if it is papillary carcinoma thyroid, you can go directly for this thyroidectomy. So इतना आपको याद रहना चाहिए. बिल्कुल. Fine. Then about this is how this PET scan looks like. And PET scan, it is a functional scan. It tells you based on this effect of uptake of glucose, okay, which is known as Warburg effect. Okay, because these tumor cells, they will take up much glucose than usual one. So this PET scan will use this FDG glucose, fluorodeoxyglucose, which having the T half of 120 minutes. Okay, so we'll check whether how it is uptaking. So if it is tumor cells which is having this metastasis, it will be having this red color. So see, there is a metastasis everywhere. Okay, bladder either. Okay, so remember, so it is the PET scan, and we need to know this functional scan. We need to know exactly where is the metastasis. So then we can do this MRI, or we can combine this MRI along with the CT scan, and we can tell, yeah, anatomically either means here only will be the lesion or here only will be the metastasis. So we can diagnose. So it is PET CT or PET MRI. Now we are doing. Fine. And recently they start asking about this few normal or few X-ray techniques. See, you are holding the penile urethra. Okay, mostly it is done in males, this RGO. Okay, RGO, because female urethra, it is very short. Okay, so what is the pathology will rule out there. Okay, whereas in a case of male urethra, it will be longer. So in a case of any trauma, okay, in a case of trauma or in a case of any post stricture or post stricture formation, you need to know where is the stricture. So in such cases, what you will do, you will do this evaluation. You will hold this penis and you will push the dye. Okay, you will push the dye and you will take up the film. So this is known as what? Retrogradely we are going. So this is known as RGU. RGU, okay, retrograde ureterogram. It is used for analyzing the anterior urethral pathologies like anterior urethral stricture or any anterior urethral trauma, fine. Whereas if you see a child with recurrent UTI, okay, you plan to do this investigation. You put up the catheter and you fill this catheter with dye. And now you tell the child to urinate. Okay, you clamp the catheter and now you tell the child, means see, this is the bladder. You put up the catheter. Okay, you put up the catheter. Now you fill this bladder with dye. Okay, once you fill this bladder with dye, then or this means radiopaque material, then you will be having this urinary catheter, right? Like this urinary catheter will be having this bulb. Okay, so you clamp it. Once you clamp, and you will tell the patient to urinate. Okay, urinate means it is known as micturating. The patient is micturating, so it is known as micturating cystourethrogram. It is known as MCU, which is known as micturating cystourethrogram. We will tell about the cystic, means urinary bladder pathology as well and urethra pathology as well. Fine. Okay, ureter pathology as well. See here, if there is any reflex into this ureter, it is what it is this? It is this vesico-ureteric reflex. It is the vesico-ureteric reflex. Fine. It is a vesico-ureteric reflex where you will use this MCU. Fine. And next, you have a patient who is presenting with this delayed passage of this meconium, and when you see this anal opening, there is no anal dimple. Okay, when you see the anal opening is empty. So in such cases, what you will do? What should be the location? You will keep a coin, okay, coin like this, and you will invert the baby to see how much the gas or till how much rectum the gas is there, and you will take up this instrument in investigation, which is known as what? Which is known as invertogram. It is used for this imperforate anus. Yeah, good Dr. Shrey, good Dr. Teja. Yeah, it is the invertogram. It's used for imperforate anus. Okay, we'll keep a coin at anal dimple, which usually should be there. Okay, fine. So this is all about this radiology part that you should know. Okay, if you know this thing, mostly we'll get from this radiology general one on this about this radionuclide imaging part, fine, and about the radiotherapy part. And the rest mostly we covered during your medicine surgery as well, and respective subjects you will be able to get through this, fine. What is the time now? It is 1:50, fine. We'll take around till 2:15, okay, 2:15 or 2:20, then we'll complete ortho, then we'll go for a big good decent lunch break. Okay, fine. The ortho, fine, ortho part. You're welcome. You're welcome. Do you have any doubts? If you have any doubts, please put up. Okay, good Dr. Quinn. Yeah, good. Okay, Dr. Ansha, fine. Then about the orthopedics part, there also will be like 5 to 7 questions, and they started to asking more from this orthopedics part nowadays. Okay, so this trend may even come and even persist for longer time. So just make sure you are reading orthopedics well and go, because there will be 6 and 7 questions, and out of which at least 4 to 5 questions will be from this PDF. Okay, so if you see, they will ask about this benign conditions, and if you see the single thing, if you see this single cyst which is having this fallen leaf side, okay, fallen leaf side, okay, this fallen leaf side, okay, this single unicornal bone cyst or single bone cyst or simple bone cyst which is having this fallen leaf side, okay, fallen leaf side. So this is known as what? This is known as unicornal bone cyst, also known as, yeah, simple bone cyst. So can anyone tell me in which of the following organism you will see this falling leaf motility? Falling leaf motility kahan dekhoge? Yeah, you will see this falling leaf motility in a case of giardiasis. Remember, Giardia, Girardia. So it will be having this falling leaf motility. And next, you will differentiate. Yeah, good. You will differentiate this two. It looks almost similar. It looks like a soap bubble. If they will tell you like it is different, but it looks almost similar to you, like aneurysmal bone cyst and GCT. How will you differentiate this aneurysmal bone cyst to the GCT? See, one is history, next one is the X-ray. See, this aneurysmal bone cyst, it will be it will be happening in younger, much younger. So if you see this bone plate, the bone plate will be unfused. So if there is unfused bone plate and along with this multiple cystic lesions, these are hemorrhagic. Okay, hemorrhagic means which is filled with blood. So this is aneurysmal blood cyst. Okay, aneurysmal bone cyst, which is made up of blood, and this happen in a young individual. Whereas if you see this is GCT, giant cell tumor, which will be giant cell tumor, which will be like a soap bubble, which can be seen in this distal part of this, around this wrist joint or around the knee joint. So this soap bubble, and it is occurring in this fused epiphysis. Yeah. Okay. Yeah. That's a few things will be with us, and we will be always remembering it. Yeah, good. Okay, good. A nice way to remember Dr. 𝗵𝗶𝗀𝗀. Right. So if you're able to see fused epiphysis, it is this GCT, and if you see this GCT, it will be, they will tell this classical history. On evaluation, you will be able to see this. This is the epiphyseal lesion. See, it is an epiphyseal lesion, and once you press the lesion, you will be able to see this. If you are non-vegetarian, this egg soon, right? And egg will be having a shell. Like once you crackle the egg, like how is, if you will crush the egg, you will get this sounds of crackling sound. Likewise, if you crush this one, you will be able to hear this crackling sound. That is classical feature of GCT. Yeah. Okay. Yeah. Hope so. It won't recur. We'll pray for you. You will get through this exam as well. Don't worry. You are already having this much hope to be a part of this medical community, and just try to serve, and you just serve more people, you will get more goodness and good dua. Good. Fine. So this GCT, it will be occurring in this epiphysis. Okay, GCT, it will be occurring in the epiphysis, and it is also known as osteoclastoma. Fine. And next, if you are able to see this type of mushroom appearance, especially around the knee. If you are able to see this type of mushroom appearance, it is what it is, this osteochondroma. It is what it is, the osteochondroma, also known as exostosis. Yeah, good guys, good, Dr. Shanash, good, Dr. Shanavas Khan, good. It is this exostosis, also known as osteochondroma. Fine. And next, if you see, they will ask you, there is a patient who is presenting with this osteochondroma. In options, they will give you which of the following should be evaluated for this malignancy. Then when you will consider this osteochondroma, which is being converted into a huge malignancy or a malignant condition. It is what? If the cartilage is more than 2 cm, or if there is a very rapidly increase in growth, or if the growth which will be started happening after skeletal maturity, and there is a loss of differentiation. So all of these features, it will lead to this increase in chances of malignancy. So agar koi bhi isme, means you get any of the symptoms in the question, so you will think of this is being changed into a malignant one. Okay, check for malignancy, increase in chances of malignancy. Okay, increase chances of malignancy. Okay, then if you're able to see this type of only one lesion, but remember there will be history. There is after taking NSAID or aspirin, the pain subsides. It will be written in the history. So it is what? It is the typical feature of osteoid osteoma. So if there is they will tell in history, there is a patient who is presenting with bony pain, and after taking NSAIDs, the pain is subsided, and the pain is mostly occurring at the night. So what you will think of? That is the exostosis. Yeah, there is the aspirin. Okay, fine. And if you are able to see this, yesterday we saw in the case of hyperparathyroidism, you will see there will be blood collection because of this bony resorption, which is known as brown tumor. Whereas if you see this tumor of this phalanges or the fingers, it is known as enchondroma. Yeah, good, Dr. Hans. Fine. And next, we already saw about giant cell tumor. Next, about this fibrous dysplasia. If you are able to see this type of Shepherd-Crook deformity, Shepherd-Crook. So you know, right, the shepherd, like we know mutton at least we know, right? So the mutton, it will be come from the sheep. So the sheep handler will be having this type of stick, which is known as Shepherd-Crook deformity. Yeah. This enchondroma is associated with two syndromes. One is known as 𝗵𝗶𝗀 syndrome. Okay, and this 𝗵𝗶𝗀 syndrome, it will be having this soft hemangiomas, which will be associated. Okay, associated with this soft hemangiomas. Okay, remember. Yeah. Yeah, fibrous dysplasia. It is also associated with this McCoy-Albright syndrome. Like fibrous dysplasia is associated with this McCoy-Albright syndrome. Just remember, this is a one-liner. If you want to remember, it is a one-liner. It is associated with this fibrous dysplasia. This macules will be there. Okay, it is in a case of McCoy-Albright syndrome, and precocious puberty will be there. Fine. Next, if you are able to see this 𝗍𝗗𝗏 sarcoma, this 𝗍𝗗𝗏 sarcoma, as we discussed, it is a radiosensitive one. Radiosensitive one, and it will mimic this osteomyelitis. There will be a pain. On X-ray you won't see anything, but if you see with a higher quality X-ray, you will be able to see there is this presence of this formation of onion peel. Yeah, good. It is the onion peel, and there is a presence of this diaphysis. It will involve around the diaphysis. Okay, involve around the diaphysis. And remember about this 𝗍𝗗𝗏 sarcoma. It will produce, we studied, right? Men, they are the pseudo people. They are very false people. So it will be having this 3 rosettes, which is this homocyte pseudo rosettes in a case of medulloblastoma, 𝗍𝗗𝗏 sarcoma, and neuroblastoma. And here, see, here you will see this translocation of 11, 22. E for 𝗍𝗗𝗏, E for 11. E for 𝗍𝗗𝗏, C for 11, 22. It is 11, 20. Remember, it is 11, 22, which is in the case of 𝗍𝗗𝗏 sarcoma. Fine. And here, if you are able to see, this type of Codman's triangle, and along with this sunburst appearance. Okay, here you can see, but actually, if you are able to see this type of sunburst appearance along with this Codman's tumor, both of them, it will be suggestive of osteosarcoma. And we know this osteosarcoma, it occurs after radiation exposure, so it will be radio resistant. See, radio resistant. So you are an FMGE, you came after so much of hurdles and problems, so you will be resistant to few problems. So if it is temperature, you are from Kyrgyzstan, you are from Kazakhstan, and you studied in Russia, then the temperature is normal. If it is very cold, you will feel, yeah, chalega koi na. Then if you are from the very hottest cities of China, then you will feel, yeah, hot, let it be hot. Okay, I am hot. Okay, that's it. So here in a case of osteosarcoma, you will be able to see two. This one is this sunburst appearance, and another one is the Codman's appearance. It is known as what? It is known as Codman's appearance. Fine. That's it. You need to know about this osteosarcoma. So that's why osteosarcoma, it will be resistant to radiation therapy. Okay, and it can be secondary to retinoblastoma. So radiation will cause osteoblastoma, osteosarcoma. Fine. There are complications. Means like it will be secondary to radiation therapy, secondary to Paget's disease of bone. Okay, and it is also seen in a case of retinoblastoma. Retinoblastoma. Remember, fine. Next, we'll move on to this classification, which is known as Salter and Harris classification. See, in Salter and Harris classification, type 1, it is just through, means the red color one, it is the injury one. Okay, it is the injury one. See, this is the injury one. So the injury at this level, it is very minimal. So it is just straight vicross and it is very minimal. So it will be having this best prognosis. Okay, whereas if you see, if the injury is above, okay, it forms a different fragment. See, there is a different fragment. It is a normal bone is till this much. Whereas here, if you see, it is forming a different fragment once again. So it is known as what? It is known as this fragment. It is known as what? It is known as Thurston-Holland fragment. It is known as Thurston-Holland fragment. Okay, this fragment, it is known as what? It is known as Thurston-Holland fragment. Yeah. You know this mnemonic as Salter. SALTER. So Salter means S for straight across, A for above, which is having this fragment which is known as Thurston-Holland fracture, and L for low. It will be involving like a low. It is a third one. Okay, whereas in fourth, imagine it is a 4. Okay, or like this 4. Okay, so if you are able to see like a 4, means see, in a case of here, if you are able to see, there is a fragment above, but if you see, the both side will be like above and below will be involved. So it is this 2 or through. Okay, it is a type 4. Whereas type 5, it is what? It is a huge compression force, and because of this compression, the growth plate, the green color growth plate is itself, it is not there. So there is this, it is the crush injury. Yeah, good, Dr. Shanavas. It is the crush injury which is causing this crushing of the growth plate. The growth plate will be crushed. Because of the crushed growth plate, the limb will be shortened, or the limb won't grow. So the contralateral limb will be growing, whereas this limb will be short in nature. So okay, remember, yeah, good, Dr. Gautam, good, Dr. Yeah, Bhagav. So all this type 5 will be always retrograde. Like for example, the patient has fallen from somewhere, but he landed correctly. Then he started going with normal routine life. After a few years, he feels like, yeah, this leg is or this hand is more lengthier, whereas this one is shorter. So what is the reason? When they do analysis, they found that, yeah, this is because of this type 5 Salter plexus injury. Okay, remember, and you need to know this type 2. It is associated with this Thurston-Holland fracture. It is associated with this Thurston-Holland fracture. Fine, or fragment. Fine. And you need to know about this few fractures in the arm and forearm. They are very important. Okay. If you see about this first fracture, yeah, we have time. Yeah, we'll do it. Fine. If you see about this first fracture, this is occurring at the level of supracondyle. So it is known as what? It is known as supracondylar humerus fracture. It is a supracondylar humerus fracture. Okay, see here, in the case of supracondylar humerus fracture, see, this is the humerus. This is the humerus part. This is the humerus part, and the fracture is at this level. So if you see here, this elbow will be spared. So they will call this 3-point bony relationship. So this 3 points will be there. Okay, this 3 points, when you extend, it will be in a straight line, whereas when you flex, this will be there. So this 3-point bony relationship, this 3-point bony relationship will be maintained. In a case of supracondylar fracture of humerus. So 3-point relationship will be maintained. Okay, and if it is not healed properly, this leads to this deformity, which is known as Gunstock deformity, which is a 𝗵𝗵𝗴𝗺 deformity. It is a 𝗵𝗵𝗴𝗺 deformity. Fine, and we know, we already studied in anatomy, this humerus, along with this, there is a few nerves will be there and few arteries will be going on. So if you see anteriorly, there will be this brachial artery. If a fracture happens, this is the fracture bone, and this is, imagine this is the artery. It will go on kink. It will go on, you push to this artery, it will impair the blood supply. So this is the fracture, and this is the artery. It will go on kink. It will go on irritate and kink. So the blood supply will be lost, and because of this loss of blood supply, we know it will lead to the syndrome which is known as compartment syndrome. And if there is any compartment syndrome, we will remove by this fasciotomy. Will resolve by fasciotomy. Good, guys. Right? Will resolve by fasciotomy. Good. Yeah. Good. Will put incision over the fascia and will release the pressure. Okay. Usually the normal capillary pressure is 30. If it is more than 30, we'll tell it is a compartment syndrome. Fine. And what is the first sign of this compartment syndrome? Yeah, guys. What will be the first sign? In question they will be mentioning, it will be what? It will be pain on passive stretch. It is the pain on passive stretch. Okay, pain on passive stretch, and at last only there will be a vascular injury. So last only there will be pain, and last there will be pulselessness. Okay, pain, pulselessness will be there. There will be paleness will be there. So first will be what? First will be this pain on passive stretch. Okay, itna yaad rakhna. Fine. Then if you are able to see, I told there is nerve injury. The nerve which is being most commonly injured here, it is this anterior introitious nerve. It is anterior introitious nerve, more common than this median nerve. So around this humerus, okay, this supracondylar, there will be two nerve. One is this median nerve, and the branch of it is this anterior-introitious nerve, and this can even cause this damage. And we know if there is any damage to the anterior-introitious nerve, this lead to this formation. This is normal OK, and this is OK. So it lead to this formation of improper OK sign. Okay, improper OK sign. It is seen in a case of anterior introitious nerve injury. Fine. Yeah, good, Dr. Anna, good, Dr. Koinin, good, Dr. Anush, good, best. Fine. And because of this compartment syndrome, okay, because of this compromised vascular supply, what will happen is that flexor compartment, ठीक है, हमें पता है जो भी anterior है, these are the flexors. So if it is flexors, it will be supplied by which nerve? It will be supplied by the median nerve. And because of this decreased blood supply over here, because of this, due to this injury to this brachial artery, this flexor muscles go into the atrophy. अगर जैसे ही atrophy में जाता है, it will cause spasm, and it will cause necrosis of this muscle, leading to this type of contracture, which is known as what? Which is known as this type of contracture, which is known as, what is the name of this contracture? It is known as Воркман's ischemic contracture. It is known as Воркман's ischemic contracture. Okay, it is known as Воркман's ischemic contracture. Yeah, thank you, Dr. Mumanch. It is the Воркман's ischemic contracture. Fine. Just one. Yeah. And if it is done by if this fracture is being reduced, but if it is done by this massager or this professional bone setters, then sometimes they may dislodge this hematoma, leading to this complication which is known as myositis ossificans. It can lead to this myositis ossificans. ठीक है, बस आपको इतना याद रखना. ठीक है, ये आपको इतना याद रखना. Okay. Then we'll move on to the next part where there is a fracture of this. Where there is this fracture of this lateral condyle of the humerus, where there is lateral condylar fracture of this humerus. We know this, I told you, like if they will mark this area and they will ask you which of the following nerve is passing near to this medial condyle. Okay, it is the ulnar nerve. Likewise, if there is this lateral condyle of the humerus fracture, this what will do? This won't grow. So kya hoga? This will be nerve will be passing here by this opposite side, it will start growing. Okay, the opposite side will be start growing. It lead to what? It lead to this increase in the length. So जैसे वो जैसे increase length होगा, so it will cause stretching. It will cause stretching of this ulnar nerve, causing this palsy, which is known as tardy ulnar palsy. और हमें पता है if there is an ulnar nerve palsy, it leads to the formation of this claw hand. It leads to the formation of the claw hand and adductor palsy. Adductor palsy इसको चेक करने के लिए हम बुक टेस्ट करेंगे, फॉर्मेट साइन देखेंगे. Then there is this introche, palmar introche, dorsal introche. We'll use this adduction test and AGAVA test. Adduction test and AGAVA test. ये सारे करेंगे. ठीक है? Yeah, good. And this can have a complication which is known as non-union, which is lead to this 𝗵𝗵𝗶𝘀 deformity, leading to this 𝗵𝗵𝗶𝘀 deformity. Yeah, good. Good, Dr. Ansh, good Dr. Anar, good Dr. Bhargav. Yeah, well said, well. Fine. And this is classified as Garland classification. They will ask you in which of the following fracture you will use this Garland classifications. Remember, this Garland classification is used for this lateral condyle of this humerus fracture. Lateral condyle of the humerus fracture. Fine. And here remember, here the 3-point bony relationship. 3-point bony relationship is not maintained. Okay. As I told you, 3-point. This lateral, this medial epicondyle, lateral epicondyle, and this orbicularis fossa. So if there is any damage up here, then this only 2 is there, 3 is not maintained, right? Whereas in a case of supracondylar fracture, the fracture is here. So this 3-point will be normal. If you see here, it is like in a straight line. This 3 points in a straight line. Whereas if I am doing like this, the 3-point is in a straight line. Whereas here it is this. This is known as 3-point bony relationship. So if there is any fracture of this lateral condyle, this will be gone. Okay, this will be gone. Okay, this will be gone. Okay, remember. Right. Next, we'll move on to this few more forearm fractures. If you see first fracture, which is this fracture, this is 𝗵𝗲𝗀 fracture. So how will you remember this 𝗵𝗲𝗀 fracture? Remember it as 𝗵𝗲𝗀. Yeah, it is known as 𝗵𝗲𝗀. Yeah. Lateral is lateral condyle, so lateral. So see. In the case of this here, why it is ulnar nerve here? Here it is lateral condylar fracture. So lateral condylar fracture means this one won't grow. So this medial condylar fracture means medial condyle will tend to grow. So we know near to this medial condyle there will be this ulnar nerve. So because of this growth, it will cause stretching of this ulnar nerve. It is known as tardy ulnar nerve palsy. Okay. Whereas radial nerve means it is not related much to this lateral condyle. Okay. It will go around mainly around this shaft. Okay, that's why we'll call it as during the shaft of humerus fracture. Around the shaft of humerus fracture, you will get this radial nerve injury. That is a radial drop. Okay, remember, don't confuse it. Whereas in like this, here if you see this 𝗵𝗲𝗀, here there is the fracture of this ulna and along with this radial dislocation. And we know around this radial head, there will be passage of this one branch of this radial nerve, which is this posterior introitious nerve. So this leads to the damage to this posterior introitious nerve damage. Fine. Is it of children or like, yeah, no. If you ask me, both the supracondylar fracture and this lateral condylar fracture, they are most common in children. So it is mostly seen in children. That's why we have this tardy ulnar nerve palsy. Okay, that's why. Yeah, mostly it is children's. Fine. So it is classified as 𝗵𝗲𝗀. It is why it is 𝗵𝗲𝗀. In 𝗵𝗲𝗀, you see ulnar fracture. Okay, ulnar fracture along with superior radio-ulnar superior radio-ulnar dislocation. Superior radio-ulnar dislocation, और हमें पता है around this head of this radius will dislocate and it will cause injury to this posterior introitious nerve. इतना याद रखो. So this is the 𝗵𝗲𝗀 fracture. So this is the fracture of the ulna. ठीक है, this is the fracture of the ulna along with this superior radio-ulnar dislocation. So opposite of this, it is the 𝗏𝗂 fracture. क्या है इसमें? It is the fracture of the radius. Yeah, it is the radius fracture along with this inferior radio-ulnar dislocation. Okay, dislocation. Okay, and it is the montage. It is around this upper. It is around this upper. Okay, whereas or proximal third fracture. It is a proximal third fracture. Whereas this 𝗏𝗂 side is the lower one third fracture. It is the lower one third fracture. Fine. Just remember these things. Next about this fracture, which is known as 𝗏𝗏 fracture. Okay, 𝗏𝗏 fracture. It is an remember 𝗏𝗏 fracture. It is an extra articular fracture. अगर जो भी fracture it is not involving this joints, if it is extra articular, तब हम क्या कर सकते हैं? We can put this cast, okay, and we can stabilize it. Fine. See, then 𝗏𝗏 fracture is क्या? It is a fracture of this distal end of the radius along with this posterior displacement. ठीक है? Posterior displacement. This wrist will be posterior displacement. Okay, there will be dorsal displacement seen in a case of 𝗏𝗏 fracture. There will be dorsal displacement seen in a case of 𝗏𝗏 fracture, and if it is not healed properly, then it lead to this deformity which is known as dinner fork deformity. और इसको treat करने के लिए हम कौन सा cast use करेंगे? We'll use this cast which is known as hand shaking cast. Okay, and I forgot to bring the image. It is known as hand shaking cast. So remember, आप विराट कोहली को मिले, ठीक है, आरबीसी जीत गया, ठीक है, इस बार आरबीसी बोला कि कप नाम दे, ठीक है ना, ठीक है, कप नाम दे, तो इस साल कप नाम दे, तो when they told this इस साल कप नाम दे, they got this cup. Okay, so you also passed your FMGE examination. So you went to meet this Virat Kohli. Okay, once you meet the Virat Kohli, अब क्या पहले क्या करोगे? You will do what? You will do hand shaking. फिर बोलेंगे चलो डिनर पे मिलते हैं, ठीक है. सो रिमेंबर टू थिंग्स, लाइक यू विल हैंडशेक विद विराट कोहली एंड यू विल टेल या विल कैच अप फॉर अ डिनर, ठीक है, पूछोगे, ठीक है ना, बताओगे नहीं, पूछोगे, ठीक है ना, you will ask him, like first you will do handshake. So remember, in the case of Kohli's fracture, you will be having this handshaking cast, and if it is not healed properly, okay, then it will lead to this dinner fork deformity. ठीक है, impossible, ठीक है, या कुछ चीज लगता है impossible है लेकिन possible हो गया, ठीक है ना, लेकिन होगा, ठीक है ना, जो भी like because like imagine like in few times we also thought like यार ये मेडिसिन में क्यों घुसे, ठीक है ना, हमें और कुछ और प्रोफेशन चूज करना था और बिंदास रहना था, लेकिन मजबूरी ये हो गया, लेकिन नहीं पता कैसे हुआ, ठीक है ना. वैसे ही एफएमजी एग्जाम भी ऐसे ही है, ठीक है, लगता है इम्पॉसिबल है, मुश्किल है, नामुमकिन है, ठीक है ना, बस लेकिन हो जाएगा, ठीक है ना. Everyone think like FMG is very much tough, it is very much impossible, like लेकिन once you done with it you will think यार इतना ही है, बस इतना सही है. So just remember, it is possible, ठीक है. I am not sure about this Virat Kohli part, but FMG is possible. Okay, yeah, इस साल कप नाम दे, yeah, you should have this motive, ठीक है, इस साल कप नाम दे, yeah, good. Okay, that's it. Next about this reverse Kohli's fracture, which is known as what? Which is known as 𝗵𝗵 fracture. So instead of posterior shifting, if this wrist is shifted to this anterior side, it is known as what? It is known as reverse Kohli's fracture, also known as 𝗵𝗵 fracture, also known as 𝗵𝗵 fracture. And in 𝗵𝗵 fracture, there will be what? There will be this deformity which is known as palmar or anterior dislocation or anterior displacement. Okay, it is this 𝗵𝗵 fracture. So it is the garden spade deformity. Okay. Okay, fine. Next, we'll see one more fracture where there is just intra-articular fracture. Intra-articular fracture of only one segment around this abductor pollicis longus. It is known as what? It is known as Bennett's fracture. It is known as Bennett's fracture. ठीक है, it is the metacarpal, and अगर एक side dislocate हो गया तो क्या होगा ना, means this will displace the bone fracture segment. तो इसीलिए ये इधर आ जाएगा. See, usually this will be like this and there will be a fragment. So usually if only one part means then it will be get dislocated, क्योंकि because of this tendon pull of abductor pollicis. अगर दोनों side है तो it won't dislocate. So this is what? This is the, if it is fracture of two tendons, it is what is the Rolando fracture. It is the Rolando fracture. Fine, just remember. Yeah. Next we'll see about this dislocation. Okay, anterior and posterior dislocation of shoulder and hip. ठीक है, दोनों का आसपास सेम ही है, तुम्हें याद रखना. You know शाहरुख खान? Do you know शाहरुख खान, like actor? Yeah, if you don't know, yeah. Now first see, understand, see the images. Let just move and come into the rhythm. Yeah, of course. It is the, of course, yeah, you know it, right? You know it better than me. So if you see Shah Rukh Khan, he will be doing this move. Like he's famous for this move, right? This one. Okay, so see, this is the Shah Rukh Khan move. Or you passed FMGE and घर में बोल रहे बेटा बेटी शादी कर लो, ठीक है? लेकिन तुम्हें तो प्यार करके ही डूबना है, तो means but you don't want to do just for a sake of sorry. So you want to make a relationship, then you want to get married. So you try to propose her, ठीक है? So means you want to go and propose her or him, okay? So if you want to propose, you will propose in front of them, okay? You will go and propose in front of them. So how will you propose? You will propose them anteriorly with a Shah Rukh Khan pose, okay? You will abduct your hand and you will externally rotate. So this is what? This is anterior dislocation. So this is the typical feature of this, yeah. This is the typical feature of this anterior dislocations, and you are proposing not in her back, क्योंकि if back में तो कैसे देखेंगे, ठीक है? तो it is anteriorly she or he is seeing, so you are doing your hand and you are proposing. So yeah, so if you see this one, this is in the case of anterior dislocation, this is what? This is abduction along with this external rotation. It is the abduction plus external rotation will be seen. Whereas in a case of posterior, it will be opposite. It will be what? It will be adduction and internal rotation. It is the adduction and internal rotation will be seen in a case of posterior dislocation. Okay, dislocation. Okay, and in the case of posterior dislocation, okay, you will able to see this. You will able to see this type of light bulb. Okay, this is this type of sign which is known as what? Light bulb sign. It is known as what? Light bulb sign. Okay, this is known as what? This is light bulb sign. This is seen in the case of posterior dislocation of shoulder. Okay, so there will be abduction and external rotation seen in the case of anterior, whereas adduction and internal rotation seen in the case of posterior dislocation. Okay, so ये dislocation को देखने के लिए we have few tests. One of them, it is known as Dugas test. You will tell the patient to touch his opposite shoulder. Okay? If there is any shoulder dislocation, then the patient cannot go and touch his opposite shoulder. Usually we can touch, but this patient cannot go and touch his opposite shoulder. It is known as what? Dugas test. And we have another test which is known as Hamilton roller test. See, like if I keep something here, then there will be difference. There will be difference. There is a space there, right? So because it is normal. It is normal one. Whereas if you see this image, if there is shoulder dislocation, there will be this loss of counter leading to this thing. Okay, leading to this, which is known as Hamilton ruler test. So keeping the ruler and assessing it is known as Hamilton ruler test. So remember Dugas test, Hamilton ruler test, and Callaway test and Briand test. So if you can't remember, just remember to this two things. One is this Dugas test and Hamilton roller test. Okay, and how will you reduce this? You will give traction in a case of anterior dislocation. You will do traction, external rotation, then finally adduction and medial rotation. First, it's already there, so you will give traction first. You will do more external rotation, then finally you will tell to adduct and you will medially rotate. So it is known as what? It is known as Koch's method of reduction. It is known as Koch's method of reduction. इतना याद रखो. Fine. And if there is any recurrent dislocation, तो क्या होगा? This is the glenoid labrum. This is the humerus का head. तो क्या होगा? When it's dislocated multiple times, then this anterior inferior part of this glenoid labrum and this posterior superior part of this humerus will be having this lesion. So if it is anterior inferiorly, it is what? It is the Bankart lesion. Whereas hill matlab paid. Okay, paid part. Okay, so this hill will be in top. So yeah, hill will be in top. So Hill-Sachs lesion will be in the posterior lateral in the superior aspect of this humerus, whereas anterior inferiorly we will see this Bankart lesions. Okay, remember, yeah, in the top. Yeah, good. You will see this infraglenoidal region, which is Bankart, and Hill-Sachs, it is the posterior lateral region. Posterolateral region. The same for this hip dislocation. Okay, the same Shah Rukh Khan pose. See, remember, in the case of hip dislocation as well, the anteriorly the same. It is what? It is this abduction. See, it is the abduction. See, the leg is abducted and yeah, abduction and external rotation. Okay, in anteriorly. Okay, so it is Faber. Okay, whereas in the case of posteriorly, you see, means Faber means it is flexion. See, the leg is flexed, whether it is dislocated or non-dislocated. ठीक है, कोई फर्क नहीं पड़ रहा है. Both of them there will be a flexed leg. So flexion along with here, if you see, because of the dislocation there is adduction. Now here it is adducted. So adduction and internal rotation. So Fader in the case of anterior dislocation, posterior dislocation, whereas in the case of Faber in the case of anterior dislocation. So just remember, it is this abduction acceleration for all the anterior dislocations, either shoulder or hip. Okay, इतना याद रखो, बस काम हो जाएगा. ठीक है? They will give this X-ray and they will ask you, which of the following dislocation is this in this left leg? See, in left leg, it is what the leg is adducted. The leg is adducted. So, क्या है? So, it is the anterior dislocation. Sorry, it is the posterior. Leg is adducted. It is the posterior dislocation. Whereas if you see this leg which is adducted, which is abducted along abducted, then it is what? Then it is a posterior. It is a posterior dislocation. Okay, hypoglycemia before lunch. Okay, it is a posterior dislocation. Okay? Posterior dislocation. Okay, just remember. Fine. Then about these things, yeah. Then about this, yeah, good. Dr. Srinivas, Parul, Gautam, Rituraj, yeah, good. Trisha, wow. Okay, then Dr. Anash, wow, good. You are good. Okay, you are answering well. Good. Fine. Next, we'll move on to this joint conditions. One is osteoarthritis. Remember about the first condition, which is rheumatoid arthritis. Remember? Okay, rheumatoid arthritis. Who will be more crying? Okay, is it male or female will be crying more? Okay, who will be crying? The females will be crying. ठीक है, रोना. ठीक है, रोना. Remember, rheumatic arthritis के लिए, rheumatoid के लिए रोना. याद रखो. ठीक है, the females will be crying because of this mood swings. Okay, yeah, female will be crying. So because of female will be crying. Remember why she is crying? Because she asked the guard like, whatever joint you want to take, but I want to apply nail polish. So leave the distal part of the hand. Okay. ठीक है ना, रोना है लेकिन सुंदर बन के रोना है. ठीक है ना, so she will cry. So it will be most commonly seen in females and it will spare the distal interphalangeal joint. ठीक है, बस तुम्हें इतना जानना है, it will spare the distal interphalangeal joint. ठीक है, हो गया. बस मैंने कॉन्सेप्ट अभी बना लिया. ठीक है, कॉन्सेप्ट बना लिया, फिर आगे बढ़ते हैं. ठीक है, yeah, don't start crying. Okay, we have more time. Okay, you will be with joy. Okay, it's our last day. Fine. If you see about this osteoarthritis, it will be opposite. So it will be involving this distal interphalangeal joint. It will be involving this distal interphalangeal joints. It can be most commonly seen in both males and females. And remember, it is the involving this distal interphalangeal joint. This is the differentiating factor from the other rheumatoid arthritis. Fine. So the first joint it will be involving, it is the carpometacarpal joints, and there will be involvement of this distal interphalangeal joint. Okay. Okay, fine. Then if you are able to see this, there are two nodes. One is known as HD nodes. This Herbander nodes, they are present at this distal interphalangeal joint. It is known as Herbander nodes. Whereas PIP will be showing this Bouchard's nodes. PIP will be showing this Bouchard's nodes. So BP, okay, Bouchard's nodes will be seen in the case of proximal interphalangeal joints. Whereas DIP will be having what? Will be having this Herbander nodes. Remember. And what are the X-ray findings? If you see, this joint space will become narrow joint space, and there will be small osteophytes will be there, like small tukada, means there will be small calcium deposits which are known as osteophytes. Okay, and finally there will be sclerosis will be there, and it can result into this 𝗔𝗵𝗴𝗻. Okay, 𝗵𝗵. Okay, because we know that 𝗵𝗻 which forms the rum. Okay, it is O. Okay, when you draw this O, it should accommodate the O. Okay. Okay, so you need to keep rum inside. You keep the rum bottle. Okay, rum bottle. Okay, it is a bottle of rum. So it is 𝗔𝗵𝗴𝗻. Okay, 𝗔𝗵𝗴𝗻, it will accommodate O also, rum bottle also. So it is the 𝗔𝗵𝗴𝗻. It is this 𝗔𝗵𝗴𝗻. It is seen in a case of osteoarthritis. Okay, osteoarthritis, it is a degenerative disease. It may involve this DIP and PIP. Okay, the first joint to be involved, it is the carpometacarpal phalangeal joints. Okay, so इसको treatment के लिए usually osteoarthritis के लिए it is a degenerative disease. So we'll give this physical therapy, weight reduction therapy, or if there is pain, we'll give NSAIDs. Pain will give NSAIDs, and in some extent we can go for this intra-articular injection of steroids, or because of this narrow joint space, हमें उसका inflammation भी कम करना, space भी increase करना. So sometimes we can use this hyaluronic acid as well. तो इसे the simple initial management. Okay, अगर कुछ भी नहीं हो रहा तब like most commonly will go for total knee replacement. ठीक है ना, तो पहले इतना था बहुत, अभी तो बहुत करीब आ गया और पास आ गया, means it came much near to it, so it will do total knee replacement. Okay, इतना याद रखो. So osteoarthritis, it forms O, so it will cause this 𝗔𝗵𝗴𝗻. Then it will involve this DIP, PIP, and the first joint to be involved is the carpometacarpal phalangeal joints, and there are two nodes, Herbander nodes and Bouchard's nodes. Herbander nodes at the level of DIP and Bouchard's nodes at the level of PIP. Remember. And the X-ray, you will be able to see there is a reduction joint space. Okay, so initial management is lifestyle management along with NSAIDs. और कुछ नहीं हुआ तो total knee replacement कर दो. Okay. Then about this rheumatoid arthritis, as I told you, it is most commonly involving, this rheumatoid arthritis, it will be most commonly involving in females, and it most commonly involves this joint, or it will be involving this joint, which is the PIP. And here the most common joint, if you see, it is this MCP joint, wrist joint. This will involve this wrist joint also, metacarpophalangeal, and mainly this distal interphalangeal joint. And it will be having these two deformities. One is known as swan neck deformity, another one is known as Bowden's deformity. If you can make this swan neck, it's fine, but don't confuse this with also a swan neck. So remember, if you not, then just see, you have this button, right? This buttonhole. See this buttonhole. Likewise, you need to make the buttonhole. See, take your finger, like bend like this, Here now you will be able to see this buttonhole here. Here you will be able to see the buttonhole. So remember, this is the Bowden's deformity. So Bowden's, it is the buttonhole deformity. Okay, Bowden's is the buttonhole deformity. See here at the end of distal interphalangeal joints, you will be able to see there is what? There is hyperflexion, like hyperextension. Here it is the hyperflexion at the rate of proximal interphalangeal joint. So this is the Bowden's deformity. Whereas opposite of this, it is the swan neck deformity. See swan neck, it is what? It is this hyperextension at here and hyperflexion at the distal interphalangeal joint. Itna yaad rakho. Okay, yeah. So just remember one thing and make the questions correct. Okay, at the end of the day, to make questions सही करना, ठीक है ना? Questions सही करना, ठीक है? Just remember. Yeah, thank you, Dr. 𝗵𝗲𝗀. Okay, yeah, this is swan neck deformity and Bowden's deformity, and sometimes it will show this ulnar deviation, which is known as Z deformity. ठीक है, इतना याद रखो. And here you will able to see an X-ray, you will able to see this periarticular osteopenia. Okay, and here there will be symmetrical joint space narrowing. और हमें पता है डायग्नोस करने के लिए हम दो एंटीबॉडीज यूज कर सकते हैं. वन इज एंटी सीसीपी एंड एंटी रूमेटॉइड फैक्टर. और मोर स्पेसिफिक इट इज क्या? इट इज द एंटी सीसीपी, इट इज द मोर स्पेसिफिक वन. ओके, एंड ओके, मोर स्पेसिफिक वन. सो अक्यूट स्टेज के लिए हम क्या क्या कर सकते हैं? वी कैन यूज स्टीरॉइड्स और एंटी इन्फ्लेमेटरी ड्रग्स लाइक स्टीरॉक्स. फिर उसके बाद हम क्या कर सकते हैं? डीएमआरस लाइक डिसीज मॉडिफाइंग एजेंट्स फॉर दिस रूमेटॉइड डिसीज. क्या? हाइड्रोक्सीक्लोरोक्विन, सल्फासालाजिन, methotrexate. Okay, hydroxychloroquine, sulfasalazine and methotrexate. अगर methotrexate दे रहे, then we need to give supplement with folic acid as well. ठीक है? तो biological inflammation अगर बहुत serious है, तब we can give more biological one like infliximab, etanercept and adalimumab. Infliximab, etanercept and adalimumab. Infliximab, adalimumab, like etanercept and adalimumab. ठीक है? 3 drugs देंगे. ठीक है? Next, you say male. कि अभी male पे आता है. The male is having complaints of unable to bend. Okay, unable to bend, and he's having features of pain around the sacral region. Okay, around this pain around the sacral region. So these two, and along with this, he's unable to move and make movements in this vertebral level, or unable to bend. So all of these features, it will be suggestive and most commonly morning and males who is positive with HLA-B27. It is what? It is the ankylosing spondylitis. Okay, ankylosing spondylitis. Okay, and in the case of ankylosing spondylitis, here there will be a stiffness of the back will be identified by this test, which will tell them to bend, which is known as Schober's test. और हम radiologically देखेंगे, then the central, there will be this central calcification, which is known as what? Dagger sign. Then if you see, there will be this internal disc, IVD also will get calcified. So this one will be known as what? Bamboo spine, and there will be inflammation around this vertebra, leading to this. Initially there will be shiny corners, followed by this squaring of vertebra known as squaring of vertebra. Next, this shining, it is known as Romanos sign. Okay, and it is HLA-B27 positive, and it will be associated with this uveitis. I mean, it is associated with this uveitis. Okay, mostly the anterior uveitis. Okay, it is this ankylosing spondylitis, which will causes inflammation over this sacroiliac joints. Okay, sacroiliitis in young male females, which is HLA-B27 positive. Okay. Next about the pseudo-gout and true gout. Pseudo-gout and true gout आपको याद रखना है. Pseudo-gout, it is a erosive disease, मतलब it produces erosions. ठीक है, rat bite erosion. जैसे चूहे काटते हैं ना, चूहे means rat, how it come and cut the carrots. Likewise, it will come and cut your bones. See, this is the rat bite erosions. Okay, rat bite erosions you will see in a case of bamboo stick appearance with central spurs. We will see in a case of business anthracnose. Yeah, nice, good catch, guys. See, this gout, we know it is due to the increased level of uric acid. Okay, and this gout, you will be able to see this type of rat bite and erosions. Okay, which is known as Martel's J sign. Okay, and in the case of pseudo gout, It is most commonly seen in knee joints, and if you see here, there will be a presence of this calcification here. This is known as meniscal calcification. ठीक है, अगर erosion उन्होंने बोला, then it is gout. If they say it is the calcification of this menisci, then you will think of it is what it is, this pseudo gout. And remember how they will differentiate. How they will ask you how we differentiate. We'll do a test which is known as, with microscopy, we'll go for this bireferencement testing of the crystal. Okay, whereas in the case of pseudo gout, everything will be PPP. Pseudo gout, yeah, pseudo gout, it will be positive for bireferencent. Okay, bireferencent, because it will be having this calcium phosphate. Okay, calcium phosphate, especially calcium pyrophosphate. Remember, it is pseudo positive and it will be calcium phosphate crystals. Okay, whereas in the case of gout, it will be needle. It will be needle shaped crystals. It will be negatively. N for N, it is needle and it is negatively bireferencent. It is negatively bireferencent. Okay, remember, and the crystal is monosodium urate crystal. Okay, and here the first joint it will be involved is the first MTP, whereas in the case of pseudo gout, it will be forming the calcification inside the meninges. It's like not meniscus, so there will be a meniscal calcification. Meniscus हमें पता है वो knee में होता है, तो pseudo gout, it is classically involving this meniscus. Okay, yeah. In pseudo gout, you will be able to see rhombus, rhomboid shape, yeah. See, these are the signs you need to know. Next one about this important one, this is this pediatric orthopedics. They will ask one question from this pediatric orthopedics. What is developmental dysplasia of hip? Because means India it is very rare, because we keep the children in the godi mein bitate hain. ठीक है ना? So because of this, there is less recurrence, less incidence of TDH in India. Means godi means madi loga rakha. Means like they will keep their baby here, right? So it is DDH. Okay. So the inverse, in the case of DDH, it is this displaced hip which is causing this dislocation. So usually this is the normal hip and this is dislocated hip. So you can see this line which is known as Shenton's line. So there is a break in this Shenton's line. There is a break in this Shenton line. Okay, there is a break in this Shenton line. So this is a dislocated line. Okay, dislocated one. So here for diagnosis will use, as I told, this is children, will use MRI. We will use MRI and start with ultrasound. So we'll start with ultrasound, we'll go for ultrasound, we'll go for MRI. And we'll do two tests. See, two tests. What are the two tests? If you go to bar, what you will do? If you go to bar, what you will do? You will keep on adding the pegs, So if you keep on adding the pegs, at some point you need to come exit. So finally it is exit, it is dislocation only. But in a case of Barlow's test, you will keep on adding. So if you do adduction and the hip dislocates, it is known as Barlow's test. Whereas it is opposite, which is this Ophthal test. If you do reduction by abduction, it is what it is, the Ophthal test. Okay, Ophthal test, it will be entry. Okay, just remember. Okay, entry. So Barlow's, you will keep on adding the pegs, so it leads to this exit. So it is known as Barlow's test. Okay. And for this management, we use two things. One is known as Pavlik harness. So Pavlik's harness, and this is the von Rosen splint. Okay, von Rosen splint, which we use for this 0 to 6 months child. For this 0 to 6 months child, yeah, that is barley, yeah, that is bro one, yeah, good, fine. Then for 6 to 18 months, then we will reduction with the hip spica. Okay, also known as bachelor's cup. Hip spica will keep. Just search this and we'll get it. Fine. Next one is known as perthes. Perthes is nothing but it is a necrosis of this femoral epiphysis. This femoral epiphysis become necrosed because of this avascularity, or because of this obesity, or because of some idiopathic reasons. Okay. So we know if there is any necrosis of this head, will be seen as yearly with the help of MRI. And we know it is a pediatric condition, फिर भी हम MRI करेंगे, ठीक है. So treatment के लिए हम एक कास्ट लगाएंगे, उसका नाम है broomstick cast. Okay. Then what this here you will be able to see in X-rays, you will be able to see this sagging rope sign, also known as crescent sign, you will be able to see here. Fine. Just see as a mnemonic this Perthes disease. It is the avascular necrosis of this femoral head, and along with this for diagnosis we will use MRI. Okay. The next condition is known as CTEV, congenital talipes equinus and varus. Fine. Congenital talipes equinus and varus. And if you see this will be most commonly prevalent in India, and it will be characterized by 4 deformities. One is this cavus, adduction, varus and equinus. Cavus means exaggeration of this medial arch, and adduction means exaggeration of this forefoot adduction, and varus means there is subtalar. Varus its levels happens at the level of subtalar, and equinus means ankle joint. Okay, equinus means ankle joint. So if you are able to remember, well and go. If not, remember it is cave. cavus, adduction, varus and equinus. Cavus, adduction, varus and equinus. बस इतना याद रखना, ठीक है, in depth में नहीं जाना, ठीक है. For this treatment, we'll use this type of splint. Okay, what is the name of the splint, guys? What is the name of the splint? It is known as Dennis Brown splint. It is known as Dennis Brown splint. Yeah, good Dr. Anna, good Dr. Muhammad Shanwas Khan, good Dr. Gautam, good Dr. Ansh. Okay, it is known as Dennis Brown splint, and they will be having this special shoes. If you see normal shoes, it will be this side. Whereas in a case of CTV shoes, you will be having this outer rise and without heel. Okay, outer rise without heel. So this is a classical for this CTV patients. Okay, CTV patients. So itna yaad rakho. Fine. And initially we'll do for this Dennis Brown splint. If they present in late, then we'll do for orthodosis procedures. We'll go for this orthodosis procedures. Okay. Then about these two diseases, we studied them in biochemistry as well. See, 𝗶𝗏 means first we'll see rickets. Rickets, it is what? It is decreased calcium. Decreased calcium, calcium decrease. Then because of this, the bone formation will be impaired. Okay, bone formation will be impaired. And radiologically आप कैसे देखोगे? Okay, radiologically आप देखोगे these three findings which are known CSF. Cupping, splaying and fraying. Okay, कप बन रहा है, ठीक है, कप बन रहा है, ठीक है, अंदर में थोड़ा थोड़ा फायर जैसा फ्रेइंग है, ठीक है, फिर उसके बाद साइड में स्प्ले हो रहा है, ठीक है, तीनों cupping, splaying, flaying and spraying. All of this thing will be seen in case of rickets. Cupping, flaying and fraying, cupping, flaying and spraying. And as I told you, this rickets, it is painless condition. So whatever thing, there will be a ricketic rosary will be there. There will be a windswept deformity will be there. There is a 𝗵𝗵𝗶𝗀𝗃 will be there. So all of them, it will be painless in nature, and all of the manifestation, they will be manifest in bones. There will be a ping pong skull, also known as craniotabes will be there. So this is a typical feature of this rickets. और इसको treat करने के लिए मैंने उसी दिन भी तुम्हें बताया कि it is the regimen which we use, which is known as Strauss regimen, where we'll use this single dose of vitamin D, which is around 3 to 6 lakh based on the weight, for either IM or oral dose. IM or oral dose. This regimen is known as Strauss regimen. Okay. From here you will be able to see ricketic rosary, and because of this diaphragm pull on this ribs, it will be having this Harrison's groove, and you will be able to see a line which is known as white line of Frankel. When you start giving the treatment, there will be new calcification will be happening. It is known as white line of Frankel. It is known as white line of Frankel. Fine. Next, leg will be having this knock knees, or this means windswept deformity and 𝗵𝗵𝗃 and 𝗵𝗵𝗃. Okay. Then scurvy मैंने बोला, scurvy it will cause, it is due to the defect in this vitamin C causes hydroxylation of lysine and proline. Hydroxylation of lysine and proline. Okay. And this hydroxylation of lysine and proline will be used in a case of, will be used helpful in formation of collagen. So if there is any problem in this collagen formation, then it lead to this improper collagen formation. अगर ये improperly collagen बना, then it leads to this leaky blood vessels and causing this periosteal hemorrhages. It will cause this periosteal hemorrhages. ठीक है, periosteal hemorrhages. तो याद रखो. If you want, you can remember something like, तुमने क्या किया? You passed your FMGE examination and you went to a mall, okay, and you went for a movie, okay, went for a movie, okay, with your friend or whatever. Fine. हमें पता है, means they told the movie will start at 8:25 PM, लेकिन you went at 6 PM. तो अब क्या करोगे? Okay, अब क्या करोगे? आप फूड जोन में जाओगे, ठीक है, फूड जोन, ठीक है, रिमेंबर. ओके, सो देयर इज अ जोन्स विल बी अवेलेबल हियर. तो फूड जोन में आप क्या खाएंगे? बर्गर खाएंगे. Will eat burger. Okay, burger. Okay, then we'll eat the burger, and we know this burger sometimes it will be having this French fries, right? And this French fries will come and nick your oral cavity, and it will cause bleeding. Okay, इतना याद रखो. Okay, bleeding. Okay, because of this side, like this, the burger will be there, and side there will be this, because like spur like this potato chips will be there, right? French fries will be there. So okay, there will be a French fries, and you are taking a French meal, and there will be this burger. There is a French fries. So it is just a story. Just remember, here you will be able to see this burger. Okay, this burger. So here you will be able to see this 𝗵𝗵𝗃 sign. 𝗵𝗵𝗃 sign, and burger is also ring. This is the 𝗵𝗵𝗃 ring here. Then there is this. We are taking this French fries. So remember, it is a Frankel. It is a French fries. Remember, it is a Frankel line. F for F, it is the Frankel line. And here it will be showing this type of spurs, like your French fries. It is known as 𝗶𝗀𝗀𝗀. So there will be 𝗵𝗵𝗶𝗀 ring along with this 𝗶𝗀𝗀𝗀 and along with this white line of Frankel. So all of them will be there. If you are able to correlate the story, keep it. If not, just leave it and remember these things. 𝗵𝗵𝗶𝗀's line and white line of Frankel and along with this 𝗶𝗀𝗀𝗀, and there will be a features of bleeding, gum bleeding. Okay, and the mostly this scurvy, it will be painful in nature. Scurvy will be painful in nature because there will be hemorrhage and will lift up the periosteum, and we know the periosteum is highly innervated. Okay, so it will be painful in nature. Okay, itna yaad rakho. Then we'll move on to this TB of vertebra. We know this TB, it will involve this, especially this paradiscal space. Yeah, paradiscal space, and if there is involvement of this paradiscal space, this TB will cause collapse of this vertebra. Okay, and to treat this, we can do two things. We can do surgery at the same time, and we also need to start with ATT. So this going in between, it is known as middle path regime. Okay, it is known as middle path regime. Okay, this is the vertebra, this is the vertebra in between the disc. So in TB, there is this disc involvement. That's why collapsing of the vertebra will be seen. Okay, yeah, good. That is the middle path regime, and the name of this thing, spinal TB, it is known as pot spine. And they asked this about this TB of hip. Okay, or in this TB of hip, if you see, the most common site, it is the acetabular roof. It is the most common site of this TB hip. Okay, the second most common site, it is this epiphysis of this femur, and third one, it is this metaphysis, and fourth one, it is the greater trochanter. So these are the sites where TB can go and settle down in hip. Okay, and there are few stages: stage 1, stage 2, 3 and 4. Stage of synovitis, early arthritis, stage of arthritis, and advanced arthritis. See, in a case of synovitis, you will feel pain. So what you will do, you will flex and abduct. So you will keep for the position of ease. Like if you keep it somewhat distant, you will feel some relief, right? Relief from the pain. So it is what it is, the flexion, abduction and external rotation. Okay, flexion, like for example, when you want to free, you will go to the bed and you will lay, right? So likewise, you will externally rotate and you will keep your leg abducted. So it is the stage of synovitis, and followed by this, everything will be the same. It is the flexion, adduction and internal rotation, flexion, adduction and internal rotation, and flexion, adduction and internal rotation. And because of this, there will be happening of this thing which is known as shortening. Okay, there is an infection हो रहा है, तो infection हो रहा तो the bone will got affected and there will be starting of the shortening. ठीक है, बस इतना याद रखो. Synovitis में there will be, you need to keep, there is inflammation going on, there will be a painfulness, so you need to keep at the position of ease where we will do this abduction. You will keep your leg outside and externally rotated. Okay, इतना याद रखो. Fine. Next, about these few instruments, we'll see and we'll wind it off. Fine. If you see about this knuckle bender splint, where you will use this knuckle bender splint, you will see in the case of claw. Okay, where you will use this cock up splint, a good Dr. Ansh, good Dr. Quinin, good Dr. Shanavas Khan. It is what it is, this cock up splint. Where you will use this cock up splint, yeah, cock up used in the case of radial nerve injury. And where you will use this aeroplane splint, you will use this aeroplane splint in a case of brachial plexus injury. Fine, yeah, good. Then this is this Adams forward bending test used for identifying the scoliosis. Yeah, no, it is the Schobers test. Schobers test we use for anterior, that also will use, tell them to bend, whereas here we will be able to see the symmetry. It is what it is, this scoliosis will use. Okay, whereas in the case of the Schober test, he will be having painful detection. Here there will be no painful in the case of scoliosis, and we'll use this type of brace where, see, there is the support here. Okay, one rod anterior and two rod posterior. It is the 𝗵𝗵𝗀𝗀 brace. Whereas if you are able to see, there is a pass at the level of axilla. Axilla ke पीछे एक pass है, तो it is the Boston brace. It is the Boston brace. Next, this is the Taylor's brace for TB spine, which is the spot spine. Then this is known as our Jaipur foot. It is the Jaipur foot for after this rehabilitation. Fine. And this is the dynamic hip screw. Okay, this is the dynamic hip screw. Then initially, if there is a fracture of the head of femoral, then we'll keep this dynamic hip screw. This is screw and this is movable, so it is known as dynamic hip screw. Fine. And there are these two processes which is known as Austin Moore. So Moore matlab there is more. There is a more holes. So if you are able to see this type of holes in this this arthroplasty process which is used for this partial arthroplasty in a case of head of this femur. This is what this 𝗲𝗔𝗔 prosthesis. Whereas if you're able to see, there is no holes. It is the Thompson prosthesis. Yeah, Thompson prosthesis. Yeah. That's what, like, this is the questions which you often get, because these are these topics. That's why it is a must known important topics. That's why we are having this game changer. If you know this, your game will be changed. You will be out of this race. If you are 149, you will be getting 150 and you will pass the exam. That is the game you want now. Okay, fine. Next you will see this type of circular one. It is what? It is this 𝗲𝗏𝗀. It is 𝗲𝗏𝗀 one, which is an external stabilization. Yeah, name changer from a just doctor to this registered doctor in India. Okay, just feel कैसे होता है, ठीक है ना? Just doctor to this registered doctor. No, that is a really, like, when you have this number now, you can tell, hello, ठीक है करके. No, that is an अलग feeling. You will come. Okay, and good time will come for you. Like, we'll pray for you, and just keep your work hard, and you just be consistent with this your efforts. You will be coming out with flying colors. Okay, इतना तो मुझे पता. ठीक है. So this is this ring shaped one. That is the 𝗲𝗏𝗀 fixator, and if it is straight or parallel one, it is the rail fixator. It is a rail fixator. And next sometimes they will give you this ring of X-ray. This is the same 𝗲𝗏 fixator. 𝗲𝗏 fixator. It is 𝗲𝗏. Okay, and this is the bone cutter and bone holder. And we saw in a case of unusual bone, cyst, we need to remove this inside hemorrhages. So we need to remove one by one. So we'll use this type of scoop, which is known as unusual bone scoop. We just call it as bone scoop. We'll call them as bone scoop. Okay, and these are the 3 pins. Okay, see, this is the K wire. Okay, this is Steinmann pins. These are 2 pins, K wire and Steinmann pins. Okay, usually K wires, they're very much thin and used in distal procedures. Like, for example, in the case of olecranon fracture, they will use this thing which is known as tension band wiring. Or if any fracture here, we'll just put up this K wire and do it. Okay, so these are all about this orthopedics part that you need to know. Okay, guys. Then we'll have a lunch break. What's the time now? It is 2:49. Yeah, we are exceeded the lunch limit. Yeah, it is 2:49. Then we'll meet up around 3:30. Okay, we'll meet up around 3:30 and we'll take for 1 hour and we'll complete it. Fine? Yeah. Fine? Yeah, 2:49. We'll meet up around 3:30. Okay, if any doubts, please post in the chat section. We'll catch up. Fine? Just 2 more subjects left. Then your game will be changed and your name will be changed. Okay, that's it. Bye bye, guys. Hello doctors, welcome back to the game changer part of Dr. 𝗏𝗲𝗀𝗃's session. And in this, we have two more subjects left, which is the dermatology and the anesthesia part. And we'll do this and we'll complete with this our game changer session. And if you have any doubts or something, we'll take up in the last. Fine. But don't worry that the PDF are in the sharing form. Like it will be you will get it soon. Okay, don't worry, you will get it soon. Like, guys, are you connected? Yeah. Yeah, it's yeah, we are back. I guess everything audio and video is clear. Can you please confirm from your end, guys? Can you please confirm whether the audio and video are clear? Okay, thank you, Vanki. Thank you, 𝗏𝗵𝗶𝘀. Yeah. Yeah, thank you. Fine. Yeah. Thank you, Aishi. Yeah, fine. Thank you, Trisha. Yeah. Thank you, Gautam. Yeah, fine. Then welcome back. We'll start with dermatology and we'll move on with anesthesia, which will be our final part. And we'll try to finish it by 4:50, 4:15. Okay. No, sorry, now it is already 4:50, right? Around 4:50 we'll finish it off. Okay, yeah, we'll begin. And if any doubts, just keep it with you and we'll answer at the end of the session. Yeah, we'll share all the annotated PDF. Don't worry. Yeah, don't worry about the PDF part. We'll take care of it. Fine. We'll move ahead with dermatology. The same about dermatology. There will be around 7 to 8 questions from the dermatology part, and if you read this, it is more than enough for dermatology. Okay, don't bang your head with new things. Try to revise this notes and try to do the PVQ part. It will be helpful for you. Fine. Yeah, fine. Okay, cool, Dr. Ansh. Fine. Next, about this alopecia areata. There are different types of alopecia. One of them is what? One of them is alopecia areata. If you see about this alopecia areata, it is what? It is an autoimmune disorder. It is the autoimmune disorder which affects your hair follicles. It affects your hair follicles, and because of this autoimmune disorder, what will happen is that there will be a hair follicle, and once there is this hair follicle, it will be attacked by this swarm of lymphocytes. It will be attacked by this swarm of lymphocytes. Okay. So because of this, and histologically, if you see, there will be what? There will be this swarm of B appearance of lymphocytes here. Okay. There will be swarm of B's appearance in histologically. Fine. And under the examination, this is known as strioscopy. When you examine the hair, you will be able to see this type of sign, which is known as exclamatory sign, which is known as this exclamatory sign, which is seen in a case of alopecia areata. Alopecia areata. Fine. And just, yeah, good, Dr. Mohammed. See, if you see in a case of any other part of hair loss or any other type of hair loss, this alopecia areata, it is different. How? This alopecia name itself areata, it will cover only minimal area. It will only cover a small part of area of this head, or there will be a patchy, it will be in a patch. So there will be a patchy hair loss will be seen in a case of alopecia areata. Along with this, there will be a presence of exclamatory mark, and usually if there is a there will be two types of hairs will be there. Normally black hair will be there, and there will be a small grayish or vellus hair will be there. All of the normal black hair will be affected, whereas this vellus hair or this small grayish hair will be unaffected. That's why it will be showing this phenomena, which is known as gray hair phenomena. Okay, just remember. So they're presenting with this broken hair, which is showing this exclamation mark. Okay, and on histopathologically, you will be able to see this swarm of P appearance. Fine. And for treatment, what you will do, as it is an autoimmune disorder, you need to start with this intralesional steroids. You need to start with this intralesional steroids or this intralesional drugs. Okay. And it is a treatment of choice, or you can even use oral corticosteroids if there is more than 6 to 8 pages. Because what we will do, we will take this intra-lesional steroids and we'll start applying based on the square by inch. Okay, based on the square inch, we will start applying. Whereas if it is more lesions, then you need to go for oral corticosteroids. So it is an autoimmune disorder with patchy hair loss, with exclamatory sign, along with this graying of hair phenomena, and finally you will give intra-lesional steroids. You will give intra-lesional steroids. बस इतना आपको याद रखना है, ठीक है? Yeah, most of them, anything start with A and T, like it will be non-scarring. For example, alopecia areata, androgenic alopecia, fine, all of them, fine. Then about this part, which is androgenic alopecia, it is due to this hormonal changes, especially this androgenic alopecia. It is most common in males when compared to the females. In males, what will be the typical pattern? It will be what? It will be recessing of this forehead. Okay, the forehead will be starting recessing so that the hair will still keep on going backside. So it is because of this testosterone. We know this testosterone will be converted into this dihydroxytestosterone by 5-alpha reductase, and this is responsible for this conversion of this hair. Okay, conversion of this hair. So this is what causes this androgenic alopecia. It means usually this dihydrotestosterone which causes what? Which causes this growth of the hair, whereas here it will be mismatched, so it won't be protection of this hair will be there. Here the male pattern hair loss, if you see, this frontotemporal recession means the frontal area and temporal area, the hairline will start going back. So it is known as frontotemporal recession. It is known as frontotemporal recession. Okay, and this will be classified as Hamilton classifications. There is known as 𝗧𝗵𝗶𝗀. Okay, there is this classification. Okay, just remember it is this Hamilton classification. It is known as Hamilton classification. Fine. And how will you manage it? For example, this is most common in males, but it can be associated with this females as well. So if it is female, we'll give lesser percentage of this drug, which is known as minoxidil. We'll give 2% minoxidil in a case of female with this androgenic alopecia features, whereas in the case of males, we'll give 5% minoxidil. In the case of males, we'll give 5% of this minoxidil. Fine. And we can use this anti-androgen drugs, okay, like for example, 5-alpha reductase inhibitors. 5-alpha reductase inhibitors. Like actually what does this? It will convert this terminal hair, this proper black hair into this vellus hair. It will convert this terminal hair into this vellus hair. Because of this, there won't be any proper terminal hair, and all of this terminal hair will be lost. Only the vellus hair will be left. Okay, just remember, only the vellus hair will be left. Yeah, good guys. The 5-alpha reductase inhibitor, one of them, it is what? It is this drug which is known as 5-alpha reductase inhibitor, which is an finasteride. Which is an finasteride. Fine, remember. And then you must be seeing a psychiatric female or a female, psychiatric female, or mostly a females who is presenting with this emptiness or the area which is easily accessible, which is having this patchy hair loss. Okay, there is a patchy hair loss in accessible areas. Yeah, accessible areas, and along with this, hair with variable length. Hair with variable length. Okay, and on examination, you will be able to see this perifollicular hemorrhages. Perifollicular hemorrhages. So all of this thing, hemorrhages. So all of this thing where there is in accessible areas where you will be able to get this patchy hair loss, and then hair of different lengths. Like one is this length, next one is this length. So hair with different length, and along with this, because of pulling, there will be a bleeding happening there. So this leads to this perifollicular hemorrhage. So all of them will be classically seen in a case of trichotillomania. Yeah, good Dr. Gautam, good Dr. Parul. This is seen in the case of trichotillomania. And remember, this trichotillomania, then the patient can be a psychiatric. So in such cases, he can eat. So it is known as 𝗏𝗏𝗏𝗏. 𝗏𝗏𝗏𝗏. Okay, 𝗏𝗏𝗏𝗏. So these are this few alopecia that you need to remember of. Okay, this androgenic alopecia and alopecia areata. Okay, there is two more types of alopecia. They are known as effluvium. One is known as androgen effluvium, another one is known as tenogen effluvium. Remember, anagen effluvium and telogen effluvium. Okay. This anagen effluvium, it will be happening in a case of chemotherapy. In a case of chemotherapy, whereas this telogen effluvium will happening in a case of tension cases. For example, when there is a tension, okay, during the phase where there is a pregnancy, where there is a chronic illness. In such cases, yeah, in such cases, this telogen effluvium will be happening. So telogen will be happening in tension, or an anagen effluvium will be happening in a case of chemotherapy. In a case of chemotherapy, especially. Remember this thing. Yeah, good guys. Next, we'll come on to this few nail changes. If you're able to see this type of elastotic degeneration, which is known as what? Which is known as pterygium, and this pterygium will be classically seen in a case of lichen planus. Lichen planus, you will see this pterygium. And next, if you're able to see this type of fingers, where this, instead of like this fingers, it will become like a drumstick, and the angle is not maintained. 𝗏𝗏𝗏𝗏 angle is not maintained. So it is what? It is this clubbing of the finger, which is especially seen mostly in a case of pulmonary disease and few cardiovascular disease also this may see. Okay, remember, it is mostly seen in a case of pulmonary disease where there is decreased oxygen fusion. Okay, diffusion. Remember, yeah, there is a features of, it is a features of hypoxia. Next, if you are able to see this type of spoon shaped nails, spoon-shaped nails. These are typical for the spoon-shaped nails. They are typical for this iron deficiency anemia. They are typical for this iron deficiency anemia, which is known as 𝗏𝗏𝗀𝗏𝗃. 𝗏𝗏𝗀𝗃 means spoon-shaped nails. Remember, fine? Yeah, good. And okay, fine. Next, if you're able to see this type of whitish lines, able to see this type of whitish line which is seen here, this type of whitish lines on this nail bed, it is known as what? It is known as 𝗓𝗨-Mees line. We know this type of 𝗓𝗨-Mees lines, it is classically seen in a case of poisoning with arsenic, and it can also be seen in a case of thallium poisoning. Okay, remember, yeah, good Dr. Ansh, good Dr. Shanavas Khan, good Dr. Gautam. Fine, that's good. Fine, this type of whitish line, it is what it is seen in a case of arsenic poisoning. Next, if you are able to, this type of nails where there is this presence of leukonachia, this type of leukonachia, it will be classically seen where there is presence of this decreased protein amounts. For example, they are known as Terry's lines. They are seen especially in a case of liver dysfunctions like cirrhosis, or it can be seen in a case of congestive hepatic failure or diabetes mellitus. So all of these conditions, especially in a case of any liver pathologies like cirrhosis, can present with this Terry nails. Fine. Next, if you see this next nail, which is known as half and half nails. Okay, half and half nails, it is known as Lindsay nails, and this Lindsay nails, it will be classically seen in a case of renal failure. Okay, so this is the cirrhosis and congestive heart failure. Okay, heart. Fine. So this half and half nails, also known as Lindsay nails. Okay, see, it is half, and it is also apparent leukonachia. Means you see this is looking like half of the nail it's white. So this apparent leukonachia, it is known as what? Half and half nails, also known as Lindsay nails. Fine. And next, if you are able to see this type of things, they are known as what? They are known as pitting. This pitting, there are two types of pitting. One is known as regular pitting, and another one is known as irregular pitting. Irregular pitting. See, regular means this is the regular pitting. Whereas irregular matlab, you will see one is small, one is large, one is small, one is large. This is irregular pitting. This type of regular pitting will be seen in a case of alopecia areata. Whereas this type of irregular pitting will be seen in a case of psoriasis. Okay, psoriasis. Yeah, good Dr. Gautam, good Dr. Ansh. Fine. Next, if you are able to see this nail where there is around this nail bed, you will be able to see there is a pus formation due to the infection over here. That is known as paronychia. Around the nail, it is known as paronychia. Okay, paronychia. And we know the most common cause of this skin and scuff tissue infection, it is mostly what? It is this Staph aureus infection. It is the Staph aureus infection. Fine. Next, if you are able to see this type of oil drop sign, it is also seen in a case of psoriasis. Then, if you are able to see this lysis of this nail, it is known as onycholysis, or separation of the nail, it is known as onycholysis. Next, if you are able to see this nail, it is being separated from this finger. So there is huge separation here. So this type of thing, which is known as happens due to this subungual hyperkeratosis. This is known as subungual hyperkeratosis, which can be seen in a case of fungal infections. Okay, remember, yeah. Good guys. That is oil drop cataract will be seen in a case of galactosemia. See, oil drop cataract will be seen in a case of galactosemia, whereas oil drop sign in the nail will be seen in a case of psoriasis. Remember, fine. Next, if you are able to see this lamp, sorry, this is known as wood lamp. Okay, this wood lamp, it is used to assess this skin lesions, especially this macules or lesions, right? The most commonly, the wavelength which we use here, it is this 360 nanometer, and the component which is made up of means this there will be a filter. This filter of this wood lamp is made up of this barium silicate and 9% nickel oxide. It will be made up of barium silicate and 9% nickel oxide. So just remember, it will be made up of barium silicate and 9% nickel oxide. And based on the color which is be seen from this wood lamp examination, will tell, yeah, it might be this disease. First, the most common one which is being tested, it is what? It is known as erythrasma. In the case of erythrasma, what you will see this coral red fluorescence. So remember, in the case of erythrasma, you will see coral red fluorescence. If you can see bright apple green or yellow green fluorescence will be seen in a case of tinea capitis. In the case of tinea infections, you will able to give, especially in the case of capitis, you will able to see this yellow green or apple green emissions, or else in the case of vitiligo, we know vitiligo is white color. So here you will able to see bright white kind of discoloration in a case of wood lamp examination. Okay, see. Next, if you are able to see this green, the pseudomonas, we know it produces multiple colors. One of them is what it is, a greenish color discharge. Okay, and it is the most common cause of corneal ulcer in contact lens ulcers. Fine. So this produces this green color fluorescence. Whereas in the case of melasma, we know melasma right here. Melasma will be there for which will give this hydroxychloroquine, mostly seen in elderly patients, and this melasma it will be brown, dark brown in color. Fine. Whereas this Purpurea cutanea tarda, it will be red in color. Purpurea cutanea tarda, it will be red in color. Okay. Then we'll move on to this part where we discuss about this ulcers. Okay, about the sexual transmitted disease and the ulcers. See, you need to try to differentiate. What is the first differentiating factor? In question, there will be mentioned there is a 30-year-old male. There will be what? There will be a 30-year-old male who is truck driver by profession, and he had a recent unprotected sexual intercourse. Fine. And now he is presenting with the type of lesion. If they're presenting with painful ulcer, remember, painful. If someone is in pain, he will cry. So remember, it is the chancreoid, or it is caused by the 𝗵𝗔 due cry. So remember, if he is cry, it is because of this cryoid. So remember, it is the chancreoid will cause this pain. Okay, it will cause this pain. Okay. What are the painless ulcer? Like, okay, if you take up this LSD, this is a drug, then you will feel everything is you are in euphoric state, so you will feel painless. So this LSD conditions will be having this painless ulcer. What are the LSD conditions? One is this lymphogranuloma venerum. Fine. Next one is this syphilis and the donovanosis. Okay, donovanosis. So this is the first thing. If they say painful ulcer, then you need to point your diagnosis towards 𝗵𝗔 nuclei. Then you should move on to this. If there is any vesicles present or not. If vesicle presence, then you need to think of herpes simplex infections. If not just ulcer, then you should think of chancroid, which is caused due to the 𝗵𝗔 nuclei. Fine. So then how will you differentiate? They will tell if there is a single ulcer if present with the presence of induration, and there is no pain, on evaluation you will be able to see the patient had this infection very long back. If the incubation period is between 9 to 90 days and there is a single ulcer along with this presence of induration which is, and the ulcer is painless. Okay, this is the typical feature of syphilis. This is the typical feature of syphilis. Fine. Whereas if you compare this syphilis with the next, which is this chancroid. Okay, chancroid, if you see, as I told, syphilis it will be painless, whereas chancroid it will be painful in nature. It will be what? It will be a painful in nature, and here it was a single ulcer, whereas in the case of chancreoid it will be multiple ulcer. There will be a multiple ulcer. Fine. And here the induration will not be present. Okay, and this will be a very fragile ulcer. Once you touch, it will bleed. Once you touch, it will bleed. So this chancroid will be, once you touch, it will bleed. The ulcer will bleed. Like that kind of presentations will be there. And there will be a presence of lymph nodes which will be mostly unilateral in nature. And as I told you, there will be a painful ulcer. It will be a painful ulcer. Fine. And now next if you see about this donovanosis and lymphogranuloma venerum. If you see about this donovanosis and lymphogranuloma venerum, then you just see this donovanosis and lymphogranuloma venerum. Both of them, they will be having this single ulcer, and both of them, they will be almost painless in nature. Okay, here LGV also is almost painless. Remember, fine. And this, if you see about this donovanosis, it will be a very thin ulcer which is granulomatous in nature, and there will be association of this 𝗬𝗵𝗶. Whereas lymphogranuloma venerum, it will be associated with this bilateral lymph node involvement. Bilateral lymph node involvement will be present. Just remember, if it is bilateral pupils will be present, it will be LGV. Whereas in the case of donovanosis, you will see there will be 𝗬𝗵𝗶 formation. There will be a presence of 𝗬𝗵𝗶 formation. Okay, so donovanosis and LGV you need to differentiate. Fine. Then both will be having this painless and single ulcer. Whereas in the case of donovanosis, they will call it as red-beefy ulcer, which is also having the features of bleeding. Okay, so there will be red-beefy ulcer. Okay. This is the case of donovanosis. Fine. This will be typical like this. There will be a red beefy ulcer. When you touch, it will bleed. Fine. And In a case of text, as I told you, HSV, it also will be having this painful ulcer. But if you see about this painful ulcer, it will be having this multiple, and it will be having this polycyclic ulcers, means there will be 1, 2, 3, 4, 5. There will be multiple ulcers which are being coming together. There will be multiple ulcers which will come together and will form a single ulcer. So it is known as polycyclic erosions, and we know it will be caused by this HSV2. Mostly whatever it's below the waist, it will be caused by this HSV2. Itna yaad rakho. So okay, fine. So these are the things. Painful means it is chancroid, painless means LGV, syphilis and donovenosis. You just remember. Fine. And this is the case of secondary syphilis, where you will see. In the case of secondary syphilis, after starting of treatment, if you are able to see this type of phenomena where there is a presence of red rashes in the hands, red rashes in the hands. Okay, this is seen in a case of secondary syphilis after initiation of this treatment. Fine. Next, if you are able to see this type of friable ulcer, which is painful, it is what it is, this 𝗵𝗵𝗀 𝗺𝗀. Okay, and then if you are able to see this type of red ulcer, this is what? This is typically seen in a case of donovenosis. Fine. And next, if you are able to see, there is two suppurative. This is what? This is suppurative lymphadenopathy causing this formation of groove in the inguinal region. So this is known as formation of buboes. So this buboes formation will be typically seen in a case of which one? Lymphogranuloma venerum. It will be caused by the lymphogranuloma venerum, where you will see this groove sign. Yaad rakho. Fine. And management, we know, in the case of syphilis, will give benzathine penicillin, whereas in the case of 𝗵𝗵𝗀 𝗺𝗀, which is this chancroid, will give azithromycin. Okay. Okay, where same for this lymphogranuloma venerum, will use both azithromycin and doxy. Donovenosis also will use azithromycin. Okay, azithromycin. Fine. That's it, guys. It's how you will be able to differentiate this type of ulcers based on their characteristics. Okay, Okay, and then we'll move on to some of these papillosquamous disorders. Okay, if you see about this papillosquamous disorder, at least one of them it will be tested, either lichen planus or there will be psoriasis. Within these two, they will test at least one. See, in a case of lichen planus, they will tell there is this purple polygonal pleuritic plaques. And it is present on the flexural aspect. And if they are presenting on the flexural aspect, this is the typical feature for this lichen planus. And this is also an autoimmune disorder. Okay, autoimmune disorder which is having this kind of purple pleuritic plaques. Okay, polygonal plaques will be seen in a case of lichen planus. And if there is any involvement of this oral cavity where there is formation of this white lacy pattern, this is known as what? This is known as 𝗵𝗵𝗀𝗀. And next, if you see this, as I already shown you, right? If there is presence of this nail involvement and if there is a degeneration like this, it is known as pterygium, and it is typical for this lichen planus. Fine. Whereas we saw this pterygium, right? It is also what? It is the elastotic degeneration of this conjunctiva. Okay, it is the elastotic degeneration of the conjunctiva. Okay, don't forget those also. Okay, and we know this pterygium, it can lead to this astigmatism. Okay, right. And if you do exercise of this lichen planus, then you will be able to see this type of bodies. They are known as what? They are known as 𝗪𝗺 bodies. You will be able to see this 𝗪𝗺 bodies. Okay, 𝗪𝗺 bodies. Fine. And here also you will be able to see, as I told you, it is an autoimmune disorder. This autoimmune disorder will cause us this lymphocytic infiltrate. Okay, don't forget. So there will be 𝗪𝗺 bodies and there will be a presence of this lymphocytes because it is an autoimmune disorder. Okay, autoimmune disorder. Fine. And as it is an autoimmune disorder, what will go? Will give this steroids like oral and topical corticosteroids, and along with this calcineurin inhibitors like topical tacrolimus and pimecrolimus. Okay, pimecrolimus. Okay, tacrolimus. Okay, remember. Then we can use one more therapy which is known as UVB phototherapy. We can give this UVB rays with or without application of this drugs, and once the UVB exposure, these lesions will tend to reduce. Okay, So this is this lichen planus. Okay, it will be having this purple polygonal pleuritic plaques, especially on the flexural involvement. Okay, there will be presence of 𝗵𝗵𝗀𝗀 and there will be presence of this pterygium, and for treatment will give corticosteroids, and HPE will see this 𝗪𝗺 bodies. It will see this 𝗪𝗺 bodies. Yeah, good, Dr. Ansh. Fine. Next, if you see about the psoriasis, you know the psoriasis, it is also one of the most common one. It will be having this extensor, like lichen planus it was flexor, whereas psoriasis it will be having this extensor involvement. So as this is having this extensor involvement, there will be extensor involvement with silvery white micaceous scales. Extensor involvement with is having this silvery white micaceous scales, and once you remove one scale, once you remove one scale and peel and see this, then you will able to see there is a bleeding spot inside. So this type of bleeding spots, once you remove the scale, it is known as what? It is known as 𝗲𝗵𝗊 sign. It is known as 𝗲𝗵𝗊 sign, which is seen in a case of psoriasis. Once you remove a scale, you will see there will be a multiple bleeding spots like this. So this is known as 𝗲𝗵𝗊 sign. Okay, this is known as 𝗲𝗵𝗊 sign, and we know this HLA-CW6, it is being associated with this psoriasis. The psoriasis will be associated with this HLA-CW6. Okay, whereas we know ankylosing spondylitis, it is associated with this HLA-B27. HLA-B27, remember. Fine. And next, on histopathological examination, you will see two things. Okay, one is known as 𝗏𝗏 pustules and another is known as Munro's microsubstance. Okay, Munro's microsubstance and 𝗏𝗏 pustule you will be able to see in a case of psoriasis. So remember, it is this MP. Okay, Munro's microsubstance will be seen in a case of psoriasis. Munro's microsubstance will be seen in a case of psoriasis. Okay, just remember. And here you will be able to see, we know usually when the skin come from the superficial to the means deep to the superficial layer, skin will become flattened, and when it reaches from this to this stratum corneum layer, then the nucleus will be absent. If the presence of nucleus in the stratum corneal layer, we'll call them as parakeratosis. Yeah, we'll call them as parakeratosis. Yeah, good guys. We'll call them as parakeratosis. And instead of one layer, if there is multiple layer which is causing this formation of this silvery white micaceous scales, so this is known as what? This is known as hyperkeratosis. So it will be having both hyperkeratosis and parakeratosis. Remember, fine. And two abscess, 𝗏𝗏 pustules and Munro's microsubstance. Fine. And once you start scratch, for example, here you had this psoriatic lesion, but you scratched here. When you make a trauma, then what will happen is that whenever you make trauma, the psoriatic lesions will start developing to the regions where you make trauma. So when you do like this, you will start next day or after a few days, there will be a formation of this silvery white micaceous scale blocks will be present on this external surface after exposing to this trauma. Okay, fine. And as I told you, this is an extensor involvement. Okay, there are few more types of psoriasis that you need to know. For example, if there is this type of psoriasis which occurs in this females, pregnant females, okay, it is known as impetigo herpetiformis. Okay, and the treatment for them, it is what it is, the steroids. So only in this case we'll use this steroids. Fine, steroids will use. Fine. Whereas in next case, if you see, there is this presence of around the same type of pustules. Here also pus is there, here also pus. But this is known as lake of pus or this pool of pus. There will be a huge pus. There will be a lake of pus. So it is known as this lake of pus. It will be present in a case of pustular psoriasis, which is known as von 𝗵𝗵𝗀𝗀𝗃 reaction. Okay, and von 𝗵𝗵𝗃𝗃 reaction, it is due to this over treating with the steroids. It causes this pustular psoriasis, which is known as von 𝗵𝗵𝗃𝗃 reaction. Fine. And next, if you are able to see this type of raindrop kind of psoriasis, yeah, good guys, raindrop kind of psoriasis, it is known as what? It is known as guttate psoriasis. Good. Yeah, good Dr. Bhargav, good Dr. Konin, Anna and Gautam. Good. Fine. Next, if you are able to see, there is this whole body along with the scales, there is a formation of this red. It is red erythematous. So it is known as what? Erythrodermic psoriasis. Okay, erythrodermic psoriasis. Next, as I told you, this psoriasis will involve this extensor surface, but instead of extensor surface, if it start involving this flexor surface, like for example, inferior to the breast or mammalian or into this axillary region. So if it start involving this flexural region, so it is known as what? It is known as inverse psoriasis. Next, if the psoriasis, if it start affecting this hands or this bones, it is known as what? Psoriatic arthritis. It is known as psoriatic arthritis. And remember, the psoriatic arthritis, it will especially love this place, which is known as DIP. Okay, DIP, it will be love to affect. So it will lead to this type of deformity, which is known as pencil in cup deformity. Okay, pencil in cup deformity. Yeah, good, doctor. Yeah, good. Okay, it is known as pencil in cup deformity. Okay, yeah, good. And for treatment of this, we'll use methotrexate. Okay, on evaluation you will be able to see this is the sausage disease, sausage digits with pencil in cup deformity. Yeah, we will use this methotrexate. Good guys, good, fine. So usually in a case of psoriasis, what we'll do, we'll give moisturization and we'll give corticosteroids topically, and we'll start with retinoids. Okay, like usually with topical retinoids like tazorotone and any other calcineurin inhibitors. Okay, and we have two regimes where we use this UV lights. Okay, where we will use this UV lights and this sunlight. See, one regimen, it is known as Gskeman regime. Okay, in Gskeman regime, we'll use this coal tar. We'll use this coal tar placed and we'll apply for this. Apply to the skin and will expose to this phototherapy unit. Fine. Whereas in case of Ingam regime, what we will do, we'll apply the anthralin paste. Okay, in the case of GC, remember it is CG or GC. In Gskeman's regime, what we will do, we'll apply the coal tar. Whereas in the case of Ingram's regime, we'll apply this anthralin paste and will undergo this phototherapy. Okay, and phototherapy usually will be what? Will be having this UVA phototherapy with psoralen. With psoralen, we'll having this phototherapy and it is being used for this psoriasis, remember. And for psoriatic arthritis, I told we'll use methotrexate. Arthritis, yeah, we'll use methotrexate. And next one, it is what? It is this. This is which is known as acne. In the case of acne, it is what? The typical case of acne, which is mainly due to what? It will be due to the infection and along with this hormonal changes. Infection along with this hormonal changes, and the typical form and the typical the most consistent finding in the case of acne, it is what? It is known as this one, which is known as what? Comedones. Comedones are also known as black dot. Black dot also known as comedones. Fine. And this is due to this blockage of the sebaceous glands. Fine. And this can even lead to this type of complicated acne, which is known as what? Which is known as, what is the name of this complication of this acne, guys? It is known as nodulocystic. It forms nodules and cystic. Yeah, good, Dr. Like Anash and Gautam. Yeah, if you see this comedones, if it is black dot, it is known as open comedones. Like it is known as what? Nodulocystic disease. Yeah, good, Dr. Anar, good, Dr. Parul, good, Dr. Gautam. Good. Fine. So it is mostly involved, means this acne, it will mostly involving the seborrheic areas where there is sebous hyperplasia due to this androgen, or this comedones, there will be this follicles will be alterly differentiated. That's why it will become this comedones. Okay, comedones. Fine. And there will be this, sometimes there can be associated with this papules and pustules formation, and that's why when you remove, when you crush it open, they will be able to see this pustules. Fine. And finally it will be scarring, mostly this eye scarring, the vital, like it will scar and heal. Fine. And there are different stages. In stage 1, stage 2, stage 3, what you will see comedones for sure. That is this black dot, and followed for this you will start with the same topical retinoids, and if there is any comedones along with this inflammatory papules and pustules, then we'll give topical retinoids. Along with this there is a pustules, so there may be chances of infection, so we'll give antibiotics. So we'll give pustules. For pustules present along with comedones, we'll give antibiotics. इतना याद रखो. फिर उसके बाद आते हैं grade 3. Grade 3 there will be multiple inflammatory papules and pustules. Inflammatory papules भी है और pustules भी है. Then we'll give topical retinoids along with topical antibiotics and antibiotics. Topical and oral antibiotics हम दोनों देंगे. But in the case of nodulocystic disease, it is a very severe form. In such cases, we'll start with isotretinoin. और हमें पता है the most common side effect of this isotretinoin का है, it is the dryness of the lips. Dryness of the lips, it will be caused by this oral isotretinoin, and in later part or in pregnant female, what will happen is this can even cause teratogenicity. Okay, fine. And next about this part, which is known as contact leukoderma and contact dermatitis. Fine. Leukoderma, it is nothing but this whitening Okay, whereas contact dermatitis, it is when there is area, there will be starting of this dermatitis. Fine. Okay, so just remember this allergic contact dermatitis, it is a type 4 hypersensitivity reaction. Yeah, good enough. It is a type 4 hypersensitivity reaction. And next, it will be sudden in nature, whereas leukoderma, it will take some time. Fine. It won't be sudden, it will be take some time. Okay, because you got a new detergent, you got a new watch, it will start like you wear it and tomorrow you're getting, like it will take some sudden, it will take some time to occur. Fine. And it is subsequently exposed to the antigen, like after the first exposure, usually like previously formed nickels, or previously you are using this detergents and again you are exposing to same. Fine. For example, the most common one in the case of jewelry, it is what it is, the nickel one. Okay, whereas it can happen because of this bindi. Okay, bindi, actually it is leukoderma. It can happen because of the bindi, which is known as what, which is known as bindi dermatitis, which is due to this PTBP. It is due to this PTBP. Okay, paratertiary butyrophenol. Paratertiary butyrophenol will cause this bindi leukoderma, bindi dermatitis. And if you see in the case of hair dyes, it will cause inflammation over here, which is due to this paraphenylalanine. Okay, it is the PPD which causes this hair dye, induced allergic contact dermatitis. Fine. And it can even lead to this type of contact leukoderma. Remember, it can lead to this, finally as a complication can lead to this contact leukoderma. Remember. Okay, next, to know this allergic contact dermatitis, we'll use this test. What is the name of this test, guys? Iska naam kya hai? It is known as what? It is known as patch test. Good, guys. It is the patch test. And here there will be this aluminum chambers will be there, and we'll keep one allergen one by one, and we'll pick as a paste. And most commonly we read after 48 hours, but the best reading can be done at 96 hours. Okay, it is used to detect the allergens. And we know it is also what? It is also type 4 hypersensitivity reaction. Yeah. Okay, so this is the patch test which is used for this allergic contact dermatitis. Fine. Then we'll move on to this most important one. It is what it is, this pemphigus group of disorders. You see about this pemphigus group of disorders, this is this pemphigus vulgaris and bullous pemphigoid. See, pemphigus bullous pemphigoid, like if you see about this old age patients, they will be always tensed. So if you see there is a lesion which is occurring in this old age patients and causes this tense bullae, which is occurring in the old age patient, it is what? It is the bullous pemphigoid. It is the bullous pemphigoid. So it is in elderly patients, and there will be what? It will be tense. If you see, this is very tense. Okay, this is tense, and it won't involve these mucosal regions. Okay, and it will produce what? It is produces this subepidermal clefting. It is due to this subepidermal clefting, and immunofluorescence. If you do, especially direct immunofluorescence, you will be able to see linear deposit. This type of linear deposits in a case of direct immunofluorescence. Linear deposit. Okay, linear deposits of this IgG. Okay, for this management, you give this systemic or topical glucocorticoids. Fine. And next condition, which is known as pemphigus vulgaris. There are two pemphigus group of disorders. One is known as pemphigus foliaceus, another one is known as pemphigus vulgaris. Remember vulgar. Okay, how you will tell the vulgar words? By your mouth. So remember, the gali muh se nikalte hain. Okay, so remember, so whatever the vulgar words, you will use your mouth. So remember this, in the case of pemphigus vulgaris, your mouth or this oral mucosa will be, affected. In the case of pemphigus vulgaris, fine, there will be affected. Next, if you are able to see, this will be what? This won't be a tense bulla. This will be what? This will be having this flaccid bullae. And direct immunofluorescence, it will show this type of pattern, which is known as what? Fishnet pattern. And here, like for example, remember, you told gali, means you told any bad words, and once you say bad words to a bigger person or a elder person, then they will kill you and they will make you a tomb. Okay, they will make you a tomb. They will bury you and they will make you a tomb. So remember, in the case of pemphigus vulgaris, you will see this fishnet appearance, or they will put fishnets and they will catch you and they will kill you, and they will they will bury and they will put a tombstone. So remember, here on histopathological examination, you will see a row of tombstone appearance. Yeah, tombstone appearance. Okay, and once you apply pressure over this bulla, then what will happen is that this bulla will break, and this type of sign, which is known as what? It is known as Nikolsky sign, will be positive. And here the antibodies against this desmoglin 1 and 3, whereas in the case of bullous pemphigoid, it is due to the antibody against this bullous pemphigoid antigen 230 and 180. Okay, here I told you it will be producing this type of fishnet appearance. Okay, itna yaad rakho about this too. Next, about HSV, I told you this is this herpes labialis which causing this multiple vesicles which is forming this polycyclic ulcer. Okay, polycyclic ulcers, fine. Then HSV1, it affects above the waist, HSV2 below the waist, fine. And yeah, HSV causes affect, it causes herpetics, gingival stomatitis, and herpes labialis. It is the formation of this what? It is the formation of painful vesicles, and around the border which is known as vermilion border, fine. And this virus can stay dormant and it can cause reactivation. Take a reactivation. So topically will give antimicrobial and prevent secondary infection as well, fine. And in genital herpes also it can remain dorsal. Okay, and this will produce this polycyclic erosions with bilateral painful lymphadenopathy. Okay, see, there is two painful ulcers. One is what? One is this chancroid, next one is HSV. Whereas HSV produces this polycyclic erosions, whereas chancroid will be producing this very friable ulcer will be there in a case of chancroid. Yeah, and on Zank smear, yeah, and on Zank smear you will able to see there is this multinucleated giant cell. Multinuclear giant cells will be seen in a case of Zank smear, fine. And we'll come on to few warts. If you see this type of individual warts, this is known as what? This is known as condyloma acuminata. Whereas if you're able to see this type of warts where there is this cauliflower growth. What is this one? Yeah, what is this one, guys? Yeah, it is also the condyloma acuminata, which will be having this cauliflower or giant condyloma acuminata, which is showing this type of cauliflower like growth. Okay, and most commonly it will be caused by this HPV 6 and 11. It will be caused by this HPV 6 and 11, whereas high risk HPV, which include 16, 18, 31, 35, it will cause us this cancer. It will cause us the cancer. Okay, especially 16, 18 is responsible for this cervical cancer. It is responsible for the cervical cancer. Fine, and it can predispose to malignancy, yes, that's true, and it will be a large. Then it will call it as giant condyloma acuminata, like which is also known as 𝗏𝗏-Lowenstein tumor. It is known as 𝗏𝗏-Lowenstein tumor. Yeah. Now, first is also condyloma acuminata. It is also condyloma acuminata, whereas this is second one is giant condyloma acuminata. Condyloma lata, it won't be like this warts. Condyloma lata, it will be kind of flat papules, like flat will be there. It will be flat, whereas here it will be warts. Okay. I guess you will able to get the difference. Like so, condyloma lata, that is kind of nodules or nodules kind of thing. It will be flat, will be there with small rise. Okay, and it will be seen in a case of syphilis. Okay, that will be seen in a case of, yeah, first was looking like flat. No, now if you see the flat means it should be like this will be there. See here it is enlarging incoming, so it is the warts. Okay, that is how, like there will be a small differentiation that you should have the clarity. Once you see those images, you will be able to get the clarity. Fine. Next, in the case of this HPV infections, you will be able to see the presence of coilocytes. Fine. Then treatment, they recently asked it, how will you treat this type of warts? Fine. If you see these general lesions, we can use podophyllin or 𝗵𝗵𝗀 or 𝗚CA. All of these things we can do. But whereas if there is a pregnant patients, we can usually use cryotherapy induced ablation, or we can use this 𝗚CA application. This apply 𝗚CA, after that it will become fall off. Okay, it will fall off. Remember, fine. And this HPV, it is involving in different diseases. You can remember it as different types of HPV, so different diseases. So deep plantar wart, it will be caused by this HPV1, whereas HPV2 S for S. So second, it will cause this superficial plantar wart. 3 will cause this plain wart. So remember the plain wart, it will be caused most commonly by 3, not by 1. Fine. And common warts, it will be by these 3 common people. This is 4, 2, and 27. Whereas ED, fifth alphabet, it is this epidermodysplasia verruciformis will be by this HPV5. Next, anogenital warts, as we show, we know this is 6 and 11. Okay, and then Butchett's wart, which is happening from this spreading from this animals, it is known as HPV7. It is by this HPV7. So remember this condyloma acuminata, it will be by this HPV 6 and 11, whereas CA cancer, CA cervix, it will be especially from this 16 and 18. From the 16 and 18. Fine. I guess you got it. Next, you say a patient who is presenting with this increased pruritus in evening, And along with this, there is a nodules in scrotum, and here, and here in between this web space, in between these fingers, he is able to see there is this excoriations. So this excoriations between fingers, okay, all of these things will be classically seen in a case of scabies. And we know this is the age of its responsibilities. What is the 𝗧𝗵𝗶𝘀𝗀𝗃? It is a 𝗧𝗵𝗶𝘀𝗃, and it will produce this typical lesions which is known as what? Burrows. It is known as typical lesions which is known as burrows. Fine. And if it is happening in a homeless people, then there will be this millions of mites. It will come and attach to the skin, or it will lay eggs. It will eat there. It will sleep there. Though it is known as what? It is known as Norwegian scabies. It is known as Norwegian scabies. Okay, remember. Next, for treatment of this, we'll give what? We'll give 5% permethrin. Okay, we'll give 5% permethrin. If it is chota bacha, if it is a children, then we'll tell just don't apply on the face. Okay, apply at the night. Okay, on 0 and 7th day, open a bottle of this permethrin, means permethrin solution. Then just pour and apply all over the body during your night, and once you wake up, just bath. Okay, this is how the application of 5% permethrin. If it is child, we won't tell them to apply over the face like around until 12 years, and after that, if it is adult, we can tell them to even apply around the face. Okay, just remember. And for this, we'll use this 5% permethrin cream and also ivermectin as a oral drug of choice if it is in case of severe. Fine. Okay, the cream has to be applied from neck to toes to overnight in a case of children for and it is repeated after 0 and 7th day. Fine. And oral use of drug of ivermectin, what will be it will be used 200 mcg per kg. Usually we'll give 6 to 12 mg. Okay, 6 to 12 mg based on the dose. Or else if it is adults, we'll give usually 12 mg. So remember, 5% permethrin and ivermectin. These are the two drugs which you use for a case of scabies. Okay, for a case of scabies. Fine. And next, we'll see about the tinea. These are the fungal infections. If you see, this is this black dot forming. This is the tinea capitis. And tinea capitis have other forms as well. So if you're able to see this type of scutula formation, it is known as what? It is known as 𝗵𝗵𝗿𝗺. It is known as 𝗵𝗵𝗿𝗺 type of tinea capitis. Whereas if you're able to see this type of tender, it is looking like a tender and boggy swelling. Okay, tender boggy swelling, and when you pluck a hair, this will come easily. So tender boggy swelling along with this easy pluckable hair, it is a typical feature of this 𝗚𝗏𝗏. Remember. Fine. And next, if you are able to see this type of central clearing. Okay, if there is a body, if there is a dead body inside, then what you will do? You will keep it and do puja? No. What you will do? You will dispose it. So remember, the central clearing will be seen in a case of tinea corporis. So if there is a corpus, then we'll remove it. Remember, it is the tinea corporis. It will be presenting with central clearing. Remember. Next, if you are able to see around this inguinal region, it is known as what? Tinea cruris, also known as jock itch. Fine, jock itch. Next, if it is involving this foot and along this web spaces, it is known as what? Tinea pedis, also known as athlete's Okay, athlete's foot. Fine. And next, most of the drug of choice for all the tinea, it is what? It is the terminophen. Except in a case of tinea capitis, we'll use this 𝗏𝗏𝗏. Except in a case of tinea capitis, we'll use what? We'll use 𝗏𝗏𝗏. Fine. And next, about leprosy. If you see about this leprosy, if it is presenting in the small child, which is looking like this patch, okay, it is looking like this hyperpigmented patch, it is what? It is this with multiple hyperpigmented patch, it is what? It is this indeterminate leprosy. Whereas if you are able to see this type of saucer which is in upright position, it is seen in a case of PT type of leprosy. Whereas if you are able to see this type of satellite lesion, this will be typical for this BT type of leprosy. In the case of BT type of leprosy, we will be able to see this satellite lesion. You will be able to see this satellite lesion. Yeah, good guys. Yeah, fine. And there is this indeterminate leprosy. You should be differentiating with one more condition, which is known as pityriasis alba. Means that what is pityriasis? Means formation of scales. How will you differentiate? There will be, in the case of pityriasis alba, it is pityriasis. So scales will be present. So once you scratch, you will see there is a formation of scales, and you will ask, there will be absent of hypopigmentation. No hypo anesthetic patches. So this patch which will be there in children, which won't be having any sensory loss, it will be normal. Just the scaly white patches, it is known as pityriasis alba, which is most commonly seen in the case of children. Okay. And next, if you are able to see this type of inverted saucer appearance, it will be seen in the case of BB type of leprosy. Whereas in India, the most common one, it is the BT type of leprosy. Okay, बहुत BD हो रहा है आज तो, ठीक है? Just remember this thing. Next, if you are able to see multiple and almost symmetrical, multiple but almost symmetrical, not symmetrical, so it is what it is, the BL type of leprosy. And if you are able to see this type of multiple symmetrical and this type of leonine faces, all of this thing, all of these things, it will be suggestive of this LL, lepromatous type of leprosy, LL type of leprosy. Fine. And we know in the case of 𝗶𝗵𝗶𝘀 leprosy, हम क्या करेंगे? We'll give this drug, like will dapsone and rifampicin, and like if it is uniform immunity, then we also add clofazimine. We'll give this drug for 6 months, whereas in the case of multibacillary, we'll give for 12 months. Okay. And while giving this drug, what we'll do means this can cause lepra reaction. That type 1 lepra reaction and type 2 lepra reaction. हमें पता है type 1 it is what it is this HSN4, whereas type 2 it is hypersensitivity reaction type 3. Okay, type 3. Okay, in the case of type 1 reaction, okay, in the case of type 1 reaction, which is hypersensitivity reaction 4, there will be formation of granuloma. There will be the granuloma formation, and it will be treated with steroids. Whereas in the case of erythema nodosum leprosum, which is the type 2 lepra reaction, it is a type 3 hypersensitivity reaction, and see here there will be a formation of papules, nodules and macules. There will be a rule of 5, like see 1 plus 4 is 5 and 3 plus 2 is 5. Okay, so type 2 lepra reaction, it is type 3 hypersensitivity reactions, whereas type 1 lepra reaction, it is type 4 hypersensitivity reactions. Fine. So here there will be formation of papules, nodules and macules. Along with this Glovenstock formation and Glovenstock formation of anesthesia. So इतना आपको याद रखना. So you should remember at least this much about this case of leprosy. ठीक है, लेप्रोसी में तुम्हें इतना याद रखना है. और 𝗶𝗵𝗶𝘀 कैसे बोलेंगे? इफ देयर इज 5 lesions with no involvement, no nerve involvement, it is known as 𝗶𝗵𝗶𝘀. if it is more than 5 along with at least 1 nerve involvement, it is known as multibacillary. It is known as multibacillary leprosy. ठीक है, we'll move on to few neurocuteness syndromes and tumor, then we'll finish up with derma. Fine. If you see about this neurocuteness syndrome, okay, one is this NF. Neurofibromatosis, it is an autosomal dominant. See, there are two NF, NF1 and NF2. If you count this neurofibromatosis, then it will be consisting of 17 alphabets. So NF1, it is because of this chromosome number 17 defect. So NF2, it is 2. So you see in skull, what you see? You will see this ice cream cone shaped, bilateral ice cream cone shaped acoustic 𝗏𝗏. It is two ice cream, right? It is not one ice cream, it is two ice cream. So it is 2-1 and it is NF2 and it is what it is? The chromosome number 22. It is the chromosome number 22. इतना आपको याद रखना. It is the chromosome number 22. Fine. In the case of NF, you will be able to see this type of spots, which is known as what? Which is known as 𝗏𝗏𝗏𝗏 spots. It is known as 𝗏𝗏𝗏𝗏 macules or 𝗏𝗏𝗏𝗏𝗏 spots, and followed by this, these are this neurofibroma. Okay, neurofibroma, and an eye you will be able to see. This leash nodules, and axilla you will be able to see this type of freckling in the axilla. Okay, there will be a formation of freckles in the axilla, and here you will be able to see this type of leash nodules. Okay, इतना आपको याद रखना है जरूरी है. ठीक है, whereas in NF1 it can be associated with this pseudoarthrosis of tibia. Pseudoarthrosis of tibia. Yeah, good Dr. Anash, good Dr. Kanyon, and good Dr. Gautam. Good. Then this is what? This is our bonovilus. This is also known as tuberous sclerosis. This tuberous sclerosis, it will be having this triad. Okay, which is known as epilo. Yeah. Okay, what is this epilo? Means there will be epilepsy, there will be low IQ, and what will be there? There will be adenoma sebaceum. So it is what it is, this Vox triad. It is not Vox triad. Vox triad will see in a case of keratoconus. It is the Vox triad will see in a case of tuberous sclerosis. And in case of tuberous sclerosis, you will be able to see this type of hypomelanotic macule. There is a white-like macule, which is known as ash leaf macules. And here around this face or around this lumbar region, you will be able to see this type of patch, which is known as what? green patch, and there will be small potato tumors. It is known as what? Facial angiobromas, also known as what? Adenoma sebaceum, also known as adenoma sebaceum. Adenoma sebaceum. इतने याद रखो, ठीक है. Next, this tuberous sclerosis can be associated with this ungual fibroma, this fibrous and cephalic praves, and there will be a presence of this cortex. There will be presence of this tubers. Tubers can be present here, and also you'll be able to see this one which is known as subependymal giant cell astrocytoma. This is also seen in a case of tuberous sclerosis. You will see this subependymal giant astrocytoma. You will be seen in a case of tuberous sclerosis, and in lungs you will see this lymphangiomyomatosis. Lymphangiomyomatosis. There will be large cystic swellings will be there. This is known as lymphangiomyomatosis, and in kidney you will see this angiomyolipoma. There will be vessel, there will be bleeding, there will be vessel, there will be lipids, and there will be muscles. There will be bleeding, there will be lipids, and there will be muscles. It is known as bilateral angiomyolipoma, and next one is the lymphangiomyomatosis. So all of this following will be typically seen in a case of tuberous sclerosis. It will be seen in a case of tuberous sclerosis. आपको याद रखना ही रखना है. Next, if you are able to see this type of Port-Wine stain along with the features of glaucoma, and here you will be able to see this type of tram tract calcification, and tram tract calcification sometimes associated with this intracranial calcifications. So Port-Wine stain, glaucoma, and tram tract calcifications, all of them will be seen in a case of 𝗧𝗵𝗶𝘀 syndrome. All of them will be seen in a case of 𝗧𝗵𝗶𝘀 syndrome. Okay. Next, about this first part, if you see this basal cell carcinoma, also known as rodent ulcer. This rodent ulcer, it is most commonly seen around this area where there is more exposure to the sun. Okay, where there is more exposure to the sun. See, it can occur near to the ear lobule, around this nasal area as well. There you will be able to see there will be a central ulcer, and followed by which there will be this dilatation of this vessel. They are known as telangiectasia. Okay, telangiectasia. Remember, there will be ulcer along with this telangiectasia, and we know, like other side, it can present with this squamous cell carcinoma. This is how this ill-defined squamous carcinoma present with, and we know in a case of squamous cell carcinoma, there you will see there is a presence of keratin pulse. Okay, fine. And next, this is this melanoma, and we know melanoma, it will be having the few features. What are them? If you see this melanoma, it will be following this ABCD rule, and it will, and based on this depth, we'll see whether this is malignant or if it is going to metastasis. Fine. So next to this basal cell carcinoma, it is the most common one. It is the most common skin tumor. It is the basal cell carcinoma. Whereas in the case of squamous cell carcinoma, it is next to this one, and it will be showing, or we will be able to see this keratin pulse in the case of squamous cell carcinoma. Malignant melanoma, it will be positive for this 𝗵𝗶45 along with this S100. So these are the few things, or these are the main things you should remember from this dermatology perspective. Fine. And this is what everyone tells, like just when everyone is sleeping, make sure you are reading. Okay, so that you can sleep after January 12. Okay, so that you can sleep after January 12, because if you don't sacrifice your sleep now, you will sacrifice your sleep for next 6 months. Okay, so make sure you, means there will be a bit hard times, and make sure you are making your effort with very silently, with inside you, with very by your own self. Okay, because the victory is not for anyone else in the world, it is for you, your recognition, and it is your victory, and only you can do it. Okay, that is the motivation, that is the thing that you should have till your FMGE examination. Once it's done, just keep everything out of mind, have an enjoyable days then after it. Fine. That's it about dermatology, guys. Yeah, good. Then we have this final subject, which is the 19th subject of our game changing session, which is the anesthesia part, and after that we'll be done with it. Fine. Yeah, I guess we are in correct part. Yeah, cool. Okay, fine. If it is done with it, then we'll be done. Okay, and don't worry about the GT. Okay, just try to give GT. Why I'm telling is that, because now you know what is the content. Okay, till now you got an understanding that content, what they will ask, but you don't know how to solve the questions. So then what you will do, you started solving PVQs, and you started solving this QBank or custom modules, then you know idea. Okay, then the set of mind, or the mindset, means 19 subjects will be floated like this. Okay, it will be floated like this. So you should think in all subject perspective. and everything should come in mind, and there will be this clock will be ticking. Okay, 50 minutes, one set, 50 cushions. So 3 sets, 1 hour means like 150 minutes, 50 minutes each set. So you should be always vigilant about it. Okay, because once you complete this 300 minutes, okay, 300 minutes, you should be having the satisfaction. Okay, then if you have the satisfaction, that then only you can have a like peaceful life till your results. Okay, so try to have the satisfaction and try to have this imagination before your examination. So if you do grant test once or twice, then you will able to see like, yeah, this is how gonna happen, this is how gonna attempt, this is how I'm making mistakes, this is how I can improve. Okay, and in this subject is my weak subject. So try to attempt few grant tests, and initially your score will be in a lagging phase, and sometimes it will come into a stationary phase. And if there is stationary phase, analyze yourself which subjects you are weak at. You are weak in this subject, make sure you are revising it and you are reading the PVQ for sure before going next step. Fine. That is the main kind of things, and with this we'll move on to the final part of our game changing session, that is the anesthesia part. Fine. And in anesthesia, if you see, we'll use this oral cavity assessment. Okay, what is for this? For example, a patient came, or you are going to do an elective surgery. Then you need to know, means during elective surgery or when you are giving this general anesthesia, you need to make this patient to be respiring. Okay, so what you will do, you will put this ET tube. So to put this ET tube, you need to know whether this oral cavity is adequate so that you can perform this maneuver and put the ET tube. So in such scenarios and things, we will use this score which is known as 𝗵𝗶𝗀 score. Okay, and I don't know why they have this love towards this 𝗵𝗶𝗀 score. Mostly they will ask at least one question from this 𝗵𝗶𝗀 score. Fine. And in 𝗵𝗶𝗀 class 1, if you see, the tip of the uvula will be visible. If the tip is visible, it is class 1. So tip will be visible, rest of the uvula will be visible, soft palate also will be visible, hard palate also will be visible, and along with this tonsillar pillars. So tip and tonsillar pillars are visible in a case of class 1 of 𝗵𝗶𝗀 scoring. Whereas in a case of class 2, tip and tonsillar pillars won't be visible. There will be no tip, no tonsillar pillars, which will be seen in a case of class 2. Whereas in a case of class 3, there will be no uvula itself visible. It will be only soft palate and hard palate will be visible. This soft palate and hard palate will be visible in a case of class 3. Whereas in a case of class 4, only hard palate will be visible. Only hard palate will be visible. Okay, only hard palate will be visible. Okay, and next this stage where when you tell the patient to open the mouth, look, it is beautiful view. If you see here you will be able to see the epiglottis even. So if you see this type of airway, आपका ET tube आराम से चले जाएगा. Okay, you can even close your eyes and you can put the ET tube. Okay, so this is this grade 0. This is the class 0 kind of 𝗵𝗶𝗀 classification. This is the class 0 of 𝗵𝗶𝗀 classification. See, and next we have one more grading which is known as ASA grading. ASA grading, it is done for this based on this complications what can be having. For example, in the case of ASA grade 1, it is a normal healthy patients. Okay, normal patient फिर क्यों आए हैं, ठीक है ना? Then means for example normal patients which is done for the small lipoma or something small. So he's a healthy, non-smoking or minimal alcohol use. So it is a ASA grade 1 patients. In the case of ASA grade 2 patient, this is a patient with mild systemic disease. Okay, mild systemic disease without any limitation. Yeah, without any limitations. Fine. Or well controlled, or systemic disease which is well controlled. Fine. Whereas in grade 3, it is what? It is having this severe systemic disease which is not controlled, means not under controlled diabetes or not under controlled hypertension. This is not on control. Okay, whereas in grade 4, he is having a disease which is what? Which is having this constant threat to his life. Because of this, there is high BP. It is not just high BP, it is very high BP. It can anytime it can turn into a cerebrovascular accident. So it is what? It is this grade 4 patient who is presenting with this systemic disease along with this constant threat to his life. 5. Whereas grade 5, it is this moribund patient. Okay, moribund patients, and if you didn't do anything, the patient will go and die. So this is the ASA grade 5. Whereas grade 6, it is what? The patient who is already declared blinded. So blinded patients for organ harvesting will classify them as ASA grade 6. So ASA grade 1 normal, ASA grade 2 there is systemic illness but well under control, grade 3 systemic illness which is not controlled, whereas grade 4 with the other systemic disease which is having this constant threat to his life. Grade 5 it will be what? It will be this moribund patients. If we didn't do anything, the patient will die for sure. Grade 6 it is what? It is this blinded patients, okay, blinded patients. So these are the things you should know. Yeah, good guys. About this ASA classification, one of them either of them they will ask it. Fine. Next, about this instruments, you need to identify. Okay, this ET tube, it was asked in 2022 December. Okay, this is asked in neetpg 2024. Okay, just remember. Yeah, thank you, Dr. 𝗬𝗵𝗶𝘀. Yeah. See, if you see about this ET tube, it is what? It is endotracheal tube. It will be having this two openings. Okay, two openings. ये दूसरे के नाम है 𝗵𝗵𝗶𝗀 है. The another name of this opening, which is known as what? It is known as 𝗵𝗵𝗶𝗀 eye. Okay, so during any procedure, if this secretion got obstructing the main duct, you should go and suction it, right? So for this, we'll use this 𝗵𝗵𝗶𝗀, or for this preventing from this blockage also we'll use this 𝗵𝗵𝗶𝗀. Fine. And they will ask you which of the following will determine the resistance of this tube. Which of the following will determine the resistance of this tube? The length or the diameter? Remember this. Yeah, good Dr. Quinin, good Dr. Gautam. It is the diameter of the tube. The diameter of this tube which decides its resistance. The diameter of the tube which decides its resistance. Fine. And now you need to do some oral surgeries. You know this tracheal tube you need to put within your mouth. Okay. Whereas you need to do some ranula excision or some other surgeries. Then you will use one more tube where you will put your tube by this nasal route, which is known as what? Nasopharyngeal airway. This is known as what? Nasopharyngeal airway. Fine. And next, there is a patient who is presenting with this pulmonary hematoma. There is a patient with lung cancer. In the case of those patients, you want to remove some portion of the lung. So in such cases, what you will do? You will use this tube which is known as double lumen tube. In these cases, one lumen it will go and ventilate the opposite side lung, and one lumen you can obstruct and you can do procedure. Okay. So this will go and ventilate one side of the lung. That is the double lumen tube. Fine. Then this is the laryngeal mask airway. So for any simple procedures, you can use this, which is known as laryngeal mask airway. You don't need any laryngoscope. You just put it in. It will go and set. You will just inflate it, and you will do anesthesia. That's it. Then LMA Procil. But the problem is that this will go and sit over the epiglottis, and it can cause aspiration. If this cause aspiration, then it can cause aspiration into the respiratory tract. So to prevent this, we'll have this Procil LMA, which will be having this opening for this for this NG tube. Yeah, NG tube. Yeah, good Dr. Gautam. There will be two tubes. This is LMA. This is the NG tube. Fine. Next, we have one more tube where we can there will a laryngeal mask airway will go and sit over there. But with this laryngeal mask airway only, we can do intubation. Here intubation will be so easy. So it is what it is known as intubating LMA. Here you can intubate. It is known as intubating LMA. And for example, if you are doing this surgery like this, means like you are doing in supine position, then it's fine. But you want to operate on this myelomeningocele, or you want to operate on this 𝗵𝗵𝗶𝗃 septum, which is on the downside. So at those moments, what you will do, you will put a tube. If you put this normal tube, then it will, while coming, it will bend. So to prevent bending of the tube, we'll use this armor tube. Okay, we'll use this armor tube. Remember, we will use this armor tube. Okay, fine. This two tubes, which is this ray tube, which is having this south facing and north facing tube, they are known as ray tube. Next, this is known as what? This is known as Goodell survey. So see, during intubation, you intubated, but there will be this tongue, right? When you give anesthesia, the tongue will try to fall back. So to prevent this tongue to fall back, okay, prevent fall back of tongue, will use this Goodell survey, and they will ask you how will you measure. You will measure from tip of this mouth to angle of mandible, to the angle of mandible. So tip of the mouth to the angle of mandible, to the angle of the mandible. This is here. Sorry, this is the tip of the mouth to this angle of mandible. You will measure this Goodell survey. Once you put, this tongue won't fall back. Fine. And next, if you are able to see, this tube, which is known as what? Tracheostomy tube. Tracheostomy tube. See, you got a patient who is being intubated and kept in ICU for a prolonged period. So after some time, this laryngeal cartilages or this trachea, where you put up this in ET tube, it will go for this softening. So to prevent this, what we will do in a prolonged cases, we'll do this intubation. Okay, we'll do this tracheostomy. So initially we'll do with this PVC tracheostomy tube. We'll do with this PVC tracheostomy tube. Yaad rakho. fine. And then we'll move on to this oxygen delivery devices, fine. How? Means if you see, you saw a patient. Now, as I told you, in asthma patient likewise, you saw a patient who is presenting with this features of respiratory difficulty. You put up an oxygen saturation probe and you saw how much is this oxygen saturation. The saturation was like manlo 89. Okay, so you started with what? You started with the first one, which is this nasal cannula. Also nasal cannula. This nasal cannula can deliver up to 0.4, okay, 0.4 of FiO2 or 45% of oxygen, and it can deliver up to 2 to 6 liter of oxygen per minute, fine. Then you tried, you saw, you waited for a few minutes, then the oxygen probe you checked, it is still the same, So as this is still the same, then you plan to move on to the next part, which is this mask. Okay, this is not the simple face mask. It can deliver up to 60% of oxygen and it can deliver up to 6 to 8 liter of oxygen. Okay, when you try this, then you check it is improved, but it is not much. It is from 89, it became 90, but not more than that. So you try to use this next mask, which is known as what? A mask, non-rebreathable mask. The mask along with the reservoir bag. This is the reservoir bag. And because of this reservoir bag, it can deliver up to 90% or even 100% of the oxygen. And it can deliver up to 6 to 10 liter per minute because of the presence of just this one reservoir bag. Fine. And next, you want to deliver just limited amount of oxygen. For example, मुझे इतना % oxygen patients को देना है. Okay. And if you have this only limited %, then you can use this type of mask, which is known as what? This is known as ventry mask. Yeah, good guys. Ventry mask, it can deliver up to 0.6%. And this is the anesthesia mask. Here, see, there is this compression so that there will be no dead space. There will be enough space between. There will be no space between this mask and your skin. So this will be, this air will be filled. Okay, this is what? This is the anesthesia mask. This can also deliver up to 100% oxygen. Yeah, good guys. Good, Dr. Mohammed Anash, Naresh Bishnoi, and Dr. Gautam. Good. Fine. And next, during COVID, this devices has been used very frequently. See, this is known as HFNO system. High flow nasal oxygen. How this is the high flow nasal oxygen? See, in the case of high flow nasal oxygen, it also looks like this cannula, nasal cannula. But this is very high flow one. Okay, very high flow one, and it is inserted till here. Okay, there will be small knobs like this, and we'll keep it inside. So it will reduce us some part of the nasal dead space, and it will produce high amount of oxygen, and there will be always presence of humidifier. This will be having an individual humidifier, whereas this rest of them will just connect to the main line. Okay, if it is central line, or like before that, we'll be having a humidifier for sure, but will connect to that lines, whereas here it will be having its own humidifier. Fine. Yeah, humidifier, it is high flow. Good guys. Fine. Next, about this cannula. If you know about this mnemonic, it is well and good. If not, just learn this. We see, in the case of this cannula, if you see the central one, the red one, or this orange one kya? It is the lava. See, it is about our earth. So central one, it is what? It is this lava. So lava will be in the central. Okay, then it will be surrounded by the soil, which will be grey color soil. Then above that, there will be our grass, like hare grass. So it is means like green grasses, like hare. Then there will be the stem, then followed by this flowers. The flowers are pink in color. So the pink flowers. So lava, soil, then green grass, then stem, which is also green, then the flower, which is pink in color, and it is in a sky, which is what? Which is this blue sky, and above the sky there is a sun, and above the sun there is a galaxy. Okay, galaxy. Okay, remember. So yeah, good. Fine. Yeah, fine. If you know this, then you can just see, like, it is 14, from 14 you can start, and you can remembering in a sequential. So if not, just see the female, they always want to be in their 20s. Okay, and they like flowers. So all of them, like if female 20 gauge, and it is equal to this flower. What? It is this 20 gauge cannula, which is pink in color. So pink in color. So it is a pink color cannula. So if you are able to remember, then remember it is. If not, just remember, you will get green signal for everything. You will set green signal at 18 years. So remember, at 18 gauge it will be a green cannula. 18 gauge it will be a green cannula. So you can go down green, then brown will be there, then there will be a lava will be there. Above if you go, there will be a pink flower will be there, blue sky will be there, then followed by there will be a yellow sun, and there will be a violet galaxy. There will be a, just add one more thing, it is the violet galaxy which will be having the cannula size of 26. Yeah, 26 gauge, which we mostly use in a case of newborns. Newborns में हम 26 gauge use करेंगे. ठीक है, good guys. Fine. This is how you will able to remember about this. Fine. Next we'll move on to this complication of anesthesia. Do you have any doubts, guys? Till now? Fine, good. Yeah, okay, good. Then it's good, fine. Okay, cool, fine. What's the time? It's around 5. Huh? Okay, fine. Yeah, fine. That's it. We'll finish it around 15 to 20 minutes. That's it. Fine. Next, what are the complications of the spinal anesthesia? If you see about these complications of the spinal anesthesia, okay. Usually, when you give the spinal anesthesia, either what you can do, will put them in Trendelenburg position or reverse Trendelenburg position. Okay. So when you put up in a reverse Trendelenburg position, what will happen is that this anesthesia, it will go upstairs. Like either it can go upstairs or downstairs. So if it is go downstairs, there is no any issues. If it is go above the decide level, then what it can happen? What it can happen is that it go and suppress this cardiac system. Yeah, it can go and suppress this cardiac system. It is known as what? High spinal anesthesia. If it is go more further, it is known as total spinal anesthesia. So it will happen at this moment. And there is the next condition. If you see, the most common complication of this spinal anesthesia, okay, it is the hypotension. It is the hypotension. So that's why in a case of while giving spinal anesthesia, we'll give enormous amount of IV fluids. We'll give good number of IV fluids. We'll give them. Okay, and if it is still not dissolved, this hypotension not dissolved, then we'll give phenylephrine more than ephedrine. Phenylephrine will mostly will try to give. Fine. And next, after post surgery or post spinal anesthesia, what is the most common complication? It is what? It is this urinary retention. It is the post-op urinary retention. Fine. Next, if there is post-op shivering is there, then we'll give pethidine. And the next complication, which is this post-dural puncture headache. Previously, we were using this dura separating cutting needle. So because of that, there are more prevalence of this headache. Now we are using this dura separating needles. Because of this, there is no or less chances of this post-punctural or post-dural puncture headache. Fine. And it happen after 12 to 24 hours. Usually we'll tell them to take this caffeine and NSAIDs. It will be resolved. Okay, it will be resolved. If it doesn't resolve, then we'll go for this epidural blood patch. Okay, fine. Next, about this anesthetics agents like inhalational, IV and muscular agents. Fine. If you know about this inhalational, see about this halothane, isoflurane, sevoflurane and desflurane. See, sevoflurane, it is the sweet fluorine. Sweet. So because of the sweet, the children's love more. So it is the induction agent for children. Okay, it is a yeah. Okay, fine. And in halothane, it is lal. It is the lal hai. Okay. So halothane, it is stored in a lal. It is stored in a red color container. Okay, and it requires special containers as well. Okay, it requires special containers known as Tech6 containers to store. Okay. So halothane, it is one of the good one. लेकिन उसको container का storage वजह से we won't use it much often. Okay, remember, fine. But halothane will be associated with this some other conditions. For example, it will sensitize this myocardium. Okay, it will sensitize this myocardium. So it will be avoided in a case of catecholamine producing tumors, like in a case of pheochromocytomas. Okay, pheochromocytomas, and it is contraindicated in the case of neurosurgery, and it can be used in a case of asthma patients because it can produce the best bronchodilation. And this H for halothane causes hepatitis. So halothane causes hepatitis, and it is not used in neurosurgery, and it can cause sensitizing this myocardium. So we cannot use in a case of catecholamine secreting tumors, and it can cause maximum muscle relaxation and maximum bronchodilation. इतना दोनों याद रखना. Then about this isoflurane, it is being widely used in most of the surgeries in a case of cardiac surgeries and in a case of neurosurgeries. Okay, it is second choice for this neurosurgery Okay, but preferred one is desflurane, but desflurane also, I guess because of this reason, we won't use desflurane much often, we use isoflurane, fine. But isoflurane, it is used for this most common for this cardiac surgeries, remember, it is the most commonly used for this cardiac surgeries, this remember, fine. Second choice. Then about the sevoflurane, it is most common used in a case of children's में use करते हैं, and it is used for this asthma patients because it won't cause bronchoconstriction. And desflurane, it is used in a case of daycare surgeries. Okay, daycare surgeries, if it is not used, then isoflurane, fine. If it is not used, it is isoflurane. Then desflurane, it is also most common for this what? It is also most common for this heart surgeries or severe surgeries, but we won't use desflurane much often, we use isoflurane. So isoflurane is used in a case of both daycare surgery and in a case of heart patients. So heart patients and daycare and heart. If it is not used, then it is the desflurane. Okay, then it is the desflurane, remember. Okay, fine. Yeah, then that will come under IV category, fine. So if you see this, yeah, it is used in hypotensive anesthesia to control blood field during surgery. Just you can add one more point, but we'll prefer less during this neurosurgical part in a case of isoflurane. Okay, just remember. Second, it is a second choice. Okay, second choice in a case of neurosurgery, which is isoflurane. Whereas first choice, it is desflurane, and daycare surgery also it is desflurane, and cardiac surgery also we can, if we have, then use but we won't use desflurane because of non-availability. So daycare and cardiac surgery mostly will use isoflurane, whereas for neurosurgery we will mostly prefer to use desflurane. Okay, just remember these 3 points, that will be more than enough. Next, about this sodium thiopentone. Sodium thiopentone, it is what? It is one of the best friend of CNS. So what we can do, we can use in a case of neurosurgery, but this neurosurgery we used to use this sodium thiopentone previously, but now if you see this one, this is being replaced by this ketamine. So ketamine we can use in a case of usmle means we can using as a successors, fine. Whereas previously the sodium thiopentone we use for main neurosurgeries or in a case of any cardiac, means in a case of CNS trauma, fine. And it will be available in amorphous powder. It will be available in amorphous powder. Itna yaad rakhna. Okay. Then this is contraindicated in a case of asthma, acute intermittent porphyria. This is contraindicated in the case of asthma, acute intermittent porphyria, and it can cause accidental injection, means this is intravenous anesthesia. So if there is any accidental injection of this drug into this intraarterial, then what will happen? This can cause painful, or this can cause vasoconstriction, and this can lead to this ischemia over the region. Okay, so we need to safely use this sodium thiopentone. Okay, and next we'll see about the propofol. This propofol, it is the milky white one. It is the milky white. And see, this propofol, it is the drug of choice we'll use for this daycare surgery. Daycare surgery, and we know, this propofol, it is a yellow, means milky white solution, and it will be having this egg allergies, fine. Egg allergy, it will be milky white solution, fine. And propofol, remember, propofol falls BP, so it will decreases BP and decreases heart rate. So it is contraindicated in a case of shock. Contraindicated in a case of shock, and it can be used in a case of acute intermittent porphyria and any daycare surgery, which is the drug of choice, and it can be used in a case of LMA insertion and malignant hyperthermia. So in all of these cases, this propofol can be used. So daycare surgery in a case of gaseous will mostly think of what? Desflurane, but it is less commonly used because of some reasons, because of non-availability. So we'll use isoflurane, fine. Then propofol, it can be used in a case of AIP and LMA insertion daycare surgery, and it is having this anti-emetic properties as well. And we can perform one more surgery, which is known as total IV intravenous anesthesia. Only with IV anesthesia we'll perform surgery. Whereas in usual surgeries, what we'll do, first we'll give induction agent, which is usually this gaseous agents, and followed by this we'll administer IV agents for the maintenance. Whereas with propofol, we can do a surgery which is known as IVRA, intravenous regional anesthesia, where we block this hand and we'll give this drug and we'll do the surgery there. So okay, that is there, fine. And next, if you see about this ketamine, it is this, it increases ICP and it can cause dissociative anesthesia. So this ketamine, like, it is used in a case of asthma, okay, asthma, and in a case of shock. So remember, in a case of asthma and shock, we'll use ketamine. Whereas in a case of any head injury, we'll use propofol, head injury. Okay. So previously the neurosurgery we used sodium thiopentin, now it is being replaced by this propofol. So propofol, you need to remember two words, it is used for this daycare surgeries, IVRAs and head injuries. So in the case of CNS also we'll use propofol. Whereas ketamine will be used for this shock and this smoking, means like in this bronchodilators, like in asthma patients, will use in a case of ketamine. So ketamine will use in a case of, it causes maximum dilation, so we use in the case of asthma patients, and shock, and along with this cyanotic heart disease also we can use this ketamine. Okay, ketamine. And it is contraindicated in the case of epilepsy, glaucoma, schizophrenia and ischemic heart disease. Okay, so but it is used in shock and asthma. Okay, just so. And ethomidate, remember ethomidate is used for this CVS. Okay, ketamine it is used for shock, means that when there is decreased pulse and decreased BP. Whereas ethomidate, if it is in associated cardiac conditions, we'll use ethomidate. Remember, we will use ethomidate. Whereas inhalationally, we'll prefer desflurane. If not, we'll use isoflurane. Fine. Remember. So it is used for this, mainly for this cardiac surgery. It is the most cardiostable. So in few lines I will write. If it is in a case of CNS surgeries, we'll use propofol, more common than sodium thiopentin. Fine. If it is asthma and if it is shock, we'll use ketamine. Okay. If it is any cardiovascular diseases, then we'll use ethomidate. Fine. Whereas if it is a case of CNS asthma, we'll turn serious in a case of daycare surgery and LMA insertion. Okay, daycare surgery, LMA insertion and acute internal porphyria will use propofol. Okay, propofol. Okay, these are the IV agents you should remember and their indication. Okay, if you want to know about this inhalational part, you just see. You see this halothane, it is used for asthma patient. Asthma, will try halothane. Fine. Whereas in a case of isoflurane, in a case of heart and daycare, we can prefer isoflurane more than desflurane. Okay, desflurane. Then heart and daycare. Okay, daycare surgery. Heart and daycare will use isoflurane more than desflurane. Then in a case of, if you see about this next one, which is sevoflurane, in the case of children, we use the sevoflurane. Okay, sevoflurane. And halothane causes hepatitis. Okay, hepatitis. And for any cardiac, iso more than desflurane. Fine. And in the case of CNS, we will prefer using this isoflurane as well. Fine. Okay, or we can use in CNS, we can use more than desflurane. So mostly it is around the same for CNS as well, but CNS will prefer more of desflurane. Okay, so but this faculty is having this confusion still now, but for heart and daycare surgery, it is isoflurane more than desflurane nowadays because of the availability. Okay, itna yaad rakho. The best is desflurane, but most commonly we'll use isoflurane. Okay. Fine. Next about this local anesthetics. If you see about this local anesthetics, like amino esters will be having one eye, amino amides will be having two eye. For example, procaine, cocaine, chlorprocaine and benzocaine. Okay, it is lignocaine and lidocaine. Okay, lidocaine. Both of them will be having two eye. Okay, bupivacaine, lidocaine, prilocaine and dibucaine. So all of them there is amino amides. Fine. And we'll see about few side effects. If you see about this benzocaine will be associated with this methemoglobinemia. It will be associated with this methemoglobinemia. Lignocaine, it can lead to the toxicity, and we know lignocaine can be used in a case of MI induced arrhythmias. Okay, in a case of MI induced arrhythmias, we can use lignocaine. Whereas this lignocaine toxicity can lead to this perioral numbness. It can lead to this perioral numbness, and there will be features of tremors and seizures as well. Fine, and it is contraindicated in a case of like hypertension, coronary artery disease. But lignocaine will mostly use for this infiltratory anesthesia. For any superficial procedures, infiltratory anesthesia will use lignocaine. Fine, and this lignocaine toxicity can lead to this perioral numbness. Itna yaad rakho. Fine. Next about bupivacaine. It is the most cardiotoxic drugs. So with this bupivacaine can be used in a case of spinal anesthesia, but instead of spinal anesthesia, if you give in this intravascular access, it will be very toxic in nature. In such conditions, you need to give 20% intralipids to neutralize it. 20% intraliquid solution. Fine, remember. Okay, then there is one more test which is known as 𝗍𝗵𝗀, which we use for this cholinesterase level by testing a test which is known as 𝗵𝗵𝗀𝗀𝗀 number test. 𝗵𝗵𝗀𝗀𝗀 number test. They are 𝗍𝗵𝗀𝗀 number test. It is known as 𝗍𝗵𝗀𝗀 number test. Remember, and we have this cream which is asked in neetpg 2024. neetpg 24. It is known as 𝗵𝗲 cream. 𝗵𝗲 cream, it is the 𝗬𝗏 mixture of LA. Okay, lignocaine and prilocaine. It is the 𝗬𝗏 mixture of lignocaine and prilocaine. Okay, which is around 2.5 for means both, like it will be having this 2.5% of this lignocaine and 2.5% of the procaine, and this is contraindicated in the case of newborns because it causes methemoglobinemia. It causes methemoglobinemia. So it is the ligno plus prilo, which is this equal mixture or 𝗬𝗏 mixture, which is 2.5%. Fine. And next I told you it is IVRA. Okay, intravenous regional anesthesia. Okay, there is known as TIVA, which is total intravenous anesthesia, which is be used by this propofol. Whereas IVRA, it is regional. For example, you applied a tourniquet and you want to just use this region, so it is IVRA. So in such cases, you need to apply tourniquet here, and this tourniquet in the case of upper limb, it should be more than 50 millimeter of HG plus systolic. So 50 plus systolic in the case of upper limb and 100 plus systolic in the case of lower limb. Okay, and most common used drug is 0.5% lignocaine, whereas 𝗵𝗵𝗀𝗀𝗀 is contraindicated in this case because it is a cardiotoxic one. Okay, cardiotoxic one, and it's also contraindicated in the case of sickle cell anemia or any vascular diseases like Raynaud's disease and peripheral vascular disease. Okay, itna yaad rakho. Fine. And about this muscular just relaxant, just remember this muscular relaxant, there will be depolarizing and non-depolarizing, and polarizing muscle relaxant, it will act with this competitive antagonism. And if you see, you need to know just this D-tuberculin, atracurium and 𝗏𝗏𝗏𝗏𝗏𝗏𝗏. Okay, atracurium and 𝗏𝗏𝗏𝗏𝗏𝗏𝗏, both of them, they will be metabolized by this Hoffman degradation. So if there is any kidney damage itself, or if there is any liver damage itself, we can give this drug, it will come out of it. Okay, itna yaad rakho. Fine. And whereas this vicuranium, it will be more cardiostable. The cardiostable one, it is the vicuranium. Okay, whereas the succinylcholine, it is the fastest acting and the shortest acting depolarizing one. Whereas in the case they are asking non-depolarizing, the shortest one is the 𝗵𝗵𝗀𝗀𝗏. Whereas this depolarizing one, it is what it is, the succinylcholine, it is the depolarizing muscle relaxant. Fine. And it can lead to this apnea, which is known as choline apnea, which is if there is deficient of the pseudocholinesterase enzyme, this can lead to this succinylcholine or choline apnea. So to test this amount of this pseudocholinesterase, then we'll use this number test, which is known as 𝗍𝗵𝗀𝗀𝗏 number test, which we studied before, right? That is one. Fine. Next, one of the complication of this succinylcholine and most of this IVR means this inhalational agents, it is what it is, this malignant hyperthermia. This malignant hyperthermia, it is mainly triggered by this succinylcholine inhalational agents like halothane, isoflurane, desflurane, and ether and lignocaines. Fine. So mostly this will be having this continuous contractions in the muscles. So leading to this, there will be increased hypertension. Like this, yeah, most of the all inhalational will cause this malignant hyperthermia. So this will cause increase in temperature. To treat this, we'll use this dantrolene sodium. With the use of dantrolene sodium, we'll treat this malignant hyperthermia. Yaad rakho. And if you see, they asked about this layers of piercing. If you see, first we'll go through skin, then subcutaneous tissue, then see these three ligaments: supraspinatus, then interspinatus, followed by this ligamentum flavum, and it will reach this epidural space. Okay, and finally this dura mater and arachnoid mater. If it is, we are giving this as a arachnoid. Yeah, there is this supraspinous ligament, interspinous ligament, and ligamentum flavum, interspinous ligament. Okay, so remember the sequence. So if we are giving this epidural anesthesia, we'll stop here. But if you want to give this spinal anesthesia, we'll go till here. Okay, spinal anesthesia. Okay, so see. So if you see this spinal taper anesthesia, we'll go into the subarachnoid space. But if you want to, around the same for this epidural, means same for this lumbar puncture. Whereas for epidural, we'll just go till the ligaments and we'll stop before the dura. This is the dura, and before the dura, we'll stop and we'll administer the drug in the epidural space. Okay, in the epidural space. Itna yaad rakho. Fine. Yeah. And finally, the CPR, if you see about the CPR, the correct ratio for adults, it is 30:2, where means with 1 or 2 rescuers, like who or how many is there is no matter, but in adults it is 30:2. If it is pediatric case in children's, that is 30:2 if it is 1 people, if it is 15:2 if it is 2 rescuers are there. And unit, we always need 1 to hold and 1 to, because it is encircling techniques, right? So you will keep both hands here, then who will ventilate? So it will be usually 2 will be present and 1 will be ventilating. So see, so in such cases, it will be infants, it will be 2 people already present, so the ratio will be what? It will be always remain 3:1. 3 compressions and 1 breath. 3 compression and 1 breath. Okay? Next, what are the sequence? First you will check for the seal safety, then you will call for the help, and you will check for the response. Then you will check pulse, then breathing. Okay? Then first you will ensure like whether is there any obstruction or something is there, then you will remove it. Okay? If breathing and pulse present, then what you will do? Then you will put him in the recovery position. If breathing but pulse absent, then what you will do? You will give, no, if breathing is absent but pulse is present, then what you will do? You will give this rescuing breaths and monitor the pulse. Okay, if no breathing, no pulse, then you need to start this CPR, which is at the rate of 30:2 in adults. Okay, 30:2 in adults. In pediatric cases, if it is 1 rescuer, it is 30:2. If it is 2 rescuer, it is 50:2. 15:2. Fine. And one of the modality they will ask you, what is the name? How you will do in a case of CPCR. One, you can give this chin lift. You can use your finger and you need to lift the chin so that you can open the airway. Or else, if there is any huge injury, then you can provide thrust to this area, which is known as jaw thrust. Okay. The final slide, it is the Mapleson circuit. So remember, see Mapleson B and C. Remember BC, it is Gali in Hindi. Means like it is a bad word. So we won't use this BC. So we'll use Mapleson A, D, E and F. So what is the difference between Mapleson A and D is that this first graph flow, it is near to the patient in D, whereas Mapleson A, the first graph flow, it is distant to the patient. Okay, that's it. That is the only reason. Then Mapleson E, it is without balloon, and Mapleson F, it is on the way of E with a balloon. That's it. That's it. Okay, that's, if you know this they will able to crack, like which, if they ask you which type, you can able to answer it. Fine. Then Mapleson A, it is also known as Magel circuit. It is used for this spontaneous ventilation. It is used for the spontaneous ventilation in adults. Okay, whereas Mapleson D, it is also known as Bain circuit, which is used for this controlled ventilation in adults. Fine. Whereas Mapleson E, it is also known as ISTPs, which is a bagless, means without any bag and without any valve. So it is used it is also used in a case of pediatric patients. Fine. Whereas Mapleson EF, it is also known as Jackson-Reeves modification. It is used for this pediatric patients for the spontaneous and controlled ventilations. Fine. So these are the Mapleson circuits, and these are the images and most important things you should remember from this anesthesia perspective. Fine. Remember one thing, like the final call is that you can do it, because you meant for it and you came for it and you are for it, so you can do it. So have this hope till your examinations, and you will come out with flying colors, and I'll be praying for you. Don't worry, just keep your hope alive and keep your things going on. Okay, there will be many arts will be happening currently, but once you pass the examination, everything will be fine. Fine. It is really very overwhelming that I took this 5-day session, and it was really like I enjoyed it the most, whether you enjoyed it or not, but I hope you also enjoyed the same, and you can use this as a revision material during your final point, and before giving your GTs, make sure you are reading these notes so that you will get the maximum output of it. Okay, maximum output of it. So if any, please ping me or reach me out, and I'm really thankful to this Dr. 𝗵𝗶𝗀 channel so for giving this opportunity to express it. I'm really thankful. If you have any suggestions or things, please put up in the comments section. We'll be taking care of. Okay. Thank you Tarun, thank you Quainan, yeah, thank you Mohammed Anas, yeah, thank you Nidat, thank you Anat, thank you Naresh and Parul, yeah, Shivangi Rai, thank you Kainin, thank you Teja, thank you Naresha. Everyone guys, thank you very much. Yeah, thank you Gautam. I'm really lucky to have you all, and thank you. And final way it is you can do it, and I just want you guys to be come out of this flying colors and clear with really good marks. You have this patience, you have this consistency, because I have seen you guys for this last 5 days. You are consistent with your efforts and consistent in all scenarios. Be consistent for few more days, and you will come with flying colors. And if any, please reach me out in my Instagram. You can text me out, like you can text me at @SasiDancy. You can text me out if any issues or things are there. And once you pass, please let me know. And please let me know, like once you are right within, once you complete your examination, please let me know how about the questions, how many questions has come up with it, so that we'll be conducting these sessions for this future generations with more immensely. Okay. Thank you guys. If any, please let me know. Yeah, thank you. And thank you for being interactive, guys. I really enjoyed it. Thank you. If any, please let me know. Fine. Yeah, thank you. Yeah, Bim, don't worry. I will share you the unnoted PDF. Okay. It's in, means actually it's not in my iPad. It is in studio's iPad. They will share you for sure. Don't worry. Okay. I'll tell them to share. Don't worry. Don't worry about the PDF. I'll share you. Okay. Cool. Okay. Study well. We'll see you on the other side as a registered doctor, and I'll be happy to see you more than anyone else in the world. Thank you, guys. Bye bye.